Your time is over. You already gave your presentation, right? Yes. You want an extra deep purpose sticker?
I love the teacher. Amazing. That is so.
Quindi ragazzi, abbiamo mandato YouTube. Come stai invece con le presentazioni di mattina? No, magari bello. Sta arrivando Sentite una cosa, vi devo dare una presentazione PowerPoint che mi ha mandato ieri sera una paziente, te la do però me la devi trasformare sulle basi dello scuole, me la devi trasformare in video, cioè devi fare export video perché lei l'ha registrata dentro, ma tutte le cose a
Quella era
quella era lei sta messo un po' nude, ma non so, sono malaccia, hai capito? Togli che le porta nude, no, non lo so perché è tutta la mia vita, ma che devo fare? La mettiamo o la mettiamo su?
Good morning. Thank you for joining us early. And we start the last session of the International Breast Surgery Workshop. And this is a special session organized by EURAPS, which is the European Association of Plastic Surgeons. And I have a privilege of being the president this year. I was Secretary General for 7 years ahead. And together with me will be the moderators, Dolores Wolfram and Marco Mazzocchi. So we will start this session. Please, Dolores.
So, please, Professor Clemens, just give a great talk. Phoenix Rising, interesting. So we're looking forward.
Thank you. We've spent so much time talking about the optimal way to reconstruct people. Over this next talk, I'm going to challenge you with one question. What does it take to truly restore a breast cancer patient? For the following financial disclosures, I wrote this book this past year. All proceeds from the book go to fund breast cancer research and breast reconstruction, and to date, it's supported research at Stand Up to Cancer, ASCO Foundation, Plastic Surgery Foundation, and MD Anderson. MD Anderson participates in FDA clinical trials with Allergan, Mentor, and Establishment Labs, but I perform no consulting for any company. I'm going to start with an idea, and the beginning of this phrase was said multiple times yesterday, which is that beauty is in the eye of the beholder. I would challenge that, and I would say, although beauty may be in the eye of the beholder, the feeling of being beautiful exists solely in the mind of the beheld. It's not us to decide looking at a woman, it's for her to feel that she is beautiful. And how do we accomplish that? Meet one of my patients, Jewel Johnson. 5 years ago, she was diagnosed with breast cancer, triple negative breast cancer that had metastasized to her lymph nodes. And she was overwhelmed. She did not deal with this very well. She required radiation therapy, surgery, chemotherapy. She developed neutropenia. She had massive weight loss. She had neuropathy. And she credited that a large part of the success being able to get through this was actually integrative medicine. That is treating a patient from a holistic perspective, treating their mind and body. So giving them nutrition support, physical therapy, counseling, psychological counseling, all of these coming together to help her through this journey. So often, if you ask a hand surgeon, what's more important, the actual surgery or the intense physical therapy afterwards, many times they'll say that the most exquisitely, technically, perfectly performed surgery can completely become mute without the importance of the follow-through with the physical therapy afterwards. And I would contend that breast cancer is the same way. So we're going to cover approaches to the breast reconstruction patient, our institutional protocol, and our outcomes. And first, I just want to give you a definition of what is integrative medicine. It's combining mind and body, integrating nutritional support, physical therapy, stress management, and its aim is not only to reconstruct the physical form, but to truly restore overall well-being and the quality of life. There's very good data for this, but not in the plastic surgery literature. If we look, patients who receive nutritional support pre and post-surgery can actually show up to 66% decreased in postoperative surgical complications. Studies indicate that early physical therapy intervention, usually performed within 24 hours, can reduce postoperative pulmonary complications, particularly in large free flap reconstructions. I want to introduce some key concepts, which is the idea of actually doing this before surgery, so prehabilitation. Consider the idea of doing core exercises a month before actually performing a DIEP flap. In essence, to make that surgery and the recovery a lot easier. There's definitely good literature across orthopedic literature of the benefit of this. Improved function, increased strength, and enhanced quality of life. Now, while it's not in our literature, it's extensive in the oncology literature. So there's actually integrative therapy guidelines for breast cancer in the Journal of Clinical Oncology. And I draw your attention to the very last line, which is actually on lymphedema. They actually have formalized oncology guidelines from JCO specifically on laser therapy, manual lymphatic drainage, and compressive bandaging for improved lymphedema. And what I was struck by going through this was that they graded all of the evidence and how high integrative medicine is supported in the literature with prospective randomized controlled trials. At MD Anderson, we have a number of different services that we offer patients, from integrative consultation for all breast cancer patients, acupuncture, physical therapy consultations, health psychology, meditation, music therapy, nutrition consultation, and oncologic massage. And I'll point out, MD Anderson was actually the very first institution in the United States to actually have a department of integrative medicine, for which we've been doing this for over 20 years. This very complex slide breaks down every single one of those areas and all of the services that are offered. And I'll just point out some of them, from behavioral interventions like cognitive behavioral therapy, managing chronic pain, post-surgical depression, to alternative therapies as well. Also, what I think is key is addressing post-mastectomy pain syndrome. We find that that occurs in about 1 in 3 patients at 10 years after mastectomy. And so often as plastic surgeons, we really kind of feel helpless to address this because it usually is intrinsic scar tissue to the chest wall that's kind of independent of our reconstruction. And yet we've worked with our occupational therapists to create a regimen using non-narcotic neuromodulators like gabapentin and Lyrica, topical analgesics like lidocaine patches, and targeted botulinum toxin injections to the latissimus and the serratus. And it massively reduces, you break the cycle of pain for these patients. I just want to give you an example of a standard protocol that we have for our plastic surgery reconstructive patients that involves initial assessment and planning, nutritional counseling, prehabilitation, psychological support, and then after the surgery, intensive prehabilitation and education, just to make sure that they're completely optimized in anticipation of a surgery. This just demonstrates one protocol. Again, very busy, but there's a lot that we offer for these patients, from nutritional support, therapeutic support, postoperative assessment, physical therapy, and continuing to go through to make sure that they're completely optimized as best as they could for the healing process. I want to give you an example of a deep flap reconstruction patient who comes to us requiring an elective deep flap. She has an initial BMI of 43, and because it's elective, we have time to be able to use our integrated medicine services. We do an intensive 3-month pre-surgery program, doing nutritional support, exercises, core strengthening, particularly to the abdomen. And you can see the outcomes is that we reduce her BMI to 35. We actually accelerate her recovery. This is fast in my hospital, a discharge on post-op day number 2. And importantly, her glycemic control significantly improves from 8.9 to 7.2. She notices improved physical health, weight reduction, and enhanced metabolic control, and particularly psychological resilience to be able to handle that surgery and the stress associated with it. This is another example of a latissimus flap requiring prophylactic lymphovenous bypass at the time of surgery. We do, this time it's all after the surgery. We perform an intense integrative care for 3 months after the surgery. We actually see, in combination with her surgery, she has a 20% reduction in her limb circumference. Her pain tolerance is very good. She requires no narcotic support. She, on a generalized anxiety disorder, plummets her score from a 14 to a 6. And she has very good shoulder range of motion, actually improved from pre-op by about 40%. Don't just believe those anecdotal stories. We did a prospective randomized controlled trial of our plastic surgery cases at MD Anderson. And we did it in 47 patients with multiple different time points. pre-intervention, treatment, 3, 6 months, and 1 year. And I think what was important is that we pitched this to the IRB. They said, we want to do this study. And they said, no. They said, you can't withhold standard of care, which is nutritional support and rehabilitation, which are key aspects of our integrative medicine. They considered that such the standard of care that we couldn't randomize patients against that. So integrative medicine in this prospective randomized controlled trial was only psychological supportive services, a small part of integrative medicine, but just kind of speaks to how much they thought that this was just the standard of care that you had to do for patients, nutritional support and rehabilitation. And just with that intervention, psychological support, we can see that there was a statistically significant improvement in quality of life, self-perception, and well-being over controls. The effect was greatest at 3 months, but it persisted up to 12 months. And that was statistically significant. And when we broke it down by cohort, oncoplastic, alloplastic, and autologous, we actually saw that there is a statistical difference between those 3 cohorts, and alloplastic breast implant patients most benefited from integrative medicine. And this was by an SF36 evaluation. I'm frequently asked, yeah, but who pays for this? Well, in the United States, shockingly, insurance most commonly does, particularly integrative medicine initial consult, as well as nutritional health and psychology. For the other things like massage, Reiki, herbal supplements, usually not covered, but our institution gives those away. They usually make classes where they can handle 30 or 40 patients simultaneously to be able to give those things to them. For further reading, I would turn you to these journals, websites, books on the subject, as well as I want to end with that being diagnosed with a life-threatening disease, it causes unwanted distress and interferes with quality of life. And these therapies directly address that to help us to have our reconstructions as successful as possible. They assist patients with building social and emotional support, managing stress. And I would offer to you that plastic surgery patients would benefit from formalized society recommendations in our societies like we see in others. I'm going to end on a quote. The journey of the phoenix is one of surrender and rebirth, teaching us to let go of what no longer serves us and embrace the transformation that awaits. That's the last sentence of the first chapter of my book. If anybody would like to buy it, it supports breast cancer research. For any medical students, trainees, fellows that are in the audience, I've actually brought over a dozen copies to give you for free. So if anybody would like to come up, you're more than welcome to have a book. Thank you.
Questions from the audience first.
Thank you for your talk. This talk brings the attention on our role to dedicate to every patient a different treatment, probably. So what is missing in our role, probably, is the person who is able to manage the whole of the patient needs. Right. So thank you. We have several possibilities. We have to treat the patient, not enough to treat the disease. In this way, we will be able to give a better quality of life to the cancer patient, like every other one.
Yeah, I will acknowledge that this would be way too much work for us to surgeons to actually organize ourselves. But many times these services are available in your hospital and they just need to be brought together in one formalized plan. For instance, if you just standardize the protocol, you can send them to these services usually already existing in your hospital. It's just about putting it together.
So if there are no further questions, I think we move on with our next talk. The next speaker, warmly welcome. Now we're talking about challenging asymmetries in breast augmentation.
Thank you. Good
Our
morning.
president-elect of EURAPS.
Thank you. Dear Chair, dear colleagues, good morning. I would also like to thank the organizers, Fabio Santanelli and Mark Clemens, for the invitation. It's an honor for me to be here, and also for organizing this Europe session within the conference program. So I will talk on how to correct challenging asymmetries by breast augmentation. I have no disclosures. It is well accepted that difference more than one size between breasts is considered to produce a severe breast asymmetry. But are all severe breast asymmetries challenging cases? Not really. I think that a challenging case is that is quite difficult to correct surgically. It needs, by definition, asymmetrical treatment, and also it is difficult to achieve satisfying long-lasting results. If we go through the literature on breast asymmetry, it's easy to realize that there is a lack of consensus in the classification of breast asymmetry, the management, and even evaluating and reporting outcomes. So most authors and papers are using classifications that are based on descriptive terms, including unilateral or bilateral asymmetrical hypoplasia, unilateral or bilateral asymmetrical hyperplasia. It doesn't work very, I don't know why. Okay. Hypoplasia on one side, and then hyperplasia on the other side, or asymmetries with chest wall deformities. Most of those cases are syndromic. So it's easy to understand that the most challenging cases are those with hypoplasia and hyperplasia on the contralateral side. So when approaching those cases, it's a little bit difficult to speak. It doesn't work. Okay. When approaching those cases, we should always analyze all the breast features and the differences between the two breasts. So it's not only the volume that is different, it's the differences and the discrepancies include all the other features like the ptosis. Okay, the ptosis, the IMF level, the footprint discrepancies, the neck size, and any constriction deformities, unilateral or bilateral, that may be present. So it's by definition, when we want to expand, to enlarge the hypoplastic part, we need to use augmentation. Most frequently with implants, it's very difficult only with fat to correct those cases. Of course, they need asymmetrical approach, tailored to each side, evaluating each case. And of course, we need to discuss with the patient what are her wishes, her expectations, and her awareness also. So there are many questions that arise on correcting those challenging cases. First of all, how to select the right implants preoperatively. So in our hands, the use of external prosthesis is very helpful, and we usually use it to determine and assess the desired augmentation preoperatively in each case. Like this one, of course, it seems quite old-fashioned compared to all the 3D laser estimations. However, it is very useful to try those external prostheses with a bra beforehand in order to assess the desired augmentation. Intraoperatively, I think that gel-filled sizers are mandatory to use, no matter what is the brand of the implants that we will use, Mentor or Motiva or Nager or whatever. We need to ask the distributor to provide us gel-filled sizers, and comparing to the expandable ones are much more helpful because it's not only the volume that we want to assess, it's also the base, the projection. So we need to have sizers identical to the permanent implants that will be used. So in my practice, I always start with a small breast. I use pre-filled sizers to reach the desired augmentation, and then I continue with the reduction of the contralateral side or augmentation mastopexy or what is needed to adjust any discrepancies. And as for the augmentation, I follow the standard technique that I'm using for any augmentation in terms of the type of the implant, the pocket, etc. I usually put the insert the implant in a subglandular or dual plane pocket. In those cases, whether we go for a unilateral, bilateral augmentation, like Stephen McCulley presented yesterday, with symmetrical or asymmetrical implants in our hands, bilateral augmentation with symmetrical implants following a unilateral reduction, it is not performed systematically. We, not only in very selective cases, in less severe asymmetries, like in this case, for example, where we did a small reduction on one side and then we continued with identical implants to get this symmetrical result. Otherwise, in those cases with very severely constricted unilateral hypoplasia, would you go for an implant expander or permanent expander? I would first start with an implant, and in case that I cannot reach the desired augmentation, then I would prefer to use an expander. After all, expandable implants are reported to have significant more complications. So I would go for a two-stage reconstruction with an expander with a remote valve, because we need to remember that when the valve is incorporated, it's very difficult to locate it with a magnet below the parenchyma. So, of course, what are the patient's wishes? We need to talk with the patient to set realistic goals. The more severe the symmetry is, the more difficult to have long-lasting results. We recommend to operate on both sides, if the patient agrees, of course, with similar techniques, if possible, in order to get long-lasting results. But yet it's difficult by definition in those cases. We need to treat them differently, and thus we expect that the breast will react differently with time, with aging, pregnancies, etc. So this is a table taken from a very recent systematic review, where we can see that all combinations of surgical approaches and treatment can be used, and especially for challenging cases, unilateral techniques are performed in each breast. So let's go through some clinical cases. The first one is not a very severe asymmetry, but yet if we analyze the features, we can see that there is a discrepancy in the volume, the ptosis, IMF, and NAC. So a different approach was used, augmentation on one side and augmentation mastopexy on the other side. And already at almost 3 years, the results still remain stable and quite symmetrical. Another more severe case with a more obvious discrepancy on the volume, IMF, footprint, and NAC also, and also some constriction, was also approached differently in each side with asymmetrical techniques, an augmentation on the right side and only a mastopexy on the left side. And this is the result at almost 2 years. It is quite symmetrical, but still it's quite early to assess it. Another much more difficult case with a big reduction required to reduce the hypertrophic right breast, and on the other side we did an augmentation directly with an implant, not an expander. This is the immediate result, which is quite acceptable. And here is the patient at 13 years, which the breasts are not quite similar. There is a different appearance, but still the volume is quite acceptable. And the patient, although we suggested some corrections, the patient was very happy. The clothes fit very well with the bra. No asymmetry is seen, so she didn't want to undergo another surgery, especially given the situation where we started from. Another quite difficult case with tuberous breast, asymmetrical tuberous breast, and asymmetrical treatment was required. Like we can see here, an augmentation, mastopexy both sides, but in different ways, a wise pattern mastopexy on the left side. This is the immediate result, where we can say that it is a perfect symmetry in terms of volume, NAC, IMF, footprint, etc. However, down the line, after 5 years, we realized that, of course, as expected, the breasts altered in a different way. And we can see it's not only the volume is quite similar, but it is the position of the NAC which change and gives this appearance. What about using only the fat? In cases like this, where we have a chest wall deformity, we might use only fat. This is the wishes also of the patient, in order to also to fill the upper part, not only to augment the small breast. And this is the result. Okay. What about unilateral? Okay. What about the unilateral approach? Although we suggest our patients to operate on both breasts, sometimes the patients, they don't accept it. Like in this case, this was a developmental hypoplasia after a surgery that was done immediately after birth. It was this patient had esophageal atresia, so she was operated when immediately after she was born. And the patient and her parents didn't want us to touch the left breast. So we did almost a reconstructive procedure using a very small texture implant at that time with an ADM, because we use the same scar. And here is the result at 1 year. And this is, okay, can we go back? And this is the result 14 years after, which is very symmetrical and very pleasant to the patient. She didn't want to touch anything. So although we cannot use an algorithm to correct those cases, yet it is a bunch of heterogeneous conditions with variable manifestations, but we can still follow some steps in order to analyze each case individually, plan the approach which should be tailored for each patient, considering all the different features, of course, and discuss with the patients the limitations of surgery. We can have some satisfying results if we go for an accurate measurement, a very careful technique, and pre-opening or intraoperative assessment. But still, revisions should always be considered for the future. And as Mark Clemens presented previously brilliantly, our goal is not only to provide the most symmetrical breast appearance, but mainly to have the most satisfied patient. So before can you go back, please? Before the end, I would like to remind you the upcoming EURAPS annual meeting, which will be held in Athens. Save the dates, 30th of May till the 1st of June. We will be very happy to welcome you all in Greece. Thank you very much.
Thank you for a nice presentation and fantastic results. Of course, my comment is first that the most difficult cases are not this, which you present, but the patient who has a asymmetry 2 millimeters, 1 millimeter, and it is they are the most difficult patients in our practice. But first remark, the breast asymmetry is connected to chest asymmetry. Last year, I published the article in PRS with the classification of chest asymmetry. And when we try to correct, we have to take this to asymmetries. And we did a study of the breast asymmetries as well on the 1,000 cohort of patients using the Vectra and Canfield system. And the conclusion was that in 95% we have an asymmetry of the chest, and in 95% the asymmetry of the breast. So it is important conclusions which we always gave the patient. We explained them that asymmetry in the nature is normal, not the symmetry. So this is the first point. And of course, this kind of cases which we present are probably challenging, but the most pleasant for us, like a surgeon, to correct it, to find a solution, to discuss, to design it. So congratulations, very nice results, and I think very satisfactory for you as well.
Yes, thank you. Thank you for your comments. It's true that the first thing that we always need to consider is to discuss with patient and explain what we can, what kind of symmetry we can reach. And of course, there are many times we haven't investigated whether in all these cases there are chest asymmetries, but there are. I presented some cases, and yes, there should be. And in those cases, if we don't address the asymmetry of the chest wall, it's very difficult to have a nice symmetrical result. But still, so what is very important is the preoperative preparation and assessment, and then explain to the patient what she can expect from the surgery.
Thank you. So I think we have
Next
to
next presentation, capsular contracture. Capsular contracture still a challenging benign problem for surgeons and patients. Odarto.
Good morning. It's a really great pleasure to be back in Rome. I don't have any disclosures to make apart from the fact I love this city. I have been coming here almost on an annual basis since 1976 when I was 12 years old. And I was discussing with Mark before the session that every time you come to Rome, you discover something new and different that you did not know about this city. It's a little bit like this conference. We're discovering something new and exciting every time I come to this conference. It's amazing. However, I've been asked to talk to you about capsular contracture, benign capsular contracture, and there's probably not an awful lot new I'm going to tell you, but I hope what it will do is set the scene a little bit for some of the controversies that we're going to talk about later on today in malignant transformation of the capsule, which is really what we want to be talking about later on today. So I hope to cover these few short topics in this talk this morning. So in terms of characteristics, we know that breast augmentation is probably the commonest cosmetic surgical procedure that we perform as plastic surgeons. And when we do breast reconstruction worldwide, implants are still the commonest way, despite all of the wonderful things we talked about yesterday in terms of deep flaps and gap flaps and tug flaps, but they are still the commonest way that we reconstruct a breast. And capsular contracture is still the commonest problem we deal with. And it has a very significant economic impact, both on the patient and on healthcare communities. And the rates vary depending on what you read in the literature, probably slightly lower with breast augmentation patients than with breast reconstruction patients. And there's very obvious reasons for that. But we know that the rates increase over time. And unfortunately, the etiology is still not fully understood. It is thought to be an entirely benign process, but is it? And this is one of the things we need to discuss later on today, does it sit on a spectrum of disease, where at the very extreme end, we do see malignant transformation. And those of us who treat breast implant-associated anaplastic large cell lymphoma patients do see a small percentage of our patients presenting with a capsular contracture. It does seem to me, in those patients I have looked after, that those patients presenting with capsular contracture tend to be slightly different from the benign patients insofar as the capsular contracture tends to be quite aggressive and progressive and presents very early. But this is something we can talk about later. Normal capsule histology, we talk about the 3 layers, and the innermost layer against the implant is the cellular layer. We sometimes call it a pseudoepithelial layer. Some people call it a metaplastic synovial layer, depending on which histological paper you want to read and what interpretation you want to make. Contains lots of different cell types, including fibroblasts, myofibroblasts, monocytes, histiocytes, and so on. And the middle layer is the one of the vascularized layer, and this enables us to use, as we saw yesterday, a capsule as a capsular flap. And it's a very useful tool in reconstructive surgery or in correcting problems with cosmetic patients. And on the outside layer, you've got your dense collagen layer. This is what a normal capsule looks like. But what happens when it becomes deranged and the contracture starts to happen? And we just see a change in the histological appearance, and we get a more intense chronic inflammatory response. Why this happens and what switches it on, we don't really understand. But we get fibroblastic deposition with more collagen formation and chronic inflammation. And then the myofibroblasts start to contract to produce this capsular contracture that we all witness very regularly in our clinics. So what are the risk factors? There are endogenous risk factors, and then there are exogenous risk factors. One of the really important risk factors, and we know about this, is the elastomer shell of the implant. And one of the very first randomized controlled trials in plastic surgery was done in the UK by David Sharp and David Coleman, comparing and looking at prospectively at textured versus smooth implants. And they showed very conclusively in that trial that textured implants had a much lower rate of capsular contracture than smooth implants. And that data was re-looked at many years later by Charles Malata and concurred with that conclusion. However, that effect is lost when you go into a dual plane or a submuscular plane, and we know that now. But we also know that there are other things that affect capsular contracture rate, such as radiotherapy or surgical technique, whether the patient has had previous capsular contractures, whether the patient develops a hematoma at the time of surgery, and so on. So all of these things will influence capsular contractures. In addition, we have the whole issue about subclinical infection, and with very, very good microbiological techniques, you can extract organisms, even in patients in whom you do not think have had any infections postoperatively. And this has led to the whole theory of biofilms and the effect that biofilms have on capsular contracture rates. And then you add into this the whole issue of autoimmune disease in Asia and where that sits in relation to capsular contracture. So basically, it's a multifactorial problem. When we talk about classification of capsular contractures, there are a number of different types, like histological. There's the quantitative type where we can do tonometry, but clinically is the classification that we tend to use as clinicians. And the most common one is the Baker classification, and Scott Spear's modification of that for reconstructive patients. And we saw that yesterday with Peter Cordeiro's talk on his wonderful series of implant reconstructions. Other classifications systems have come and gone, but essentially it's the Baker classification is what we still use. One of the problems here is that some people keep talking about capsular contracture in grade 1 and 2 patients. What I keep telling my trainees is grade 1 and 2 is normal. It's not a capsular contracture. It's really important to understand this. It's non-pathological. The pathological part of the grading system is 3 and 4. And what's the difference? Basically pain. Grade 3 patients have a distortion, but no pain. And not all of these patients need surgery. That's a very nuanced discussion you have to have with your patient. And not all of them will necessarily progress to a grade 4. Grade 4 patients, almost 100% of these patients will end up having surgery because it is rock hard and very painful. So what are the preventative strategies? There are a very, very long list of preventative strategies, and not any single one of these is necessarily going to make a difference. And this is why dealing with the multifactorial element of the causation means that preventative strategies become a little bit difficult. And yes, there have been some things that have been done that have helped to reduce our capsular contracture rates. We've had Bill Adams' triple antibiotic irrigation. We've had lots of discussion from John Tebbets about good surgical technique. My good friend and colleague in Newcastle, Nick Collis, published on using nipple shields. And then we've had other drugs that are used to try and dampen down inflammatory responses. We had Scuderi's paper in 2006 on leukotriene receptor antagonists, which are used in treating asthma patients. And these can be used either in treating capsular contracture or in preventing recurrence in patients who've had capsulectomies. Cyclosporin, perfenadone, which is a TGF-1 beta antagonist, may be helpful. But actually, they have never really progressed into the mainstream of managing the problem of capsular contracture. ADMs are useful in patients having reconstructive surgery. We don't really need to use them and don't use them that often in augmentation surgery. One of the big changes that I think that is happening because of the class 1 recall in biocell textured implants is the development of newer technologies in implant shells, which I think is something that will come forward more in the future in terms of trying to reduce our capsular contracture rates. So what are the options? Well, one option is simply remove the implant. Now, do you have to do a capsulectomy on these patients or not? And this has been a real lively discussion in the EURAPS consensus panel recently, and we're going to talk a bit more about this today, later on, as to whether or not these patients, whether they have a capsular contracture or not, need to have the capsule removed in order to reduce the risk of malignant transformation in the future. And is there actually a risk? So this is really controversial, and it's something we'll discuss later today. Closed capsulotomy, I only mentioned to condemn. You should never do this to a patient. It is very painful. You can rupture the implant. It doesn't treat the condition. If you're going to operate and take out a capsule, you must do an open capsulectomy. And whether you do partial, total, unblock, and what is the difference between them? Well, this again is another controversial discussion that we can have later on today. There is certainly an obvious difference between a partial capsulectomy and total capsulectomy. Not every patient with a capsular contracture needs to have a total capsulectomy. One of the things to mention, certainly to trainees, is that total capsulectomy in patients with a well-defined capsular contracture is actually quite an easy operation to do, even in patients with submuscular implants. But when we start talking about unblock, we get into a whole different definition about what we mean by unblock. So, and the other option is to change the plane. One of the things that Oscar Wilde said, he was a fellow Irishman, he said that life imitates art more than art imitates life. I'm not sure he was quite correct, and who might argue with him, but I'm not sure he's quite correct when it comes to this staircase in the Vatican. It's the double helix staircase from the 1500s, rebuilt in the 1930s. If you get a chance, go and have a look at it. It was built long before we ever discovered the DNA double helix. I would like to thank Fabio and Mark for the very kind invitation to come and speak to you again and visit Rome. It's been amazing. And I'd particularly like to say a special thank you as well to Diana, Carlotta, and Anna from Eurotraining for organizing what has been an amazing conference. Thank you.
Any question? Professor Berrino. Yes.
Pietro Berrino from Genova, Italy. You gave a wonderful speech about capsular contracture, the typical classical capsular contracture, which is the spherical one. But today, we rarely see it, except in a radiated patient, for example. We mainly see capsular alteration, which means fibrotic bands, area of laxity, so something which is not related to firmness. So I think now we should look at the problem in a different, modern way and go beyond the Baker classification to a more morphological view rather than firmness and thickness of the capsule. I would like to have your comment on this.
Pietro, who am I to disagree with you? Yes, you're absolutely right. Things have changed, certainly in the cosmetic world, and we probably need to start looking at new ways of thinking about how we both look at these patients and in fact manage them as well. Yeah, I agree. Thank you.
Please, Mark, and then I have something to say.
That was a great summary and a helpful review. If we look at capsular contracture rates over the last several decades, have obviously plummeted. So often we hear speakers say that it's because our techniques just got better. We're just such better surgeons today. That there's some really great literature in the Aesthetic Surgery Journal recently demonstrating the capsular contracture rate related to gel bleed, and that perhaps because of our implants changing and the bleed going down, that's actually affected our rates. And so often we blame surgeons and surgeon techniques when it's actually our devices, and the devices need to get better. Any thoughts on like why it's gotten better and how do we continue to improve that curve?
I completely agree when I was talking about implant technology. This is a whole other area of discussion. And there have been some really major changes in implant technology. And as you say, trilaminar shells and less bleed, and some of the surface texturing that we now have, microtexturing, nanotexturing on implants. I'm we are certainly seeing some real big changes in capsular contracture rates. I'm not, I have no disclosures. I don't work with Motiva or anything else, but they are reporting capsular contracture rates of 0.5%, 1% at 10 years, which is, we used to think 10% was fantastic, you know? So yes, there's no doubt implant technology is having an influence.
Thank you. It was unfair, Mark. You took my question. You know, it's I like to stress the point. I mean, excellent presentation. I missed, of course, any consideration about the gel bleeding, because what has really happened from the previous smooth implant, which you refer about the papers, and the smooth implant now, what has really changed dramatically is the gel bleeding. Everybody seems to forget it, even companies. Well, why company forget about gel bleeding? Because the implant are still bleeding gel out of it, the best ever, still bleeding. I've been putting in a box 4 different types of implant, including polyurethane, and I left it there for 6 months. Then I opened the box and there was the imprinting of the gel of the 4 implants. I mean, it's this is the real reason left why we still have capsular contraction. Of course, there's 3 things can go wrong, you know, the texture, the gel bleeding, and the gel itself, or we may say 2, gel and surface, but it's not only surface. A lot is coming from the gel that is bleeding out.
Completely agree with that. Yeah, absolutely.
Thank you again, anyway.
Thank you.
In the next presentation, solving the tuberous breast volume integration with round implants in dual plane, Professor Schonauer.
Mr. Chairman, thank you very much for the invitation. Tuberous breast is characterized by a few features: breast-based constriction, high inframammary crease, areolar enlargement and gland herniation, breast ptosis, and sometimes asymmetry. The objectives of the treatment are, first of all, breast remodeling together with management of the nipple areola complex, ptosis correction, asymmetry correction, when needed, volume integration. When there is enough tissue, like in tubular breast, there is no need of implant. You just need breast remodeling procedures, like also in some severe breast asymmetry situation, you can get away without implants. But most of the patients with tuberous breast are young patients, and they are coming requiring volume integration. So what is the strategy? I am presenting my way of approaching this problem with circumareolar incision, transglandular approach, putting round implants in dual plane pocket and doing an aggressive release of the gland both posteriorly and inferiorly. This is the same patient at 6 weeks with 400 mils round implants. So the technique is basically the one described by Kolker and Collins in 2015 on PRS, which is with, I was saying, with the circumareolar incision to the telescoping, which is important to me, transparenchymal approach, a good release of the posterior plane of the gland from the pec major, and then going in the dual plane pocket. What is very important is recruiting tissue to expand the inferior pole, which is actually one of the key points: glandular score and round block closure. So behind, we do always an aggressive star release, which is like putting a lemon on a squeezer, and at the end of the squeezing procedure, so that the gland is ready to accept the implant and is not constricted anymore. This is a patient with this kind of approach with 360 mils. This other patient, you can see the inferior quadrants. The classification we are using is the typical Groth A and then modified by Costaiola. Most of the tuberous breasts were type 2, type 3. And in my geographic area, patients are asking quite large volume implants. So basically always 360, 400, 450. So what is the challenge? The challenge is to expand the lower pole by this aggressive scoring and putting implants in one stage. This is another patient with some grade of asymmetry. We have been talking about asymmetry. The strategy is always to try and put same size implants, maybe trying to take out a few grams from the larger breasts. Again, 400 mils implants in the dual plane pocket. You can see the tuberosity of the nipple areola complex. You cannot get away, in my opinion, without a good round block closure, which is the concept of telescoping, which has been clarified in the literature. This patient asked for a 450 mils. I decide the volume of the patient together, the volume of the implant together with the patient. I never decide myself only. This patient had tuberous breast together with a chest wall deformity. So we decided slightly larger implants, 505. And you can see in the lateral views also how the lower pole is expanded and how the inframammary crease has been lowered. Again, in this case, you can see how we lower the inframammary crease and how the lower pole expansion is obtained by aggressive scoring. Again, 400 mils implants. Of course, sometimes you can have problems. This patient was offered a fat graft procedure that I never do together. This is my series without fat grafting, with implants only. You can see there is still the memory of the inframammary crease, and to this patient was offered fat graft procedure. This patient, again, with a chest deformity, sometimes a tuberous breast is accompanied to chest wall deformity, and again, large volume, 550 round implants. This patient with a slight asymmetry that was corrected in some way by taking few grams from the left side with 360 mils implant. Of course, sometimes we are forced to do this procedure only on one side and to do other procedure like in severe breast asymmetry and tuberous breast. So breast reduction on one side, and you can see how the inferior and medial quadrant, which is completely absent in the pre-op, has been corrected in the post-op. Tuberous breast can be associated with pectus excavatum and always with the circumareal approach can be corrected. You can see also the expansion in the lateral views. We did a retrospective study of patients operated for tuberous breast using the Costaiola classification, which compared to the Groth A is including also type 0, and evaluating the outcomes. Inclusion criteria were the use of implants, and we included 74 patients, and we looked at 5 parameters: breast shape, volume, nipple areola complex, symmetry, and scars. This is our series of 74 patients, and we saw that implants, of course, were used in most of the time bilaterally, 94%. Sometimes with significant volumetric asymmetry. Type 2 was the type of tuberous breast seen the most. And in 85%, we were okay just with the round block mastopexy, which is a good indication. Our evaluation with the VIS scales gave us good marks for volume appropriateness, for nipple areola complex shape, and also for symmetry. Recently, we started using a new laser level up, which you can use with your iPhone, that is projecting two crossing green bars, one horizontal and one vertical, while pointing the patient with the phone camera. You can use these for better planning in the pre-op, the symmetry of where you're putting your nipple areola complex, and also for checking your post-operative result. Because the most important thing is the pre-op adjustment of where you put the nipple areola complex to get good results in the post-operative. So, in conclusion, the key points of the treatment for tuberous breast are management of the nipple areola complex and ptosis management that you both can get away with circumareolar mastopexy and a good round block closure. And when you need volumetric integration, of course, you can use fat graft, but this series was with just round implants and gland remodeling in the dual plane pocket. Thank you very much.
Any question?
I have one question, because when I look at your post-op pictures, it seems that all your scars are still red. How long is the follow-up, and what happens after 1 year, 2 years? What about stability, and specifically stability of the diameter of the nipple areola complex?
May I have the slide just after the finished one? One slide just after. Yes, absolutely right. I didn't have for time limitation to discuss this. The round block scar is subjected to revision, and we offer that. So if I go just there, I was ready for this question, and what I offer to patients is a circumareolar scar revision, which is a very easy procedure, but still you have limited your vertical scar, which is no needed, and with a very nice revision, you can get away after 6 months or 1 year.
Thank you.
Can I? So thank you very much, Fabrizio, for your interesting presentation. I have a couple of points. You don't go through the glands when you use the circumareolar or the periareolar approach. You dissect under the skin.
No, I go through the gland.
You go through the gland.
Transparenchymal approach.
Okay. So now comes the point that I would like to raise a little bit of discussion, because we saw yesterday the approach by Stephen. I don't know, where is it, Stephen? There it is. And which I also do. We do from inframammary. We don't need to do a revision of the inframammary scar, and we apparently achieve the same results. I think the key point is definitely the dissection of the skin from the gland. Where are the bands of retraction? So even going by periareolar, probably I would not go through the gland. I would go under the skin in the lower pole, so that you dissect all the contraction and leave intact the gland. Because what I noticed, I don't know if something that I noticed myself only, or I can share with other colleagues, when you go through the gland, you disconnect the lower pole of the gland from the duct. And when you disconnect the gland from the duct, later on you have an atrophy of the gland. And you may have secondary long-term asymmetries of the lower pole because you have been cutting through the duct. That's my experience. I don't know if, Stephen, what's your opinion?
Well, I had made a decision I was going to keep quiet this morning.
No way.
But seeing as you've dragged me up, with the greatest of respect, I've seen nothing this morning which would change my mind. You've obviously got a great experience, and I love the honesty of most of the talks. The periareolar scars that you showed that were good, they didn't need a periareolar scar because the size of the nipple didn't change. The ones that were poor were the much larger ones. And I don't think actually saying it's easy to do a periareolar revision at 6 months is a good answer. I don't buy that, actually, personally. You're obviously making it work in your practice, and congratulations. I don't want to make it about your particular series. But if you've got a really large, some of the really difficult ones, I personally would still do a vertical scar. I don't see the problem with putting a vertical scar in the really extreme cases, that you will then control the nipple completely. But again, I think the more honest picture.
So what is your?
Well, I think
Make
the more honest picture is actually the one that you showed at the end, because that is what happens.
Okay.
That's what happens. I think.
So first of all, the vertical scar has been sort of abandoned recently. You know, the trend is to abandon the vertical scar because it's been clarified that tuberous breast has not problem on the horizontal deficit, but only in the projection of the nipple areola complex. This has been clarified by the literature, first of all. Second of all, to do a revision after 1 year is an ambulatory procedure that takes you 15 minutes on one side and 15 minutes on the other side, and the breast is corrected through the periareolar approach. You presented yesterday, yes, from Nottingham, yes?
Yeah.
Right. Okay, I didn't want to ask you yesterday because I was waiting to present my cases this morning. I have seen some areola, tubular areola, left like that and seen after 1 year, and they are not retracting at all. So this is my answer.
Okay, but that's not my experience, and that's not my experience with long follow-up in these patients. And it's not that I'm saying no patient needs a scar around the areola. I'm not saying that. What I'm saying is that many of them don't need it.
Okay, I'm happy that I started this argument, that you will continue in the coffee break personally, and give room to Marco Klinger for a very short question, please, because...
With the maximum respect, the problem is completely different. The tuberous breast is tight, and you have to enlarge, and first of all, to slow down the sulcus, as Fabrizio said. First. Second, you have to make more round the inferior pole, and you need sometimes fat graft and needles, as we use, as Fabio said yesterday. And sometimes you need flap from the gland to round, in the most difficult cases, to round the inferior pole. The periareolar scar is necessary in the sense that you have to put the areola in the top of the gland. And if you are going to do a periareolar scar with time, cutting, as I said yesterday, all the dermis and going deeply on the gland, your periareola is okay, and your areola are not going to enlarge. So it's a completely different way. I think that the last days, we published a new classification a couple of years ago, and the new way of seeing the tuberous breast is new. It's completely different from the past. You have to slow down the sulcus to enlarge or the breast, to put a new shape with implants or without implants, and then to move the areola. Is completely different. This is my opinion.
This is exactly
Thank
what
you
I
very
feel.
much. We will remain without consensus on this issue. So we postpone it to next year again. Thank you.
So now, interesting talks, point, counterpoint. Looking forward to your presentation.
Thank you. I thank Fabio and Mark for the kind invitation, and congratulations for the excellent organization of the meeting. So Fabio asked me to talk about my experience with microtextured implants that I use since now at least 10 years. I had no disclosure to declare. Breast augmentation, as we all know, is one of the most frequently performed procedures in plastic surgery. An estimation is that about 35 million patients implanted with a breast implant, and it represents, as we all know, one of the most performed operation in plastic surgery. In Italy, we have every year almost 60,000 breast implants sold, 33 for aesthetic purposes and 37 for reconstructive purposes, actually. Mr. Croning, Dr. Croning and Dr. Gero invented the silicone breast implant. And since their use, the breast implants have undergone progressive improvement and innovation in terms of implant filler, material, shape, and surface structure. So that's called texturization. And the first lady to be operated on with a breast implant was the Timmy J. Lindsay, that was operated in 1962 in Houston, Texas. And here's the Timmy J. Lindsay. That was a curiosity. She was in on the left side was in 62, and now she's 92, and she still has prosthesis today. According to some literature, I mean, it's not scientific literature, so publications, she still has the same prosthesis, but I guess she changed at least 4 times. And going through the generation of breast implants, current silicone gel are made with cohesive gel, and we know that with the time it changed from, as to concern shell thickness and gel stability. And this is the classification of breast implants that we actually know around microtextured, and newly the so-called nanotextured, that I think could cause a discussion because some people think that they are more smooth than nanotextured, as we know. Another point is secondary breast surgery. The steady increase of primary breast augmentation procedures has led, in addition to a rise of the number of reoperations and secondary breast implant surgery. And we know that the causes of reoperation are multiple, and we can rate here oversized implants and wrong pocket dissection, inadequate soft tissue for implant coverage, bleeding in the peri-implant space, excessive handling of the breast implants. Capsular contracture probably and surely remains the most common complication after breast augmentation, followed by rupture and malposition rotation of the breast, actually. To minimize the risk, this is for the trainees and residents, we should, and to reduce the complications, a good patient selection is mandatory. Tissue characteristics have to be considered, preoperative planning, implant selection, and surgical technique. And around our implant selection, also here, the choice of breast implants depends on some factors like patient's anatomy, surgical history, patient's wish, sometimes are difficult wishes, surgeon's experience, aesthetic goal of procedure. Although the current literature does not provide a guideline for the choice is, of course, to be a combined patient and surgeon decision. Preoperative planning is important, very important, and all around surgery, so physical examination is very important as well. Our experience has progressively directed us in breast augmentation towards microtextured breast implants because this type of implant, in my experience, provide a great versatility and safety confirmed by the result I have, the long-term result I have. We know that there is no perfect implant for all patients. Both round and anatomical devices can lead to satisfactory aesthetic results. In my experience, so we have with round implants lower risk of rotation, greater projection of the upper pole, lower incidence of capsular contraction or capsular contracture. The costs are lower than with other implants, lower risk of malposition and deformity, and lower risk of BIA, LCL compared to macrotextured implants, as we know, of stability over time. As far as my experience, contraindications are poor soft tissue cover, chest wall deformities, and short lower pole in the use of round implants, and the patient desires. Round implants may be avoided in patients who desire more concave upper pole, but after all, how many women want an empty upper pole? So in that case, we wouldn't have this kind of situation that I find nice. In our experience, one of the most interesting advantages based on the experience these years are the absence of rotation on the vertical axis, of course, low risk of malpositioning combined with ease of insertion. We choose this type of breast implants for patients who train regularly. So I have a lot of patients who ask for, when can I start to go to a fitness center again? 1 week, 10 days, and they always want to go very early, whenever it's necessary to use a subpectoral and dual plane technique, or in secondary mammoplasties, which present a higher risk of complications. When possible, my preferred approach is periareolar, followed by inframammary. I always make 1 millimeter inside the border, skin areolar border, because in my experience, is less visible. On the other side, incisional level and from mammary fold, it's so less bacterial contamination. I report my experience using almost 500 operating patients using microtextured implants. 60 were reconstructive procedures, 420 aesthetic procedure, divided in the numbers you see down there. So I want to show some clinical cases. This is a 22-year-old young lady with severe bilateral breast hypoplasia. She had a submuscular implant accessed through the inframammary fold. When the neck is too small, I prefer the inframammary fold. And she got 225 cc's as implants. You can see here the pre-op and post-op result. Again, one more case of bilateral breast hypoplasia, tuberous breast, perioral incision. In this case, we implanted an implant submuscularly with 300 cc's implants on both sides. And this is a result at 6 years. Again, one more case. The lady was operated on 18 years in advance. She had a micro-textured implants before, and she had an intracapsular rupture. We replaced the implant subglandularly through the previous incision bilaterally, and she's got 300 cc incision. I don't use very big implants, actually, and always maximum 350, usually. And again, one more case, the lady, 40-year-old lady with a hypoplasia, bilateral breast hypoplasia. In this case, we use 275 cc's moderate plus. That is the most used by me, implant by me, actually. And this is a post-op result with patient satisfaction, pre-op and post-op. One more case, this is a young lady as well with severe bilateral breast hypoplasia. Implants that I used in this case was 275 dual plane technique. And that was a result at a distance. I don't think the upper pole is very, though using, these implants, the upper pole is very, very accentuated actually. So as far complications, I had some cases of rippling, almost all in thin patients. 8 Baker 1 to 2 capsular contractures. One case of bilateral upside down rotation that was on both sides. That was very strange. The results reported from my experience, and we can conclude that we had almost absent findings of capsular contracture using this kind of prosthesis. No cases of BIA-LCL. I haven't seen one in my structure, in my unit, actually. No cases of malposition, bottom in and gout, stable result over time, high patient satisfaction. The result is pretty natural, and the prostheses, these prostheses are versatile. I think possible rippling thin patient, we have to think about that, and there is a faster learning curve compared to other implants for young surgeons. So I thank you for your attention.
Hello, Paulini from Rome. Thank you for your presentations. Very nice cases. I want to ask you if you change your way of mind when to go subpectoral. As we changed in the last years our way of doing breast reconstruction, going subcutaneous, so avoiding pectoral animation, I want to ask if that way of thinking in breast reconstruction affected your aesthetic breast surgery.
Yes, actually, in some cases, yes. And I actually use also for breast reconstruction mostly the round implants, because I think very versatile, and they give less complications in my experience. So usually, yes. When I can, I also, if I make prosthesis change, I stay in the same level, at the same level. I don't go necessarily underneath the muscle. Thank you.
Next presentation, point counterpoint, why I switched moving from texture to smooth implant surface. Ulrich.
Yeah, good morning, everybody. Thank you, Fabio, for the kind invitation to give a lecture about this topic. And it's funny because 1.5 years ago, I went to Houston to give a lecture about this topic. And it was very comparable to what Giovanni said this morning. And I had also there as a European surgeon, I wasn't used to use smooth implants. So Fabio, thank you very much again to give me this chance to say you why I changed my mind that I will get more and more in contact with smooth implants. I've got no financial disclosures. I've got one disclosure. I'm coming from the Netherlands. It's a very special country if we deal with prosthesis, because I will tell you why. It's a very small country, and the situation in the Netherlands is that we are one of the first countries with a national database concerning breast implants. We've got a regulatory board. It's from the Dutch Health and Youth Care Inspectorate. All of the medical devices are monitored, including the breast prosthesis also. There are no real recommendations against using textured implants, and they meet the statutory requirements, and they may be used in the Netherlands. And we've got also some recommendations from the Ministry of Health in the Dutch system. Here you can see some data from our national database. And as you can see, for aesthetic procedures, around about 20,000 implants are used in the Netherlands per year. And for reconstructive reasons, around about 7,000, 8,000 implants are used in our country. And as you see here, the discussion in the Netherlands, it's not about BIA, ALCA, it's more breast implant illness. It's a very hot topic in the Netherlands with a very aggressive discussion also on the TV also. Fabio already mentioned it in the very beginning of this session. There's always a silicon bleeding there. And there are some scientists also in the Netherlands, they call themselves scientists, that all implants are bleeding, and you can get very terrible sick about the situation. If you use implants in the media, on TV, you get these articles also that you can die when using implants, and you have to remove all implants if you want to really save your life in a way. So this is a discussion we have to deal as a plastic surgeon, reconstructive surgeon, and aesthetic surgeon in the Netherlands. As we see the indications for the revisions in our aesthetic procedures in the country, what you see is that the breast implant illness, it's getting more and more the reason that people want to get rid of their implants. The BIA, LCA suspicion is also a reason, not so high, to get rid of implants, and the BIA, LCA problem you can see here. For the reconstructive procedures, it's a bit different. Here you see also the breast implant associated illness. It's getting a bit more, but not comparable to the aesthetic procedures. And it's for the BIA, ALCA, suspicion, it's comparable. So this is the situation I have to deal as a plastic surgeon with. And as you see, it's also has been mentioned yesterday, there are more and more women who want to get rid of their cosmetic breast implants. The next disclosure I want to mention is I'm a microsurgeon, and I don't like to deal with implants. There are a lot of people and patients where implants are really, really a good choice, but I always try to use natural tissue, autologous tissue, whenever it's possible, like in this patient with a lap flap for a nice natural reconstruction. And I also use lipofilling, but as you know, the results can be different also, and there are still people that need implants also for aesthetic and reconstructive reasons. So what's the reason that I really changed my mind, that I try to get rid of a bit of textured implants and to use more and more smooth implants? It's quite easy to say. The person is sitting there on the right side. When I was on the plane to Houston, we had a small discussion about this topic, And I told Fabio, I don't know, I'm a plastic surgeon. All the technical things we can change. I can change it, I can adapt in a way, but I'm depending from the implant industry. And this is really something, I've got really problems with this. And also the discussion with BIA, LCA, they're really data on this. And the studies I'm really missing. And Fabio told me, yes, I'm also a microsurgeon, but what's the reason? I will give you some examples why I switched my mind in this way. And as a reconstructive and aesthetic surgeon, we have to deal with all the different female breasts to get a really natural shape in every woman. And the Inuits, they've got 100 words for snow. The plastic surgeon has got much more than 100 words for the different breast shapes, even what we have seen today here. And to get really a natural breast with different implants, we've got so much choice also. And for sure, everybody and every woman, most of them, will really get satisfied after this procedure. This is a study from our unit. We performed in more than 1,400 females for breast augmentation. What you see here in this large series is that the breast Q with all the different topics, with satisfaction with the breast, psychosocial well-being, and sexual well-being, it's a huge improvement we can achieve. And all these data has been done with female patients with microtextured implants in our country. And I'm not sure what will happen if we use smooth implants. I really think it will be the same, that there's an improvement in the quality of life in the patients. For the implant choice, we've already heard it from the former speaker, the gland thickness, the skin thickness is very important. The breast height also, the breast width, and also the previous treatment. But for me, also, there are not so many people in the world, but this is still a great topic. We will hear about the next session also. It's BIA LCA. And I don't know how to deal with it, with the recommendations here also. And the problem is it's an unknown risk for implants with a lesser degree of texturation, also with microtextured implants. For sure, the risk is less than with macrotextured implants, but it's not zero. And what I see in my country is that the women are more willing to consider some other options, not using implants for augmentation or for reconstruction. And sometimes they really get in the direction that they have to pay for other procedures like free flap surgery, for example, or other things. And sometimes it's my impression that cosmetic breast patients are becoming more bilateral reconstructive patients in a way. So in my opinion, there's not really an objective study that textured implants provide a superior aesthetic results. I'm still missing this. And everybody of us, I saw great results today. And also everybody has his own experience, his own case series also with nice results. But I'm really missing objective studies. And I really think that similar results can be produced with a lot of different implants, also with using smooth implants from the colleagues from the United States. I saw beautiful results using smooth implants, round devices. And even if there is a small advantage when using shaped textured devices, in my opinion, any marginal aesthetic benefit cannot justify introducing a risk of death in a cosmetic procedure. And this is one of the reasons that I try to change my mind and to convince people and women to get more in the direction of smooth implants in Europe. And for sure, there are some indications, for example, the direct to implant reconstructions in patients, where microtextured implants, in my opinion, can be a bit an advantage if we use them. And also in corrections of the tuberous breast, anatomically implants might get to a better cosmetic results, for sure. And also, for example, correction of a pectus excavatum in special tall patients, it can be nicer to use an anatomically textured implant, for sure. But altogether, in my opinion, it's not so easy for us as a plastic surgeon to choose the right implant. What's the right implant? It's my opinion that this implant is the right implant. And there should be always a choice, as already mentioned before, between the patient's wishes. Yeah, I want to have the nice breast, and what's really surgically possible. And it's a shared decision-making process between us and our patients, maybe the family also. And there's also the discrepancy in different countries, the European countries and and other countries. And for sure, smooth implants cannot be used in all patients with the best possible result. But until I have no real guidelines and hard data and evidence, I think by my own, this is really a personal opinion from me, I will get more and more in contact to smooth implants. Thank you very much for your attention.
Yes.
Hi, Maurice Nahapedian. I really enjoyed both of the presentations on smooth versus microtexture. Just a comment, really, but in 2017, David Hidalgo did a randomized controlled study comparing anatomic to round implants. Plastic surgeons, patients, 50-50 split. They couldn't tell the difference.
That's true.
Last month in Barcelona, Jaume Macia did a panel, showed a bunch of patients, prepectoral, dual plane, anatomic, smooth. The audience, we were all over the place. You know, people, there was no predictability as to whether it was a smooth or an anatomic device. So I think in properly selected patients, you could use either of these devices and get great results. It's just my comment. So I don't think it really is as big a deal whether we use an anatomic textured or a smooth round anymore.
I completely agree with you. This is the reason that I also changed my mind.
Congratulations, nice presentation. If you are talking about change of mind, I ask you if you change the terminology of the anatomical implants, because we call round implants, but really there are round footprint implants. But the gel, especially for example, the Ergo 2, is moving down, and this is the anatomical breast. If we put the form stable implant, it doesn't change the shape according to the position, but natural breast change. If the woman is on the horizontal position, the breast is flat. If it's standing position, it's more natural, the more fullness of the lower pole. So if we have an implant with round footprint, that can be anatomical because it changed the shape according to the position. So maybe when you talk, this is my question, because you change your mind in the opinion about, and you present very nicely. But maybe we have to change the definition of anatomical implant.
This might be a good review for you also, maybe just to give a command then or a letter or something like this. What's an anatomical implant? And I think most of these implant things, it's a kind of advertisement from different companies, and this will get really a kind of anatomically shape. And this is just, in my opinion, it's an advertisement also companies use.
Paulo,
thank you.
Extremely quick because we have the MMI Symposium.
Just to say thank you for your presentation. I also shift to smooth implant, despite I started with smooth implant and passed to texture and going back to the smooth. But are really related to the implant all the disease we observe today? Because, for example, the Asia syndrome seems to be related to the implant, but most of the time when we remove the implant, the patients still have the same symptoms.
Exactly.
Yeah. So that's a main problem. And I would like to know your opinion about that.
Absolutely agree. And what we see in the Netherlands, we started a prospective study also with these breast implant illness problems also. We cannot really deal with it. And what we see, I've got a lot of patients who are coming to me and wanted to get rid of their implants. They want to get lipofilling. And in a lot of patients, the symptoms afterwards, they are still the same.
Thank you very much, Dietmar. So I think before we go for the coffee break, I would like to give some couple of medical advices to you for those that were late at the party last night, and I want to thank especially. I will provide, the Congress organization will provide tablets. It's called paracetamol. That helps a lot, headache and muscle fatigue. You can find it here. Of course, I cannot give the real name, but you can use it there if you like. And of course, for the next coming meeting, which I give a promo introduction of the next coming meeting, which is the World Consensus Conference, we will attend and listen so many contrasting and impressive evidence that most of them will like it, but some of us will not like it, especially probably in the streaming. They will not like the evidence that it will raise. So for those other, I would suggest another medicine, another drug, which I cannot give the name, but I will read what is inside, and is magnesium hydroxide and aluminum oxide. And you as a doctor understand exactly what I'm talking about, and they can find it here as well. So thank you, and have a coffee break. I invite you, of course, to come back immediately as you can for the MMI Symposium. It's going to be very interesting, the robot for microsurgery. So please pay attention to this very interesting device.
Okay, we're going to start with the symposium now from MMI Symposium. So I can give you the word. You can start your talk. Would you like me to pronounce your surname?
Thank you very
Kueckelhaus.
much. Yeah,
Great.
very nice pronunciation. Thank you.
Okay, please.
Okay, then let's get started. Thank you very much to MMI for organizing this. This talk is about robotic microsurgery and how it changed our breast reconstruction practice. So let's dive right in. In 2022, we got a grant by the European Union to investigate robotic systems for microsurgery. And this way we were able to acquire the Sumani surgical system, which is a robotic system that you can see in the hall next door, which is specifically designed for microsurgery. It has wristed instruments with 7 degrees of freedom, and you can scale down the motions you do up to 20 times. It's a drivable system. It's very flexible. It's designed for open microsurgery, so important that you can bring it in and out of the operating field quickly. And we combined this system with an optical system, a robotic optical system, the BHS robotic scope, which basically has head-mounted displays that will create a 3-dimensional image for your eyes, and then you can use your head movements to switch the angle, zoom, focus, etc., everything with your head movements. This way, if you combine these two systems, you can be completely decoupled from the operating side as the surgeon, and you have synergistic effects by that. So to give you an idea what it looks like, this is our first deep flap breast reconstruction that we performed using these two systems. The surgeon on the left, I'm performing the arterial anastomosis. I'm not scrubbed in for that. It's very comfortable. You can be ergonomically in a very nice position, and the assistant is scrubbed in case of any unforeseen events. This is basically the surgeon's view, getting settled into the surgery. This is what you see, and you navigate with your head movements through that menu. You can do recordings and all that stuff. Then you can zoom in, focus. You see this augmented reality menu you can navigate through, and this cursor again is moved with your head. On the right side, then you can see anastomosis getting started. This is usually a bit more fluent, this video. Yeah, so that's not what the surgeon sees. It's you see it fluidly, of course. We started and we performed around 80 cases by now. And to see what we are applying the system for, this is about our case composition. So it's mostly actually breast reconstruction we are using it for, but also for extremity reconstruction and also some lymphatic surgery. So in order to evaluate if this system actually makes sense for us, we started going into the project saying we want to do the safest microsurgical procedures first, get trained on the system, be confident, and then see what else can we do with this. So after 23 patients, we looked at our learning curve, and we actually saw that we did significantly improve in skills and time using that system. And then we thought, okay, so we're very confident with this, and what are the major advantages over doing manual microsurgery? And one key advantage is that you can downscale the movements to the level you need. And if you go smaller in vessel anastomosis, you just downscale and you increase zoom, and then it doesn't change anything you have to do in terms of movements. So basically doing a 2 millimeter anastomosis is basically similar to doing a 1 millimeter anastomosis or smaller. And we realized that in the first cases. And so we said, all right, let's try to use that system to become less invasive in what we are doing. And we had not done perforator anastomosis for, either for extremity reconstruction or for breast reconstruction before in our practice. But this way we felt confident in moving in that direction. And that is our first patient where we said, hey, what about we use the IMA perforator prepectorally, and that way we don't have to go through the muscle. That way we can be more superficial. That way we don't need as long of a pedicle for the DIEP, and overall create a surgery that is less invasive, but of course, needs to be at the same safety level. So that's the first patient we did. We applied this, and on the right you see the perforator slightly right to the arrow, actually. Pretty small. This is on the left after anastomosis, worked fine. The veins are large, actually. There's a paper that says that the perforator veins are usually the size of the IMA accompanying veins, just a lot thinner. The patient after surgery on the right, and a few weeks out. So that surgery worked fine. She's gonna get a contralateral reduction. With the perforator concept, we then went to also do extremity. That's a soldier from Ukraine that got a perforator to perforator skip flap. And it's a learning curve for those of you that have not done perforator anastomosis. It's really a learning curve how to treat the perforator so it doesn't get spastic, doesn't get a spasm. Because you can mess up the surgery in the beginning if you're not treating the perforator well. And as this was working for us, we said, okay, we want to standardize this, and we want to do a proof of concept and a case series, developing this concept of just being a lot more superficial and less invasive for our breast reconstruction, moving from the traditional technique on the left to that perforator technique. And it has a few advantages. If you use the perforator prepectorally, you can also, to get a better size match, raise a shorter pedicle for the DIEP. And that's a major concern if you discuss the topic, that the pedicle will be too short for inset or maybe get you into trouble. Well, that may be true if you would go to IMA. However, if you go to the perforator, you can add that part of that you have for the perforator that is more superficial and basically subtract it from what you need of a pedicle length from the DIEP. Because if you add these two together, then you get back to 10 centimeter plus what you need for a flap inset. This is another case, and what we do now is basically we only, if we have a deep flap that has a dominant perforator, we cut around that perforator, and then we don't do any more longitudinal incision in the rectus muscle. We only go through that like 2 to 3 centimeter maximum hole and prepare a pedicle that is a bit shorter. But again, you can compensate for that with the length of that perforator, and you see that on the right. That's the perforator. You can basically follow almost all the way subcutaneously. And this is, yeah, an image to show you on the left how superficially you are. You don't need any retractors for that. You just have two of these, we call them fish hooks. Don't know what they are called elsewhere. And you have that pedicle that is composed of the D pedicle plus the perforator, ICG on the right, to show that it's actually everything is perfused, because that's another discussion point that people are saying, well, if you use the perforator instead of IMA, do you have a different perforosome? Do you get less perfusion in the flap? And we could basically show, we did ICG prior to flap harvest and then after, and we did basically not show a difference. So I think this is important to assess in order to address the safety concerns. So what we did then is we actually changed our practice pre-operatively as well. So in this patient, we do the duplex ultrasound prior to the surgery. That way we are trying to determine now pre-operatively, is that patient suitable for the surgery? Because not every patient has a suitable perforator. And so JP Hong published a paper saying you need 15 centimeters a second for an extremity reconstruction flap in the recipient perforator. So it's suitable to have enough perfusion, provide enough perfusion for the flap. In the breast case, I feel more comfortable if it's 20 centimeters a second, and that is when we say, okay, we will try to perform the surgery. So to give you some more examples, this is a 38-year-old patient that had actually 2 cancers in her breast, got it removed completely, got radiation therapy, chemotherapy. So these are also cases that are not basically cases where you would say, okay, we have the best tissue quality, but that are the patients that we have. So we did it in this one. And what you want to do here on the left, you can again see the perforator prepectorally. You see that there's quite a lot of tissue around that perforator still, but that's intentional. Because we want to stress the perforator as little as possible. On the right side, you see the donor side after flap harvest, with I think it's quite, it explains it well why this should be less invasive than the regular approach. On the left, you see anastomosis with the robot, and on the right, you can see what I was saying before. The right, in the image, the right side, that's the perforator, and that makes up about 30% of the pedicle length that's added to the deep pedicle. That's the result. That's a pretty large breast. It's about C or D cup that we reconstructed with that method. And that worked for us in a few patients, worked very well, encouraged us to keep going. But the perforator identification and preparation on the breast side was actually was taking longer than the actual deep flap. So we said, okay, this needs to be standardized, and we need to get going faster with this. It's working, but it doesn't have the standardization that a deep flap needs to have yet. So we thought about how can we do this faster, and I think this is a good technique to do it, no matter if you have an ablated breast or nipple-sparing mastectomy, or we do mastectomies ourselves whenever necessary. So we would go down right to the pectoralis fascia, and then from there go cranially, and then identify the perforator, not somewhere subcutaneously, but identified at the exit point of the pectoralis fascia. And from that point, then actually go distally and prepare the perforator actually the other way around as you would usually do it. And that works best for us in doing a speedy perforator dissection. Again, that was the image to show. Don't strip the perforator more than you have to. Just take this bulk of tissue and only strip the very last part that gives you the best quality for anastomosis. In terms of the harvest, yeah, we are moving towards using as few instruments as possible for this. So these are only 2 small retractors and 2 fish hooks again. That's basically it. And we basically clip artery and veins in one clip now, and then just pull it out and prepare for the anastomosis then on a back table. So now we've done a few of these flaps, and we think the concept it makes sense and it works. But what's the benefit? And I think that is the next step now that we showed that it's been safe, although we need more numbers to, if you have a 99% success rate in a regular deep flap, you need more than a few cases to show that it's equally safe. I think that's obvious. But we also want to look at what's the benefit, and intuitively the benefit would be being less invasive, leading to less morbidity. And we want to show that in the long term by patient-reported outcomes. We are preparing a prospective study that we already got ethics committee approval. But what can you do in the short term? You can look at opioid use, pain medication use, and the trend is going towards that these patients need less pain medication, which is going along the lines that we intend to show what we can do with this technique. We also moved into doing this with PAP flaps. This is a 51-year-old patient, BRCA mutation, did not want a deep flap because she didn't want the scar. Had already had a contralateral PAP. So we did a PAP flap on the other side. And here, if you do the perforator, actually, this is another thing. I feel more confident doing a pretty sizable mismatch in an end-to-end fashion using the robot because I feel I have more control over, just about the tissue handling, grabbing the exact right amount of tissue with the very fine movements that you can set the robot to then still do an end-to-end anastomosis that is successful. And in this case, on the right side is the flap artery, on the left side, the recipient vessel. And you can see, despite this big mismatch, this worked out very well. That's the patient right post-operatively. Actually, the lesson learned from that was the pedicle was longer than necessary. And if we would have just raised the PAP flap with a shorter pedicle, we would have had a better size match and still a sufficient pedicle. So lesson from that is really think about how much pedicle do we need? How do we want to do the inset? That can save you time and hassle in flap raising and in also lead to a better size match. Then we also thought about what can be a very efficient way to do a bilateral deep flap. This patient, it was a good case to think about this because she's really a heavy smoker, 40 cigarettes a day for decades already, although she's only 48 years old. She wanted larger breasts, which her belly was suitable for. But you would think this patient might actually be a candidate for bypass at someday. So we thought, how can we do this with a robot in a very efficient way? And so we decided to just use one IMA, spare one for whatever she needs in the future, and do a unilateral anastomosis. So the robotic system just stays as is. You transfer the pedicle using suction from one side to the other side. And that way you can do a speedy reconstruction. That's the patient post-operatively. So in conclusion, we believe that the remote robotic microsurgery in our setup is safe. We've had really no cases where we had to interrupt the robotic surgery due to any malfunction of the robot, which is very assuring. We are now using this technology and the new techniques to customize new operative strategies. And this is, again, I want to stress that point. If you feel confident that you can basically go as small as you want with the vessel anastomosis, that opens up new fields where you can use new type of flap surgery. It's more applicable to a wider audience. We have microsurgeons that have very little experience in microsurgery after training, and they can use that system successfully, and they can go smaller than they would usually be able to. So I think overall this is driving the natural evolution towards less morbidity. But of course, we want to be at the equal safety level. And this is why we have to customize our studies now prospectively towards A, showing that this remains at the equal safety level, and B, then showing the benefit of being less invasive translating into less morbidity, and that all being measured by the patient-reported outcomes. A nice side effect, I broke my foot a few weeks ago and fractured 5 bones. You can still comfortably use the robots and keep doing what you love. So thank you very much for your attention. I'm looking forward to any questions.
Really fantastic presentation and exciting technology. It'd be really nice to see the future implications of this. I would say that we could really use your help in our hospitals, making the pitch to the hospitals, the value of this from an economic perspective. It's obviously a huge investment up front, and I think it's obvious for surgeons to see the benefit. It'd be nicer to have that better visual ability and dexterity, but to actually say X number of procedures could now be performed, or this complication rate decreased, saving this amount of money. I noticed that your initials, you have an MBA. Leaning into that would really be helpful from a value argument for doing this in the hospital, because we've already started these discussions in my hospital. And the very first question is, what are we paying for today that will be decreased to offset the very large sum that this has? And that still is a challenge with those studies yet to be performed.
Yeah, thank you for this remark. I think that exactly is condensed what we have to do. I think we should learn from the lessons with Da Vinci, that we focus on the right outcomes right from the beginning, that we're not trying to prove we will be immediately faster with the system, because that's not what we will be able to show in the beginning. Maybe in the long run, when we can speed up this perforator preparation and have it standardized, like as DIEP is standardized at the moment, we might even be faster because we need to go less deep. But I think what we should focus on right now is the patient outcomes and the invasiveness and the morbidity. Correct. And that is what we have to sell to the hospital, that surgery is going to develop in this direction. It's a natural evolution, and we want to be at the forefront in doing that and helping the companies to develop it further and reaching this reduction of morbidity fast. And I think it's a selling point for the hospital, also to the patients, saying we don't want to say, okay, we can operate this 20 minutes faster. I don't think the patient's going to care. But if we say we can do it less invasively, I think the patients do care. Thank you.
Hi, that was a great talk. My name's Kevin. I'm a microsurgery fellow from Belfast. Just wondering, in terms of doing the perforator DIEP, if you have issues where you have to revise the anastomosis, have you had any problems when you have to do that, or have you had to do that?
Okay, a great question. Actually, we had one. That was the first one that I showed, where we are sort of naive. There was no flow on the perforator when we were actually doing the anastomosis, and we were like, is that normal? I mean, there should be some blood, but apparently it got a spasm through our preparation because we were just not experienced in handling it. But we did the anastomosis, and after the anastomosis, flow was fine. So that worked well. We had one case where we had a kinking, and we had to reposition the flap a bit. So that's why it's important that you think about it first. How long do we want to make the pedicle? Ideally, you know which way you will insert the flap. That is important. Yeah, and I think also important to have a backup strategy, at least for the first cases, until you can really show how safe it is. So we kept the contralateral DIEP in the abdomen for actually like 45 minutes after the anastomosis, just to show that it's working. And then we removed that. And another fallback, if you were ever to run into a problem post-operatively, I think then you would need to convert to IMA, and you probably have to, I mean, we don't resect any ribs. Usually, if we don't have to, then you may have to do that and raise an IMA pedicle, as you will, to compensate for that. Thank you.
Great talk. Thanks for this. I was kind of wondering, you started with secondary cases, and this was my question, because in a secondary case, I mean, I generally do not do a single perforator, at least 2 perforators to feel safe. The strategy that you say, okay, what happens if this does not work? Was it not risky? But now you explained how you deal with it. You always had a hemi-DIEP kind of aside if it doesn't work. I think that was interesting.
Yeah.
And what about training options? So people want to learn this. They have the option. They have the option to do that in centers, because I think it's very interesting, specifically also for the youngsters. I think for the next generation of plastic surgeons.
Agreed. I think it's interesting, and I think that the youngsters want to do that kind of stuff. So as these are like specialized operations, though, I think it would be smart to, like, if the users can sort of discuss who's expert in what, like how can we foster exchange and have people visit the other centers and look at the surgeries. I think that's the best way to do it, because I think people will find their niche and dig into that, develop the new strategies, and not one person is going to develop it all. So I think that exchange is something that should be promoted.
Great, thanks.
Okay. Thank you very much then.
So thank you for coming back in due time. We had a little delay due to the previous session and symposium. So I'm pleased and honored to start this fifth World Consensus Conference on the BALCL. We are going to have an approach about the evidence of this BLCL and holistic approach about those evidence. Then we will move into another session which take in consideration the epidemiology, the real epidemiological data, so you can have a clear picture of it and the management of this problem. Then we will pass by to the leading theories about the etiology, because there are several etiology that we are taking back since the years, and we never find out exactly which one is the leading, at least not the definitive one, but at least the leading one. And then we will conclude with a very important session, which is the authority guidance. We will have the connection with the FDA and the European Commission. So I invite you to enjoy this session, and I give the microphone to Mark for some introduction as well. Thank you.
Thank you so much, Fabio. I would just want to welcome you to this new Fifth World Consensus Conference on BI-ALCL, as well as to all of the audience that's watching at home. Something that we did differently this year is that about 10 months ago, we reached out to online patient advocacy groups. There's an online group of about 250 treated patients, and we actually asked them, what are we missing? What are we not including? What are we not answering? And they came back with a lot. So over 50 questions generated on some of the most common challenges, problems, what to do in atypical cases, what to do in reoperations. What if the pathology is not clear? What if you can't have access to a pathologist? What to see on imaging? What to see if it's not black and white? We always talk about the most common symptoms, but what are the subtleties? What are the asymptomatic patients, and how do you treat that? We've taken all those questions and we've spread them out to a lot of the speakers that you'll see today. And so that is really at the core of a lot of the presentations that you'll see. In addition, in the past, we've only had a couple of panels that we could include, and it's been agonizing, the editorial decisions that Fabio and I have had to make of things that we just couldn't include. This year, we did something different. We actually will continue several panels after this concludes tonight at 6 p.m. It will continue online for several hours, and we have cut nothing. So everything that we could possibly present, from a radiologist talking about the subtleties of what they're looking for, pathology talking about how to get reliable diagnosis, oncologists talking about the subtleties of chemotherapy and immunotherapy, and taking very deep dives into all these subjects. We've never been able to do that before. And so hopefully this year it is complete. Everything that we know about this disease presented to you. You may not be able to stay for so many hours, but I hope that you'll utilize that as an online resource to go back to use this as a library that you can access at any point. As we've seen just from last year being accessed over 6,000 times, our first year being accessed over 10,000 times, we hope that this is a resource for you. With that said, let's begin.
Thank you. You will not find, of course, this program on the paper that you have, but you will find it on the online program. You will have this virtual section that just said Mark. So I invite the president and the moderators to take their position in order to start this interesting first session. Thank you.
Good morning. We start with this important session about clinical evidence in BLCL. Close me, Maurice Navejan and Groth. But before start, I would like to ask you, to the audience, all audience, how much surgeon using in primary augmentation anatomical implant microtextured? Raise your hand, please. Only one. Only one. Okay, we can start. The first speaker is Monsignor Lucio Adrian Ruiz, PhD Biomedical Engineering, Secretary of the Dicastery for Communication, Vatican State. It's an honor for me. Please. Yes.
Good morning. Before I begin, I would first like to thank the organizers of this event, not only for their sensibility and competence in convening all you distinguished surgeons to explore this topic in such a holistic way, but also for taking up the challenge of a human and scientific dialogue in the search for goodness and truth. In his famous address to the participants in the 10th National Congress of the Italian Society of Plastic Surgery on October 4th, 1958, Pius XII, a Pope of medical sciences, said, "Plastic surgery has a peculiarity of being an art, not only in the generic sense of work conducted according to certain norms, but because of that artistic sense which is required and manifested in anyone who ingeniously solve problems that are always different, aiming to give a solution, even an aesthetic one. Not two cases are ever perfectly the same, but each one demands an appropriate treatment, always delicate and patient, sometimes ingenious. For the physical beauty of people is in fact an imprint of the beauty of the Creator. So great is the value attributed to your work, having a key role in certain moments of the situation of healing existential wounds in many people, both on the physical and psychic level, that the pontiffs affirm. Plastic surgery frequently faces problems. Already in this, the hand of the surgeons seems to repeat in some way the act of the hands of God that shapes the human being. However, there are circumstances in which the plastic surgeon reaches higher condition of a spiritual order of which they must have full knowledge and therefore adequate preparation in order to become even, they are almost a collaborator of God. This is a great vision of the plastic surgery, which is justified not only by reconstruction, but by the very possession of beauty that reflect the beauty of God when it is integrated in a full sense with love and the very meaning of life, with the necessary balance between objectivity, necessity, and culture. That open up real horizons of application that the greater they are, they more require responsibility on our part, scientifically, medically, psychologically, and especially anthropologically, ethically, and morally. Therefore, thinking about the surgeons as a person and the responsibility entailed by the gift that you receive, the pontiff goes on. Real relationship and responsibilities bind the surgeon as a man to God and his laws, as a professional to society, to just member he devote his work, his conscience as a man and as a professional must consequently inspire him in his resolution and acts, even before beneficent hand is laid upon the body to bring them the change suggested by science and technology. This responsibility, which stems from what each patient in the exercise of their freedom put into your hands at all times, is to seek the good by confronting your own conscience, which, when it is upright and firm, always speak the truth. A good, which does not have beauty as the direct object, but rather goodness. Thus is in the legitimate search for what is the beautiful, life emerge as a higher reality, which is the fundamental good entrusted to you by each person. This brings us back to the fundamental role of ethics, which must accompany all your actions. Human behavior is rooted in the reality of the human person, combining the subjectivity of intention with the objective contents of reality, and also the consequence of action taken. Thus, the goodness of the human act is verified not only with whether an act is well executed in its materiality, but also by its intentions, goals, purpose, consequences, and risk. The whole process in each of its parts is to be characterized by ethical principles. Since Hippocrates, ethics in medical practice has been based on 6 ethical principles: to serve, to preserve life, to alleviate suffering, to do not harm, to tell the patient the truth, to respect patient autonomy, and to treat patient fairly. This general principle find their concretization and development in 4 principles universally adopted in the study and analysis of the ethic medicine technology relationship: autonomy, beneficence, not maleficence, and justice. It is therefore necessary to verify the intention and goal for every action. It is necessary that the purposes and consequences, as well as the procedures and methods, conform to ethical parameters that respect human being and life. In this sense, nothing and no one can justify a beauty that endangers a person's dignity, much less his or her life, when it is put at risk in a known and above all avoidable way. Ethics must establish the limits within which medicine, as a science and technique applied to life, health, and quality of life, respond to this goal without damaging, undermining, jeopardizing, or betraying them in an unconditional pursuit of achieving some goals. Not everything that can be done must be done. That is the key principle, because fairly, the end never does not justify the means. And secondly, the unconditionality of action inevitably leads to counterbalancing goals. This can be verified by the lack of limit controlling entropy and the various scientific factors, errors in theories of application, and extra scientific factors to which science and scientists are also subject: political, economic, personal interest, and so on. Therefore, the basic element of ethical analysis are those related to intention, why, the goal of purpose, for what, the object, to whom or what, the means, how, and the consequences, short, medium, and long term. Thus, ethical values and norms provide science and technology with a solid anthropological framework, because all human action, especially when they concern life and health, and thus love and happiness of people, take place within anthropological vision that responds to the vision of the person, to the meaning and value of his or her life. In conclusion, I would like to propose a criterion of discernment that rarely prove wrong. When you have to find a solution to a problem, imagine that it concerns the person you love the most. There you will know, in your own intimacy, in the silence of your conscience, with the judgment of the great love, how much and when the beauty is also true and good. I would like to end with the same concluding words of the above-mentioned speech of PD12. Always be aware that your mission can and must go beyond tissues and forms, all the way to the soul, just inner beauty you will teach people to appreciate. Thank you.
Thank you very much, Monsignor. Very nice, interesting introduction. Now,
I think at this point, we'll move on with the formal part of the session. So the first presentation will be by Dr. Fritschen, and he's going to be speaking about the best registry to get valuable data for evidence.
Yes, thank you. Good morning, everybody, and thanks for the invitation. I was asked to comment on the best registry possible to get more evidence and the reason for we've just heard in this nice presentation. Now, whenever we talk about medicine and the best, I get a bit reluctant, so I think we can be happy when we get an effective registry. And if you want to set up a registry, these are the two simple questions you have to answer yourself. What you're aiming at, and why did almost everybody failed who tried before you? Now, the aims, I think, are pretty easy to identify. We want a earlier detection of device flaws before thousands of women get all these implants implanted. We want statistically sound data. We want a trace mechanism, and apparently all this under data protection as good as possible. And a couple of these answers are easy. We have to turn the passive vigilance in the European Union to a more active vigilance. And this involves inclusion of clinical aspects, because device performance is not only dependent on the implant itself. And this is difficult because we have to set up a hybrid registry. And this is really a high demand in the technical preparation. When it comes to statistically sound data, we need longitudinal data independent of the provider. We need a denominator, which means all the implant included, the entire amount. We need a high capture rate, and we need a large national data pool. And apparently for track and trace, you need up-to-date contact data, which is difficult in terms of data protection. Now that sounds easy, but when we sit down and plan it, it proves not to be easy. So implant details are usually not included in the barcode, so it's difficult to get hold of them. The clinical aspects, it's important to figure out which are actually relevant, and it's very important to get a clear data definition, which proved to be really difficult. Long-term data require a national identifier, and this is an issue with data privacy issues. Inclusion rate is very difficult to assure. The sales data, an implant, a sold implant doesn't necessarily mean it's implanted. Data quality and ownership is an issue, and who keeps up the contact data for track and trace functions. Now, the first question I will address a bit later, and the main reasons for others to fail, actually almost all national registries. The major thing was funding. There's only 2 registries more or less fairly funded, and everybody else actually failed due to missing long-term funding. The next thing is inclusion rate. But even if you get a good opt-out or mandatory registry, you still have to verify adherence. And if you find it, what do? Do you have any sanction? Data quality, who is doing this? This is really expensive if you really want to do it. So you have to find a solution for that. Now, when we looked out for solutions, we found that almost all other scientific societies had the same problems. And so we sat down and first identified the points that I just pointed out to you. Then we went through all the studies and found there is not a single one with statistically sound data. And especially it was not possible to pool these data to get a large data pool. And so what we did, we sat down and first decided on a minimal data set. You need to ask for clinical data if you want to get sound data. And then we sat down and try to find data definition. So what do we mean when we say malposition? And this sounds easy, but it's not. It took us almost 5 years until we all came up with the same definition. And this is all published, so you can, it saves you a lot of time if you just adhere to those, but it is more difficult than you would think. Capture rate. We heard about the Dutch registry, and they started off with an opt-in solution. All implant registries who went for an opt-in function, they all failed. So it has to be at least opt-out or mandatory. And the first one, the old Dutch system had an opt-in inclusion rate of 3.4%, and then they switched to opt-out and reach around this. This is what they claim, but they even say we are not really certain in revision cases, which is actually the cases we are actually interested in and not in the inclusion cases. So when we present this to our authorities, they say, okay, we're not going to engage in this kind of ambiguous thing. We go mandatory. So in Germany, who has to report? It's all patients and all health providers. And this is independent from the finances. Everybody has to deliver the data. One important thing is we try to find a fair balance between individual rights and the interest of the society. And we put a lot of time and effort in it, but finally we came up that we split up the person identifying data from procedure relating data. And they are strictly separated and independent in physical, organizational, technical, and personal terms. So nobody always gets the name of a patient plus the procedure involved. And this apparently involves a lot of communication between all the stakeholders, and it's even more complicated for the health provider. And this is apparently awful, but this is the good message. This is all automated in the background. In seconds, this is done by the background system. And I don't want to, get too much in the details. If you want to read it, how we do it, and what we decided, it's all published. Just a couple points to mention if you consider. How do we assure adherence? Data sparsity proved to be a key. If patients and surgeons don't want to spend a lot of time on it, so it has to be a short inclusion. And you see, it's about 2 minutes you need to enter the data. We try to automate it, so every information that is already included in the hospital information system can be transferred, and we try to enable scan mode. Now, scanning is a nice thing, but this was a bit of a disappointment because all the information we need are not included in the barcodes. So we had to invent a product library. So every manufacturer who wants to sell an implant in Germany has to render all the details in this library, and we can only scan it, and then the registry just transfers the information, so you don't have to enter all the details of your implant. Track and trace was tricky. We don't have an unambiguous identifier in Germany. This is not in keeping with German privacy laws, so they had to change the law. The next thing is, how do we keep up the data? So the Australians tried to do it by the patient, but this was incredibly unreliable. They had no means to contact the data. So we refer to our health system because it's mandatory in Germany, almost covering 99% of our population, and they apparently do have the actual contact. So that proved to be easy, even though some patients find it a bit reluctant that the insurer is informed that there is a implant-related procedure performed. Inclusion rate. This is apparently a big problem. You heard about it, and we thought long what would be a strong motivation, and we found it pretty easy. It's money. So if someone does not include his details, so the surgeon, he loses the right to invoice the entire procedure. So I think this is a strong motivation. And funding is just the same thing. The Ministry of Health was ready to pay the setup, but for the running cost, they say, okay, everybody who is interested in sound data should contribute. And so there's a price list coming up every year. And so everybody who wants to do either studies or whatever, the manufacturer, everybody has to contribute to the costs in the long run. So wrapping it up, if you want to set up a registry, we think, first of all, make sure you got the finances. It's a lot more expensive than you think. And you have to have it sufficiently stuffed. And we've just heard about the Netherlands. They have a pretty good system running, but it's actually depending on a handful of people. And Sweden is even worse. It's usually one person who does all the work. It has to be at least opt-out, but even then you need an identifier. How do you find someone who is not compliant, and what do you do if you know it? So in the Netherlands, they get usually compelled out of the society, but this doesn't address the root of the problem. How do you get longitudinal data? So how do you make sure that if the patient goes to someone else, is still captured in your registry? Hybrid data definition is vital. I told you we need 5 years to come up with a mutual idea. Denominator is very difficult to track. And track and trace, I told you. And all this should be independent from industry. They had this in Australia, where it was heavily funded by the industry. Then bad news came up, and the funding was withdrawn, and then they had no funding anymore and had to close down the old one. So these are things that might help you. It's published. You can easily find it or contact us. It's mandatory in Germany, but the sanctions start in 2 months, and we hope that we can add some more better data for the future. Thank you.
I want to make 2 points. One is that in principle, nobody is against registries. Your problem is not opposition, your problem is apathy. And therefore you must make it mandatory or it will fail. And so I really appreciate that point that you made. The second point, and I think that this is a real challenge, is if you ask most people in the United States, do you participate in a registry? They would say yes, because they confuse registration with registry, which are two totally different things. Registration is just sending the serial numbers to the manufacturer. I saw a couple weeks ago a president of a society stand up and say, it doesn't matter which registry you use, all the societies have an app, even the manufacturers have an app, and it's so easy to participate in a registry. That is not a registry, that is a registration. And we need to separate and make that demarcation, because it stops people from participating in a registry when they think that they already are, and they're not. This is a proactive approach to monitoring outcomes. It's so much more complicated, and it is and we need to be very clear on our definitions.
Absolutely. The thing is, in America, I mean, there seem to be two society who don't, talk a lot to each other, and they have two different means. Then I don't see why manufacturers could get hold on personal identifying data. I don't see why that's useful. And the thing is, if only the one producer gets the data, how do you ascertain longitudinal follow-up? That's just impossible. And this is shown by the FDA studies. They are heavily funded, and they couldn't agree on so mentor. If you say, what is malposition? One say malposition is rotation, malposition, whatever, and flipping over. And the others, they defined it. And some said, okay, tubular breast is reconstructive. And the others say, no, is still aesthetic. So it's a mix-up. And then they come up with their figures and say, we're doing a lot better. But you just can't compare it. You can't blame it. It's never meant to be. It's not a comparable device study. It's just to prove this one implant is safe. But as you said, this is worthless for us.
Thank you, Uwe. Like Germany and the NHS in the UK has unique identifier numbers for every single patient, so it makes track and trace potentially possible. But what you haven't covered is cosmetic tourism, which is a huge problem. And we're seeing thousands of patients from the UK traveling elsewhere for surgery because of cost. And how do we deal with that? Have you thought about this?
Yeah, we cover them, we include them, but apparently we can't track them. So we tell them, sorry, you're in our system. It will be published apparently, but we can't track you personally. And the UK is a bit of a problem because they have a mandatory system, but actually it's only sort of medium mandatory in England. Wales didn't even start in. And the Irish just contacted me and said, oh, maybe we should sort of get a bit better. What can we do? So it's half mandatory, I would say. Yeah.
I have a very quick question. Thank you very much for your presentation. It's outstanding. We have noticed a problem with breast implant registry, that it's not possible to register an explantation itself, only if a replantation. That risk to miss so many important information for the next 10 years until we don't get rid of the previous. And still after that, if a patient wants to remove the implant for any reason, we cannot register. What was the problem and why?
No, we do it.
You can do that.
No,
that's very good, because we can't in Italy.
It's not an implant. It's every implant-related procedure.
Okay, that's very good. Yeah. We cannot in Italy. Yeah. Thank you. We can? I can find on the registry. It's impossible to get it. Where? Please explain.
It's impossible here.
Sure. Okay, we will find out.
Please.
Just one short remark. Thanks a lot for your hard work you put into this registry. Actually, I'm very happy that it will come. I only have a little remark, and this was really a a big trouble for the whole community, because 80% of all the procedures are performed in private clinics in Germany, at least the primary aesthetic augmentations. And the registry, you build the whole registry on the public healthcare system. So it means all of the private clinics have to buy new hardware, new software to be able to participate in this registry. And this is actually a very big problem for us, and it's really a bad thing for the whole registry, because now we have a lot of people who are really angry and really have big problems. And still today, I mean, I have a private practice and I'm really willing to participate, but I don't know which software, which hardware to buy, because the next information we get will only be at the end of April. And this is really a very, very big mistake. And I want to warn every country who's trying to establish a registry to do such a mistake again.
Well, just a short comment. I don't think it's a mistake. First of all, I hear it a lot. And the thing is, everybody wants sound data, but please, not me involved. Yeah, do studies, do whatever I want. I don't want to contribute. And that doesn't work. And it's true, it's 80% covered in private clinics. And yes, if we want sound data, this is what we have to do. And I think we have a responsibility for our patients. I mean, we implant implants in 60 years. We couldn't answer a single question on sound data, nothing. We don't know nothing. And this is not acceptable. And the German Society published, where do you get the hardware? You pay about 2,000 euros, which is not all that much. And this is a law since 2020. So it's 4 years back, a lot of time to get
no,
things.
I don't say
we are
later.
No.
Thank
Please,
you. Thank you. We'd like to move on with Dr. Rocco, who's going to talk about, is there enough evidence on BIA-LCL? Thank you, Dr. Rocco.
Thank you. Thank you for your kind introduction. Thank you to Professor Santanelli and Professor Clemens for your invitation. I'm very honored to be here. So the question is there enough evidence on BIA-LCL? Well, I have no conflicts of interest to disclose, apart the fact that I'm not a plastic surgeon. I'm a breast surgical oncologist. Anyway, these are some numbers on BIA-LCL. We know from the BIA-LCL global networks that we have 1,344 known cases of BIA-LCL. And 59 deaths across 46 countries worldwide as January 2023. And from the FDA as June 2023, the FDA received a total of 1,264 US and global medical device reports, including 63 deaths. And the American Society of Plastic Surgeons, the Plastic Surgery Foundation, and the FDA Profile Registry, with the last update, reported on 330 cases of BIA-LCL in the US. Anyway, and we will have also the data from the European BIA-LCL task force in the afternoon. So some data on epidemiology, even if we will have a session after these on it. So we know that the currently estimated US BIA-LCL prevalence is 10.6 per 100,000 patients. That is 1 in 9,400 patients with implants. This is the last calculation of the prevalence from the paper from Professor Santanelli. And how to reach this number, the US numerator was obtained by averaging the FDA database and the Plastic Surgery Foundation Profile Registry, while the denominator was estimated for chest X-rays and included female transgender individuals as well. Anyway, we know that the US National Institutes of Health, the National Institute for Health and Office of Rare Disease Research, defines a disease as rare as if it affects less than 1 in 1,500 people. And the European Union defines rare disease as those affecting less than 1 in 2,000 people. if we, from the paper from Professor Santanelli, if we calculate prevalence and risk in patients with textured devices only, the textured prevalence rises to 109.4 cases for 100,000 individuals, with a risk of 1 out of 900 patients with textured implants. Anyway, from the literature, we can see that there is a wide range of prevalence reported, ranging from 0.2 to per 100,000 individuals, up to 282 in the work by Professor Cordeiro. That is a risk estimate ranging from 1 out of 354 Allergan implants to 1 out of 500,000 implants. So very wide ranges and very low evidence from the literature. Well, and we also know from the literature that a rare disease is defined as any disease that affects fewer than 200,000 individuals in the United States. Anyway, so we can understand that most of rare diseases are poorly understood with unclear underlying biological mechanism. And this gap, this knowledge gap, leads to some challenges, both for patients, clinicians, and investigators. Patients affected by rare disease can experience a lack of available treatments, and clinicians have limited clinical knowledge and experience and limited experience, and this could impede their clinical decision making. And also investigators can struggle because they had limited patient data and sparse funding for research. So it's also really difficult to have adequately powered studies for rare disease because we have difficulties in participants' recruitments. And also there could be barriers to guideline development for rare disease, spanning from evidence appraisal and synthesis to issuing recommendation for care. So guideline developers may be unable to generate strong recommendation for diagnosis and treatment of rare disease due to the lack of high certainty evidence. So guideline users may find guidelines conditional recommendations which have a little evidentiary base. In this, so if the question is there enough evidence on BIA ALCL? Well, I can say that we have the best obtainable evidence for a rare disease, and we should commend any effort toward reaching evidence on ALCL. But it's obviously difficult to obtain very good evidence. And how to overcome these barriers in research and guideline development for rare registries? You know that there is the Rare Best Practice Working Group, that is a project funded by the European Commission with the aim, with the focus of sharing best practices and methodological knowledge in the clinical management of rare disease. And they say that registries could be an answer, could be an option. We all know this. The previous speaker already talked about registries. Anyway, we know that patient registries can be used to supplement the published literature for questions where scanned data are available. Registries can give a snapshot of the impact on the natural history of disease and the variety and also the effects of treatments that are used. Registries can prospectively capture patient information. So a robust registry, with all the difficulties that you already discussed before, can also be equivalent to a high-quality observational study. So all the efforts done by the ASPS Plastic Surgery Foundation are absolutely commendable. We know about the profile registry that will increase our knowledge on BIA-LCL and now also on BIA squamous cell carcinoma. And we also commend the work by all the registries across the world, across Europe, also the one from the national, from our Ministry of Health here in Italy. And also commendable are the efforts toward establishing guidelines. We know that in 2019, the NCCN established evidence-based consensus guidelines for diagnosis and treatment of BIA-ALCL. And these guidelines were subsequently recognized by the FDA and all international plastic surgical society to help physicians to understand the disease and provide a reliable diagnosis and reliable treatment. And we also had very few months ago the publication of an updated evidence-based consensus conference statement from the American Society of Plastic Surgeons, as the panorama is rapidly evolving. So again, is there enough evidence on ALCL? Well, I can say that there is absence of high quality, high level of evidence to inform our understanding of the etiology, of the risk, and of the therapeutic and prophylactic approaches and outcomes of BILCL. And I will share with you some evidence on some particular aspects that still remain debated. The etiopathogenesis. Well, we know that several assumptions have been proposed, but the mechanisms that nowadays underpin BIALCL are not well understood yet. Current hypothesis goes from genetic drivers to chronic inflammation, and chronic inflammation can result either from bacterial contamination, shell shedding of particulates, shell surface characteristics leading to friction, or also implant-associated reactive compounds. Anyway, the common underlying mechanism is the development of a chronic inflammation that may lead the activation of the JAK-STAT pathway, which will lead to lymphomagenesis. These are the conclusion by the SHEAR committee in, sorry, can we go back to the, okay, yes. From the SHEAR Committee on Health, Emerging and Environmental Risk from the European Commission. And a very recent paper also concluded that current evidence is inadequate to link bacterial etiology as a central factor in the development of BIALCL. Anyway, the limitation of the existing literature prevent a complete dismissal of the role of biofilms in the pathogenesis of this disease. Anyway, the authors concluded that the use of antiseptic and antimicrobial agents during the implant insertion did not demonstrate any impact on reducing or altering the risk of developing ALCL. What about genetic predisposition? Well, we know that some studies identified some mutations, somatic mutation, mainly in the genes of the JAK-STAT pathway, as well in TP53, the DNA methyltransferase 3A, and also in AL, human leukocyte antigen, HLA, can increase the risk for the development of BALCL, as described also in other forms of lymphoma. At the moment, broad genetic testings beyond clinical trials are not recommended, but however, the further identification of markers may provide future indication for genetic testing, and also genetic markers may have, apart from a prognostic value, may implicate future therapeutic targets. Anyway, evidence remains limited on the prognostic value of genetic testing in this disease. This is a very debated issue. We will talk about it. What about implant texturization? Well, the SHEAR reported that there is a moderate weight evidence to support a causal relationship between textured breast implants and ALCL. But we should admit that so far there have been no known cases with smooth implant history alone, even though we know that the full implant history is unknown in a proportion of cases that is significantly variable with regards to, and that there is also a variability in the nomenclature and the texturing classification system used. Anyway, what about the last report and the last consensus statement? The authors conclude that the currently available evidence is sufficient to determine that the association of textured breast implants with ALCL does meet the definition of causation based on Bradford-Hill criteria. So the use of microtextured breast implants should be discontinued, while no change in the use of smooth surface implants should be warranted. Anyway, I will go to the conclusion. Also, low evidence for treatment outcomes. We know that ALCL is generally an indolent and localized disease with an excellent prognosis when patient receives surgical excision, and an en-bloc capsulectomy with explantation, resection of all associated masses and involved lymph nodes is the treatment advised for ALCL. What about reconstructive surgery? I'm sorry to be late with my talk, so I will go directly to the conclusions. We know that there is also a paucity of data on the optimal timing and mode of reconstruction, to use or not to use a smooth implant for reconstruction in patients who already have a BALCL. Also, for adjuvant treatments, we do not have prospective trials to guide the management of patients with disseminated disease, but anyway, adjuvant treatments should be used for patients with advanced disease. And this is a very important element for rare disease, the indirect evidence. So the use of evidence coming from other more common disease. That is, for example, the adjuvant treatments used for other forms of peripheral T-cell lymphoma. I will go to I'm sorry to shift this. Anyway, so reporting of new BA-ALCL cases by National Cancer Registry is critically important to obtain a better estimate of the risk of ALCL for understanding the etiology, the pathogenesis, the genetic drivers, the clinical behavior, and the best therapeutic and prophylactic approach. And accurate patient information and preemptive notification of the risk of developing BALCL is recommended for all patients with breast implants. Thank you, and sorry for being long.
Any question for the audience?
Let me start by asking a question, Nicola. I enjoyed your presentation, but what do we know about the difference in the inflammatory response between a textured and a smooth implant? Given that, you know, bacteria, biofilms, genetics, they all may have a role, but we don't know for sure. Those factors are common to smooth and textured. So what's different about that inflammatory response with a textured device that may lead to ALCL?
This is a very good question. Yes, I think that the point is that silicon is not an inert material. So there is an evidence-based, there is literature on it that silicon and all the compounds linked to the production of PMDS, the polymethyl dioxanone, are associated to an inflammatory response, to a stimulation of response. And BIA-ALCL is not the only effect of the stimulation of the immune system, both B cells and T cells from silicon. So at the moment, in my opinion, we do not know the difference in the stimulation of the immune system by textured and smooth implants. We know that there are only textured implants associated with ALCL, but we do not know why. This is the lack of evidence we have. We do not know why, and this will be the aim of our future studies.
Fabio? Thank you. You just finished to say that what we know is that it's only associated to textured device.
Yeah.
So why do you calculate it? It's, I mean, the calculation using as an active population, only the textured population, it gives a figure of a risk of 1 in 900.
Yeah.
And 1 in 900 is definitely less than 1 in 2000. Why do you continue to call it rare? It's not rare, it's uncommon.
No, I understand your point. Anyway, we have a very wide range of determination of prevalence. I know that the last one is the one
talking about risk, not about prevalence.
Yes, talking about risk. We know from your paper that there is 1 out of 900 that it becomes a rare disease. But we also know that a rare disease is a disease for which we have less than 200,000 cases. And we have less than 200,000 cases all around the world. So we can call it uncommon. Anyway, I would call it rare disease, according to the National Institute of Health.
Depends on which way you look at the problem. I would continue to call it uncommon. I'm totally against to call it rare, and I totally disagree because the actual epidemiology says totally different. I reported 1 in 900 because I didn't want to report 1 in 300. This was by other colleagues. But you know, the problem is the way you accurately check the patient and your population. Because if you spread this calculation all around the world, including Namibia or other countries that do not use implant, of course we don't have it. But if you see series of patients and follow-ups from centers of high standard quality, and you have a risk which is lower, we have to stop calling rare. We have to call it uncommon. That's my opinion. So,
no, I agree. For sure, underdiagnosis could be a reason for reduced risk in some population, but anyway, we will wait for some more data. So,
a short comment also. I understand that the title probably there is not enough evidence. It's a little bit broad.
Yeah.
I agree, we don't have enough evidence on the etiology. We have enormous evidence on the epidemiology. So to compare, if you come back and find someone killed on the floor here, you don't know who killed the guy. That is enough to say that it is not dead. We have a dead. It doesn't matter who killed him. We have it. We cannot cancel it. That's the point.
Yeah. No. In fact,
Thank you for the interesting presentation. Beyond the textured or smooth implant, are there any data about the polyurethane implant and the association with the ILCL?
Yes. Yeah, no, there are data.
Polyurethane is the same.
There are data on polyurethane. There are some cases reported, but not with Polytech polyurethane, but some other old polyurethane implants from other companies. Anyway, yes, there is also a risk associated, but anyway, textured implants are the implants that are mostly associated to the development of ALCL. Anyway.
Okay. Many thanks, Nicola.
Thank you.
Keep going. Keep going. And pleasure to introduce you, the next speaker, Fabio Santanelli. Please, Fabio, take the floor.
Thank you. And let's try to possibly save anything. So we'll decode the BLCL development through risk factors with a case control study. These are my disclosure. Okay. So I want to start with acknowledgement. Usually you acknowledge your collaborator, but I will take it differently and acknowledge my opponents that supported my will to achieve this outcome that I'm going to show you now, according to Gospels. We started from negationism with the interesting theory of the Emmental cheese slides from De Vita, who said that it's just a matter of protagonism, superficiality, mystification, and competition. BLCL doesn't exist. That was the conclusion. Then we moved to spontaneous regression and resolution. BLCL is not a cancer. It resolved by itself. And then we moved to the micromore. It's so rare that it's more common to get killed by a lightning than by BLCL. Thanks God, we moved slowly into other theories, including bacterial contamination. That is, the problem is the surgeon and not the device itself. We moved to weak evidence with the biofilm theory, which has been more or less totally dismissed. Even the author of this theory, they do not work anymore on the theory itself. Genetic predisposition showed very limited evidence. Of course, there are some genetic significant mutation, but they are not responsible for the disease itself. And the particulate theory, there are no evidence as well, particulate theory. And what is left about all this etiological theory, and you will see in next further presentation by Dr. Pitenis and Dr. Sorotos, is the tribology, is the only left possible cause for BLCL. Then in the moderate evidence, we moved a little bit up, and the share committee gave a final opinion about the safety of breast implant, and they could demonstrate a causal relationship between textured breast implant, all textured breast implant, and ALCL. The moderate level is justified by the fact that in literature at that time, which was 2019, it took 1.5 years to do the consensus and to investigate 800 papers. There was only case report of serious and retrospective epidemiological studies of small cohorts, mainly in reconstruction, still enough to state a moderate evidence. Still, a moderate evidence, it can be found in this research that we did on 248 cases extracted with implant replacement is a protective factor against BLCL. That was the first time. If you replace the implant, you reduce incidence rate, you reduce you prolong the event-free time, and you reduce the risk of having BLCL. The other statement was that the use of textured implant, because it's the onset of the disease is earlier in those patients with kind of genetic problem like the BRCA1, 2, and TP53, they have an enormously earlier onset of the disease. It's wise not to use it. Thanks God we are not alone, but we have someone else, different groups, independent, that just demonstrated the same. Vittorietti. Another group did the same study. He didn't know about my study, that was just a little bit before, and they could demonstrate exactly the same. Other group of patients, other study, different from mine, implant replacement significantly reduced BLCL risk. And these are evident, statistically evident. Then the APS produced an expert consensus panel on BLCL, and the level of evidence is still between 3 or 4. And they stated that use of microtexture implants should be dismissed. No more microtexture use to be in our patient. And asymptomatic patient, this is the first time that the consensus of scientists stated altogether that asymptomatic patients with microtexture implant have a relative indication to prophylactic explantation. So they started to talk about to prevent the disease by prophylactic explantation. Relative means not mandatory. So you can get into a mandatory breast implant registry or not. You can remove the implant or not. That's just a choice that should be shared between surgeon and patient, explaining risk and benefit of the procedure. Immediately, the FDA made an immediate release. And if you don't stop yourself at the first sentence, because that's the main mistake, everybody read, oh, prophylactic removal of textured implant is not recommended in a asymptomatic patient. That's what the FDA stated. Yes, of course. But go a little bit further, and then you notice, however, individual patients should discuss possible benefit and risk of removal. The FDA recognized that there are benefits in removal in some patients. It means patient risk stratification. This is what the ASPS, of course, stated against also, and the society said that they believe that to demonstrate a risk reduction, what was stated by the other previously, or a protective effect of explantation, the analysis would need to include controls with or without BLCL, so a control group to provide a risk ratio. So thank you very much for the assist, I would say, to the ASPS, because since quite a long time, we were arranging that study, which is a level of evidence to the highest possible level of evidence that you can ever imagine to have in this BLCL issue. So we did an age-adjusted case control study. It's a prospective study, 1 to 4 on 89 BLCL cases and 306 control cases. All patients had at least one exposition to texture implant of roughness higher than 10 millimicron, according to ISO N18. And we studied 80 variables, clinical, demographic, and lifestyle. Then we did an analysis, statistical analysis by conditional logistic regression to estimate odds ratio, exactly what the SPS asked for, and impact on BLCL incidence. So it's interesting because we started to have important risk factors. First of all, there is no association with any manufacturer. So it doesn't mean that Allergan is more guilty than anybody else. There is no statistical association on level evidence too. What is interesting is that compared to macrotexture surface, polyurethane and microtexture surface experience 13 and 11 times higher odds for BLCL. That shocked me because we were used to read only the data reported by, per se by the authorities or on papers, but not a real level to evidence statistic. Then it was very interesting that BMI is strongly associated to a higher likelihood of BLCL, and the volume of implant too is associated. So per 100 cc, you have an odd ratio of 1.2. Autoimmune disease, that's a risk factors, can be associated to 2 times higher odds compared to patients that not having autoimmune disease. And also Hashimoto thyroiditis is associated to 2.5 higher odds. So is there an important predisposition in some patient with autoimmune dysregulation? Then we have some protective factors, that's the good news. There is no association found between current smoking habits, smoker or no smoking, there is no difference. You can keep smoking, but if you stop smoking, you have 55% less likely to have BLCL. So there is a protective action of stop smoking. Post-oncologic patients were less likely to have BLCL compared to aesthetic. This is something that is finally stating that what we thought before that was wrong of Peter Cordero, because his cases was mainly oncologic patient. That's not true. We have demonstrated in the series of 1,500 with Kolasinski that the incidence in cosmetic was exactly higher, slightly higher than the Cordero one. Now we can demonstrate that the post-oncologic, it's even protective factor. As protective is the history of radiotherapy, chemotherapy, hormone therapy, which showed respectively 69, 88, and 91 lower odds. So Explant is associated to 87 lower likelihood of having BLCL. Replacement was associated to 43% lower odds. First replacement with the textured breast implant show 5.17 times higher odds if you replace with a smooth. And the second replacement of an implant with the texture compared to a smooth is associated to 5.505 times higher odds. So it looks wise to replace with the smooth. So as a first, with this study, we could confirm that there are no BLCL cases with history of only smooth implant with the roughness lower than 10 micromillimeter. That we could first demonstrate that BLCL occur more likely with higher BMI, with higher implant volume in autoimmune and comorbid disease patients. In cosmetic indication, BLCL less likely occurs with explant or implant replacement in post-oncologic patient, in patient with chemotherapy, history of radiotherapy, history of hormone therapy, and after smoking abstention. And this is a level of evidence too. Just a thought about capsulectomy. That was stated by the NCCN guideline recently, prophylactic explantation of texturing-based no routinely recommended. So I want to ask you, if you have an asymptomatic patient with texture implant that require a risk-reducing explantation or replacement with smooth implants, what would you do? Or also in case of any indication that you have to take a patient to the OR and replace an implant for any other reason, what would you do? Would you perform an intact capsulectomy or not? And if you don't perform the entire capsulectomy and your patient end up with the BLCL, would you feel comfortable with liability for not doing it? Thank you for your attention.
Any question for the audience? Okay, Fabio. Very nice presentation. I agree completely with you. Would you like to?
No question, thank you.
Okay, our next speaker is going to be the start of the point counterpoint session. Why total capsulectomy is not always appropriate when replacing macro-textured implants.
Sorry, a moment. I would like to ask for the audience another question. How many surgeons in this room, if have to perform a secondary surgery, breast surgery with macrotextured implant, perform total capsulectomy? Raise your hand. Okay. How many not? Too much people. Okay. Why, Pietro?
Yes.
May I take 30 seconds? Less, 15 seconds? Okay. Okay. Do you mind to repeat what you told me right now?
What, that we have evidence for.
Yes, thank you very much.
Symptomatic patients.
Thank you.
Pietro.
Okay. Thanks, Fabio. Thanks, Max, for the invitation. I shall focus on how to treat the capsule when removed macrotextured implants in asymptomatic patient with a capsule which is not calcific, shows no siliconomas and no masses. So going directly to the point, how should you manage the capsule, with capsuloplasty or capsulectomy? My first question is, can capsular tissue be profitably used? To answer this question, we have to go back to see what kind of capsular alteration we see today. As I mentioned this morning, it's completely different condition than what was seen when the Baker classification was devised. Today, we rarely see concentrical spherical capsular contracture, and we most often see an area of capsular fibrosis coexisting with area of capsular laxity in the absence of firmness. Or we see fibrotic bands, which is a partial capsular fibrosis, shifting the implant to the opposite side. And also the data shown by one of the main manufacturers show that spherical contracture is very rare, but reoperation are not uncommon. So something different is happening, and we have to understand the changes in the capsule in order to devise an algorithm for correction. So this is what I call the capsuloplasty. So the capsule can be released by capsular scoring, where it is an elastic. It can be tightened by capsulography, or the pocket can be enlarged by capsulotomies. So these are the maneuvers that I perform. Circular capsulotomy is mandatory, and then the other maneuver. So it's a kind of strategy of release and tighten to change that bad condition into a normal symmetrical one. Let's go to analyze in a single patient what to do. On the right side, I had to do a lower capsulography together with a capsular release in the external portion of the prosthesis, while on the left side, a very extended lower capsulography together with a medial and lateral release. And this allowed to change that horrible asymmetrical situation in a more harmonic condition. So on the right side, in this case, I needed a vertical tissue gain. So it was an horizontal scoring, changing the appearance of the breast, while on the other side, I needed a horizontal tissue gain, and this was obtained by vertical scoring, changing that asymmetrical position situation in this symmetrical one. And in this case, the main maneuver was a capsulography in order to reposition the implants. And all these maneuvers were done together in a condition so difficult and asymmetrical like this one, obtaining a harmonious appearance of both breasts. In a reconstructive patient, the problem of capsulectomy is even more important. How could I remove completely the capsule in this condition? She had implant exposure caused by exposure of synthetic mesh, and when I removed the mesh, only a very thin layer of the nuded dermis remained, so I had to use two flap from the posterior, the parietal capsule, to cover the implant and to separate it from the skin. And this is a similar case. Again, a synthetic mesh exposure, removal of the vault of the capsule, and the use of the posterior capsule to cover the implant, obtaining healing. And how can we remove the capsule in patients like this? Radiated, thin skin. We can only use a capsuloplasty to obtain these results with minor operation, unless you, of course, wish to go to major operation with distant flaps. So conclusion number one is that the capsular tissue is a precious structure, and capsuloplasty is a modern, straightforward, reliable approach for correcting this kind of situation. So it is not associated, capsuloplasty, to a higher incidence of recurrence, as demonstrated by literature. Question number two, Are capsuloplasty and capsulectomy associated with the same complication rate? No. We know from a lot of papers that capsulectomy is associated with an increased risk of complications, with a lower level of outcome. And although this wide series of more than 3,000 patients did not take into consideration minor complications such as seroma or discomfort, the statement was that capsulectomy patients are more likely to have any complication. And this paper confirmed this with the hematomas, nerve injuries, bleeding, pneumothorax. And above all, the aesthetic outcome can be jeopardized by this maneuver, can increase adverse events, patient morbidity, cost of the operation, and impair final aesthetic outcome. So conclusion number 2, international literature show that capsulectomy is a more traumatic, complicated, higher cost, higher morbidity, less predictable outcome. Question number 3, I don't have an answer to this. Some consideration are necessary. Should the ALCL issue condition our choice, our approach? Well, in this paper, interesting paper published in PRS April 21, it was stated that at the current time, capsulectomy should be discouraged. 1 month later, the same journal, it is reasonable to consider a total capsulectomy. So how can we define prophylactic capsulectomy reasonable if it is associated with a higher incidence of complication? It is not advocated by guidelines, good practices, any official authorities, and has not been shown to mitigate any ALCL risk. So conclusion number 3, prophylactic capsulectomy is not supported, but rather discouraged by any governmental institution, no scientific society, no scientific evidence. Is the ALCL issue sufficient for changing our approach? Well, I think we have to resort to big number to answer this question. In Italy, we had, until 2 days ago, 111 cases with 2 deaths. But the implants sold were nearly 60,000 per year, and more than 50% were microtextured. And our Ministry of Health 2 days ago published this diagram showing that we had the peak of ALCL report in 2019, but this was a peak of 6.35 patients per 100,000 implanted women. That means that extrapolating this data with the number of microtextured implant, the rate should be 1 to 9,000 and between 1 to 9,000 and 1 to 21,000. So this is quite different from the number shown by some cluster, but I strongly believe that the personal series are less reliable than big numbers produced by Ministry of Health and public organization. So going back to definition, common or uncommon or rare. From the scientific point of view, the ALCL is a rare disease or very rare disease. So taking into account all the previous consideration, the incidence of ALCL patients implanted with microtextured implant in Italy is not a factor supporting the performance of prophylactic capsulectomies. If we go back to history and see what happened many years ago in the 90s with the first implant crisis, Hilton Becker stated that implant crisis has caused fear and panic in many unfortunate patients. Explantation is a relatively simple procedure, while the risk of capsulectomy may indeed outweigh the theoretical benefits. And we have a duty to help these patients from being exploited and encouraged to undergo expensive and complicated procedure. So I think this statement can be transferred to today. And I agree with Fabio that the option of capsulectomy should be discussed with all patients. But of course, the choice of the patients are conditioned by the approach that we give them. So everything is questionable, but this is my opinion. Thank you very much.
Prego, Fabio.
Thank you, Pietro. I appreciate very much your last words. This is your personal opinion. Yeah. What I showed is not my personal opinion. It's statistic evidence level 2, which is totally different. I don't want to get into the discussion about capsulectomy because it's quite difficult to discuss when I don't have scientific statistic evidence. So I don't talk about my opinion on capsulectomy. I want to talk only about evidence. So you said something which I totally disagree, that the data from an organization authority, it's more reliable than data from personal statistic. That it means that the data from Cordero are wrong.
No.
Cordero is less reliable than Ministry of Health. Okay, that's what you said.
No.
Yeah, you told it.
Fabio,
it's recorded.
it's
Wait a moment, let me complete.
No, let me first answer this question. The data from Cordero are of course reliable, but they are data collected in a single unit and can be conditioned by local factors. For example, one of the many factors, we put inside the pocket of the implant many substances that have not been considered or studied. For example, detergent, disinfectants, oily solution of antibiotics, oily, textiles, swabs, plastics, the drains. So are all these substances that we introduce in the pocket have been studied? No. So this can justify a difference between a local organization, a local unit, and the general number, the big number that we see in a nation. That's what I meant to say.
So if I can go back to my point and my question. Okay, this is opinion and still not an evidence, what you say. And this evidence, you say it's lower, the one from Cordero, compared to the authority. Now, coming back, there is a big bias and a big black hole in the report of the Italian Ministry of Authority. They don't disclose the way they calculated the denominator. First, they make a mistake to calculate on implant sales. Implant sales is the worst way to calculate an active population because implants are sold, replaced on the same patient. We are dealing about a disease on patient, not on a disease on number of implants. So the Ministry of Health do not disclose how they move from number of implants to number of patients. I want to know how was calculated the denominator. It is not disclosed on the paper. If you calculate the denominator, not on number of implants, on patients that have been bearing the texture implant only, then you can rely on statistic. This is, to me, is unreliable statistic because it's not clear.
Fabio, you are referring to the previous study of the Ministry of Health, but this diagram that I showed, and it was published on the website 2 days ago, take into consideration not only the number of implants sold, but also the statistics from the hospital, the number of the registry, and other factors that the statistician of the ministry have taken deeply into consideration with very complicated calculations. So it's not perfectly, probably we shall have a definitive number in many years. but it's really a reliable way of calculating as much as possible.
I understand, but it's too much time limited. I prefer 100 times more the Sloan-Kettering statistic.
Okay, that's your choice.
Much more, because we cannot calculate on few years. We started the implant registry recently, and BLCL mean outcome, mean onset is 9 years. So we are talking about something that no serious, any statistical professional would take a study like that. And apologize still, this is not published. So it's not peer review. It's only report from the ministry. Thank you very much, but this is not science. This is not literature. When it's going to be published on a peer-reviewed journal, I will take in consideration.
Okay, Fabio. Actually, the numbers I showed started from 2011, so it's a 13-year period. And anyway, I think the president of the session is asking to stop it. Yes, thank you.
Sorry, we'll have to finish this. Thank you. And we'll continue with the point counterpoint viewed, asking Dr. Campiglio why total capsulectomy is always appropriated. That should be fun.
Thank you, Fabio and Mark, for the invitation, and thank you, Fabio, for the topic that you gave me, because it's much easier to be defended than the one from Pietro. Anyway, since the introduction in the plastic surgery of the breast implant in the early 60s, we understood very well that the breast implant that we put in the body of our patient create a periprosthetic capsule, which is the normal evolution for any body inflammation reaction, and that isolate this breast implant from the rest of our organism. And as shown, very well shown by Pietro in the previous presentation, we can use this capsule in several ways in order to correct some problem that we can have in our patient. As you can see in this short video, I used a posterior wall capsular flap to treat an implant dislocation. But it is also true on the other side that this capsule can create aesthetic problems such as capsule contracture, as shown in this patient, or problem of dislocation when the capsule is not so firm and it's very soft and smooth. And we also know that we can have a problem of siliconomes due to the bleeding of gel through the shell that collect inside of our capsule. It is interesting also to see that even expander and saline implant can have the same find histologically. So probably there is a dispersion of small silicon particles from the surface of this device. And then, of course, we can have other kind of problem related to the capsule, such as ALCL, squamous cell carcinoma, and breast implant illness. And we have seen during these days when we can perform a capsulectomy, when we must perform a capsulotomy. This is an ideal case, as shown yesterday by Swanson, for a capsulotomy in order to relocate the position of an implant. And this maneuver, anyway, is not free from complication, as you can see in this case, where a bilateral inferior capsulotomy were complicated by bilateral dislocation of an implant, which required a capsulorrhaphy in a second phase. And also, it's very important that if we decide to perform a procedure on one side of the breast, we should do the same on the other side, because as you can see, the evolution in time can be very different, as seen in this patient. We have seen also that we have several types of capsulectomy. We can do a partial capsulectomy, a total capsulectomy, or en bloc capsulectomy. Capsulectomy in secondary cases should be always considered in the following situation. This is my opinion, of course: severe contractures, as in this case, that require a bilateral capsulectomy to have a nice aesthetic results. The replacement explantation of rupture implant, in my opinion, is also a very good indication for capsulectomy, because there is a lot of silicone inside of the capsule that can create siliconomes later in the patient. And very often this type of patient with rupture implant can require also a modification of the placement of the pocket of the implant. And finally, we go to the issue of this presentation, which is the behavior about the textured implant. We have already listened by Fabio that the share definitely in 2019 stated that there is a causal relationship between textured implant and BILCL due to the epidemiological results, that textured surface is responsible of this occurrence, and a limitation of the use of textured implant should be recommended. So finally, the conclusion of this study was that there is a moderate evidence of causal relationship between textured device and BILCL. And we have also seen in previous presentation the number that clearly relate that there is a direct link between texturization and BILCL, and I agree with Swanson when he said that probably it's time to amend the name from BILCL to textured implant associated anaplastic large cells lymphoma. And as we know that from the literature that in case of this kind of disease, the best treatment is the total capsulectomy, I think that in this patient is required to do a total capsulectomy and also to do an histological examination of the capsule. All the capsules should be sent to the pathologist, including the fluid if it is present. And of course, it is important to require all the immunohistological study on the capsule that you have removed. This is an example of patient treated for explantation in a macrotextured implant, and this is another patient where I also perform a breast reshaping after that I removed the macrotextured implant. We have seen that the data, at least at this moment, clearly show that there is no cases of BILCL in smooth implant. So in my opinion, I think that the capsule can be preserved only in case of revision of undamaged and smooth implant. If you have to reoperate patient with undamaged implant or that have smooth implant, you can safely use the capsule as shown by Pietro without any kind of problem and fear of BILCL. As shown, for example, in this patient with a smooth implant, she has a dislocation that I have treated with a capsulorrhaphy, with a NAMOC capsulorrhaphy. But these are the cases where I do not hesitate to use capsular flaps. This is the patient video. And what about the macrotextured capsulectomy? You can have a prepectoral capsulectomy that can be done incrementally, or you can remove in one piece of the capsule. And it's sometimes very easy because you can undermine all the capsule from the pectoralis major, and it is a very simple procedure. It does not take time, and I don't think that it had any kind of complication mentioned previously when the breast implant is located prepectorally. Sometimes, as I told you before, we also need to change the implant. And in this case, I think that it is very important to close the pocket where you have removed the capsule in order to prevent a dislocation of the implant from the subpectoral, new subpectoral pocket to the prepectoral pocket. And I do in this case with the 2 or 3 stitches from the inner surface of the gland to the pectoralis major once that I remove the capsule. And this has 2 advantages because it closes the dead space and also create a lift of the gland. This is a patient treated this way, so I changed the plane and I removed the capsule. She had a macrotextured implant and I closed the space prepectorally. You can have a different situation when the implant, the macrotextured implant, is behind the muscle, and this is the list of potential complications that you can have in this kind of situation. This is a short video just to show you how I do it. First, I usually undermine the capsule from the deep surface of the pectoralis major. This is often a very easy dissection. Then I move to the inferior pole of the implant, and I remove all the capsule. I understand that it is not always easy to remove all the capsule from the thoracic wall, but I think that it is very important at least to try and report on the operative chart that you try to do it, because it is very important from medical legal point of view. And often I also remove some silicone knobs that are very adherent to the rib. And again, I like to close the small dead space between the pectoralis major and the lower part of the gland, because I think that sometimes the muscle can retract upward and create some deformity, even if the pocket is under the pectoralis major. As you can see in this video, the finger indicates the pectoralis major sutured to the gland in order to create a unique pocket where I can put my implant. And at the end of the capsulectomy, this is the amount of capsule that you can remove safely from your patient. This is an example of patient where I also perform a mastopexy after I remove the capsule and the implant. So there is a problem when we decide to replace the implant, because very often we have to put a bigger implant than the one that was previously inside, even if the patient doesn't want to increase the size. Usually I think that it is about 100 cc more than the previous implant, because the pocket became very large. And so if you want to have the same size, you have to select an implant which is about 100 cc larger than the previous one. And this is an example of the patient where I remove the macrotextured implant, put under the pectoralis major, and I replace with a bigger implant in the same pocket. And again, another case. This is just to show you how it's important to prevent the immediate dislocation of the implant when you remove the capsule under the muscle. And I conclude my presentation telling you that the problem became more important when the patient wants a smaller implant, because in this case you have to reduce the size of the pocket. And I usually close the pocket with stitches that prevent the displacement of the implant or the collection of serum and fluid. And of course, you can do inferiorly or laterally. And I always add some external stitch, the same that I use for my facelift, that usually lasts for 2 or 3 days in order to support this internal reconstruction. So in conclusion, managing of a periprosthetic capsule is a fundamental in secondary surgery. Periprosthetic capsule isolate the implant from the rest of the body, stabilize the results, and limits the diffusion of silicone in case of rupture. The capsule, however, can complicate the aesthetic result and can be cause of serious disease linked to the presence of the breast implant. Some of these problems are not present at the moment of the revision, but can appear later, as clearly stated in this paper from Patricia McGarry and other colleagues. And I think that personally still have some doubts about the prophylactic capsulectomy in otherwise healthy patients, but I also think that can be a serious medical, legal, and also ethical program to reoperate a patient, for example, for capsular contracture or rupture, and do not prevent them with a total capsulectomy. Thank you very much.
Please.
Presentation. One remark and one tip. Remark: when we now there are about 40 million women around the world with the breast implants. And I am fan of prepectoral or subfascial augmentation. To all who place the implants under the muscle, I am giving one suggestion. Someone will have to remove the capsule, and what the challenging surgery it is to remove the capsule and undermine from the ribs. You present the complication rate. So how many patient has this kind of complication because in primary augmentation we place the implant under the muscle. So this is the remark. And one tip for the young doctors who maybe don't know how to avoid the problems or make it easier to prepare the capsule from the ribs. First, inject the saline with the epinephrine, and it is the hydrodissection, and it's much easier and safer to do it.
I agree. The fact that we still put the implant beneath the muscle is because not all the patients are good candidates for a prepectoral implant. That's a problem. I agree.
Okay. Please, Fabio.
Just one quick comment. Thank you very much for your presentation about the complication of the capsulectomy, the total capsulectomy. As correctly stated, Kolansinski, it depends if it's a pre or retropectoral. Anyway, the paper that talk about the statistical significance claimed that only bleeding is statistically significant. Otherwise, all the other complications are exactly the same of primary implantation. So we can suggest to put breast implant to patient, and we do not probably, not all of us tell that she can have a pneumothorax because she will not do breast augmentation. This is exactly the same incidence in revision as primary. The difference is bleeding, and the bleeding is more possible, that's an opinion, it's not statistic, we go out from statistic, more possible if you replace with the smooth implant, because if you put a smooth surface on a bleeding vessel, it doesn't stop. If you put a rough surface on a bleeding vessel, it stops. So we have a higher incidence of bleeding that we have to disclose to the patient when we suggest the procedure. Thank you.
Yes, I agree. This is the problem. And I add also that one of the complaints is also that the operation usually lasts much longer when you do a capsulectomy, which is clearly true. But I can tell you that I don't think that it is an important point, the length of the operation. And if necessary, I prefer to discuss with the patient the indication. And also, this is an important topic before we talk about the possibility to discuss with the patient. But I have a question also. How many women, once informed that if you don't remove the capsule, they can have a cancer maybe later, can say, yes, doctor, please, leave me the capsule inside. I don't care about this possibility. So I don't think that any woman will decide to have a bomb inside of a body that can potentially explode once that you inform about the risk.
Okay.
So our final speaker for this controversial session is going to be Eric Swanson, who's going to be talking about conflict of interest in plastic surgery and the problem and solution. So, Eric.
Well, nice to see the healthy debate. I'm going to talk about COI and plastic surgery, the problem and the solution. These are my disclosures. Now, when Dr. Goldwyn stepped down as PRS editor in 2004, he told the incoming managing editor, will you see to it that the journal doesn't sell out to special interests? Will you keep it pure? It is a commitment to which you must succeed, a promise you must fulfill. He was very worked up about this, so we might ask 20 years later, were his fears justified? Now, in 2015, Ed Luce boldly proposed that editors with COIs be excused from being editors, from editorial boards, and same for reviewers and discussants. This proposal was dismissed by 3 former presidents of ASPRS who collected more than 4 million from industry between 2015 and 2021, so not too much of a surprise there. Now we have to look at the definition of terms. You know, consultancy fee, it's actually defined as a fee charged for expert knowledge and service to a business, typically charged hourly. We hear this term all the time. Is it being accurately used, or are these payments something else? Now, the Sunshine Act, this is a remarkable new tool, and it's allowed us to actually view physician payments, and it's made this transparent. It's only available in the US, unfortunately. It was conceived after felony prosecutions occurred. Now, the CMS regards most physician payments as equivalent to bribes. Now, let's look up me on this CMS database. You can see the green line, that's the plastic surgery mean. The yellow line's the US mean. The blue line at the bottom, that's my line. I consider this kind of an ethical EKG, but it's good to be asystolic on this EKG. So let's look up Dr. Scott Glassberg, ASPS Board of Directors, PSF President, 2015 ASPS President. Let's look up him. Now he's got, you can see the vertical scales changed completely. The payments from Allergan and LifeCell, $1.24 million or $177,000 per year from those companies. Now, why is this important? Well, there is this on ASPS, the physician resources. Dr. Glassberg is talking with patients about BIA-LCL and is saying the current risks associated with surgery are higher than the risk of developing BIA-ALCL. Well, first of all, I'm not sure that's true with the latest statistics. But he's actually discouraging people from having their BioCell implants removed. But what's missing from this is he's a paid Allergan spokesperson, and this should be disclosed on this video. And this extraordinary response, Dr. Santanelli was talking about this a little earlier, but the ASPS response, well, there's the FDA, and then this was followed immediately by the ASPS response to the PRS consensus statement from AAPS. The next day this came out, we got it as an email, a response. It was reviewed by ASPS staff and an independent external methodologist. We have no idea who that is. We don't know who the staff is. We don't know who the authors of this email, but ASPS is basically saying, don't listen to that. You know, this paper suggested that it's a reasonable option, but we go more with the FDA guideline, which is not to recommend replacement of the implants in asymptomatic individuals. So where's this disconnect? We're seeing a disconnect between the science that Dr. Santanelli showed and the position of our society. Why is that happening? So how to manage a defective product? I think this is far too convenient for the manufacturer. You know, automobile manufacturers, they recall defective parts. The customer drives their car in, the part is replaced. They're not asked to keep their faulty accelerator pedal, you know, and it might work and it might not. But in this case, Allergan, you know, BioCell implants may cause cancer, they're banned, but patients are instructed not to have them replaced, and there's no financial compensation from the manufacturer for costs incurred in replacing defective devices. When is this acceptable in medical care? That's just a basic question. Now, there are credibility problems for conflicted plastic surgeons. And, you know, this is what Dr. Luce said, why should I or any plastic surgeon attach any more credibility than the vendor, than the vendor representative? Financial COIs in medicine are not beneficial. They're strained attempts to justify them. They just don't work. So these are industry payments to plastic surgery journal editors. This is actually an invited editorial that I wrote. And we can see that Plastic Surgery Journal editors, these are the journals that I chose to review, almost $1 million. The mean was $90,000 among editors of plastic surgery journals. So do these expire? Well, a lot of journals, you know, use an expiry date of 3 years, but there's no evidence for a time limit. Does the amount matter? Well, even a small gift such as a single meal, that builds a sense of reciprocity. Any limit is arbitrary. There's no real evidence on this. So what is the solution? Well, it's either prohibition or transparency. Transparency is not working. And if you want to read more on this, this is my editorial. I discussed this. So doctors have a choice, either accept industry payments and disclose them, but give up their right to serve as an editor, reviewer, or society officer, or reject any form of industry compensation and preserve impartiality. So the concern is, well, you might find yourself with very few editors. But this study showed that 10% of chief editors of top impact medical journals, only 10% have COIs. So this problem might be overstated. Now, I've been saying for years that plastic surgeons need to abandon industry subsidies. After all, the average salary of a US plastic surgeon in 2021 was $500,000. It's often assumed that this money is needed for our meetings, journals, and societies. It's not true. And we just need to follow the same rules that everybody else does. Attorneys, judges, school teachers, nurses, police officers, they can't take payments. Why should plastic surgeons get an ethical free pass? Well, what would this mean practically? Well, we'd pay more in meeting attendance fees, subscription costs. Industry would save millions, cost savings for patients. Plastic surgeons relieved of ethical problems, and our integrity is restored. Now, there are a number of products and devices that are heavily affected by COI. I've actually reviewed a number of these. I'm just going to focus on breast implants and the Keller funnel. This is the Keller funnel, and the takeaway message from this publication. It's basically an advertisement for the Keller funnel. Now, here are the two studies that are referenced in this review. And, there's no reliable evidence for a no-touch technique, and the studies were undermined by confounders. And after all, the surgeon is putting them in with sterile gloves, so, what difference does it make? But these are the conflicts reported by the authors. You can see that only 2 authors on these studies reported a financial relationship. But if you look at the CMS database, $1.3 million distributed to all of the authors. In the categories of payments, 93% of them were gifts or other services. So there's rampant dishonesty. And, this is embarrassing for our specialty. 87% of authors had a discrepancy between the database and their publication. And this was, at the 2019 FDA hearing, this disconnect was very apparent. All 40 plastic surgeons defended BioCell implants, citing this paper by Adams, suggesting that the problem could be mitigated with a 14-point plan. Whereas the patients, I was at this hearing, whereas the patients presenting in front of this panel, they unanimously recommended banning textured devices. Why this disconnect between plastic surgeons and their patients? And we have Dr. Diva, he presented this slide at a meeting showing that it's really infection. It's not the device, but it's the surgeon that's the problem. He's actually still doing this. So this is a false narrative that's been promoted by industry and industry surrogates. So how does COI affect editor decisions? Well, it does affect, I've personally found that it does affect editor decisions. So I wrote a 1-point plan to eliminate BIA-LCL. I wrote it right after Adams' paper was published, sent it into PRS. I rebutted the 14-point plan, showed that the authors weren't really following them anyway. It was accepted 5 months later. The acceptance was rescinded by the editor, and he emailed it would not be prudent for me to submit my letter to another journal, which is pretty chilling if you want to publish in PRS. And yet there was no reason, no ethical reason given for rejecting and if you look at the payments from Allergan, you can see that the editor was receiving payments from Allergan. So this is that study by Adams in 2017. I wrote this piece showing that it was dishonest. I won't go into all the details, but it was just a dishonest study. I sent it in. I waited until the changeover, the new editor and co-editor at PRS. Thought it might be a new day at PRS. It was immediately rejected without explanation. But it was accepted by Annals of Plastic Surgery and has been a very widely viewed article. Now, the original macrotextured breast implant article in PRS with all of its problems, it remains the same. It's in the whistleblower rebuttal. That's rejected. So COI and plastic surgery, where's the transparency? We know a little bit about plastic surgeons, but what about our societies and meetings and journals? I think corporate support is now an oxymoron. And we're getting the lines blurred between ASPS and Allergan. You can see this came out in an email to me just last week. You can see ASPS, even the logo has been corrupted. Allergan Medical Institute, I thought it was a sales company, but it looks like it's a medical institute. So they're blending together. It's almost like we're the Allergan Society of Plastic Surgeons. In these journal covers, woke messaging and DI virtue signaling on these recent covers of PRS and ASJ, this is inappropriate, particularly so because the U.S. Supreme Court last year ruled in favor of the constitutional principles of color blindness and merit. This has no business on the cover of our scientific journals. So what are the remedies? Well, we need to break the industry stranglehold on our specialty. The only remedy really is to abandon industry financial support. Luce basically agrees with this. He says, don't take the money. And, I wrote this piece about the lessons of the textured breast implant crisis. The COI really created a moral blind spot. I think that's why we had all these plastic surgeons defending the implants. And if this experience in which our patients died does not lead us to correct our ways, I'm a little pessimistic. I don't think anything will. Thank you.
Eric, I think, interesting presentation. I think that, it's complicated. I think that there is a role for industry and plastic surgeons to work together. I mean, if you think about some of the innovations that have come through because of the relationship between certain plastic surgeons who are really innovators and architects of our specialty who have worked with industry to develop products that at the time were deemed safe and effective was a good thing. We didn't know that ALCL was going to be a problem when the 410 implant was introduced. Nobody did. Nobody anticipated this. The studies didn't show any evidence of it. So I don't always think that some of these relationships should be viewed negatively, just kind of, for all people. I think if done responsibly, it can be beneficial to everyone. And I agree with you. I think some people probably take advantage of these relationships. It's one thing if industry comes to me and says, Nahabidin, you've published 200 papers. We want to kind of work with you as a consultant. I don't think that's necessarily a bad thing. But I think maybe the surgeon who's done nothing to demonstrate what their credibility is, who then goes to industry and says, I will do this for you if you do this for me. I think that's a problem. I don't know. Maybe you can comment.
Well, it's interesting. A study showed that plastic surgeons who receive money, they don't think it influences them. They think it influences other people. But we're not immune to it. We're all human beings. If we're paid money, there's a quid pro quo. I'm not sure I've heard anybody say something critical about Allergan who has received compensation from Allergan. So it's a problem.
I'm a plastic surgeon, but also researcher, and I do a lot of, let's say, industry-funded research, because I need to do that because the national agencies, as a plastic surgeon, you almost have no chance to get real big funding. And then you have to think, okay, how can I make my studies? How can I bring our specialty forward in a way that there is no conflict? And in my opinion, I make the study design. I say what I want to do, and then I say, okay, good. Are you willing to fund this? And second, we have contracts. Even if I find out, okay, there is perhaps something negative, I'm allowed to publish that. So I think you can kind of make your rules, but I think it's not good to say do not accept any industrial funding. Otherwise, I think we kind of have no chance to perform great studies also in the experimental field, in my opinion.
I disagree with that. I've done a lot of studies. I've never taken money from companies to do the studies. And I know other plastic surgeons, Dr. Hall Finley comes to mind as well. So do the studies, don't take the money, and you've got a lot more credibility.
Can I? So let's try to find a consensus between those two positions, because probably there is a misunderstanding. I got founded some studies from companies, not a single one, more than one company. But I report that disclosure. Nevertheless, it's not money that I got myself. These are money that were given to the university where I work. They decided to pay, to spend, and how much to spend. I was only running the research. I don't think there is any conflict with such kind of funding. And in fact, the European community and the European Health Commission accepted me as a member of the share. Then it's not a real conflict of interest, it's a potential conflict. The difference is when you get money yourself and you decide everything. So it should be clear. I don't think you have any conflict of interest, Dolores, because I know you've been founded by Motiva, but you've done an extraordinary important research that costs a lot of money. So I agree with you, but you don't have conflict of interest, because I think the money were given to the University of Innsbruck, and they paid the check, and they bought the reagents, they bought the animal, they bought everything, they paid for everything.
If the company pays for everything,
No,
they're going to get...
Please.
Oh, go ahead.
Time is finished. Okay? My disclosure is to be your friend, Fabio, but time is finished. Okay? Many thanks, all. Maurice and
Please, for those who are interested during lunch, if they can come back, if you can come back, there is the Motiva Symposium here. It is very interesting with Alexander Munoz. I don't get money to promote this.
Dopo faccio una sua idea.
Maybe in Vatican, yeah, it's in Vatican, or in Piazza Navona. Piazza Navona, they have the Brazilian flag.
There is a telephone here.
Because it cannot stay there when
Yes.
it's here. Thank you. The vote, Alexander. Yeah, of course. Thank you. Very kind.
Un secondo perché abbiamo sì, sì. Ah, questo è solo per il simposio.
Perché abbiamo delle presentazioni
Ok.
keynote e le presentazioni PowerPoint, quindi. Allora, adesso arriva la presentazione. Provi
Ah, ok, ok.
È la stessa cosa, è importante non trattarlo come un laser che deve puntare, lo mette là e lo muove come se fosse un schermo
ok,
virtuale.
ok. L'importante è non puntarlo. Vedo, se lo metto così va benissimo.
Sì, sì, va benissimissimo.
E con questo invece vado avanti.
Perfetto.
Con questo vado avanti.
A posto. Ok.
Ok.
Questo lo vediamo se non si fa.
Okay. Welcome. We have a... Is it working? Okay. I know that everybody is hungry, but thanks those who come and listen the lecture during the lunchtime. We have fantastic speaker from São Paulo. It's my privilege to introduce Professor Munoz from São Paulo, and he will present the lecture about the newest product and about the expander of Motiva. Yes, please.
Okay.
Alex.
Good afternoon, everyone. Thank you for coming, and it's a pleasure to be here and present our experience, and especially in a very interesting topic that was already discussed during this meeting. It's the two-stage reconstruction, and especially the new devices that we have now in our practice, that I think we can have more benefits and advantage in terms of the reconstruction as well as the follow-up. I would just start with some concepts that I think are very important, and what is the indication today, DTI versus two-stage. I think we have a lot of items and aspects. I don't want to go deeply in each one, but I think the most important is patient selection. If you select the best candidates, the possibility to have more predictable results are higher, and you perform like a customized approach in each kind of patients and anatomy. I use this for my residents and fellows. It's a kind of red flag, yellow flag, and green flag. I think DTI, in my experience, and it's not new, I think if you read the papers, there are a lot of publication about this subject. DTI works very well, and I think it's a wonderful procedure for this kind of people. And most important, with viable and vascularized and good flaps. Of course, there's some aspects related to anatomy, the volume of the breast, presence of ptosis, and some cardiovascular risk factors. But I think the best candidate I related to the green group. The second one, I think DTI can be offered, but sometimes you can have more benefits with two stages. And I think if you select properly this case, it's the chance to have acceptable rates of complications will be better. So I can offer DTI, but in some cases, two stages better. In my word, I think there is no place, especially in high volume hospitals, and to indicate DTI in this group. And I think it's the best indication to work with a lower pressure device to permit the vascularization of the mastectomy flap, and you can control better your pocket and have a better results with no complications. This is a part of my postdoc thesis, and I published this almost 11 years ago. And this is well described in different papers, different experience. But when you take a look about the risk factors, large breast and especially obese patients, you have it's a significant factors to have complications. And when I analyze and you put together different risk factors, it's like an empty basket. When you don't have any risk factor, I have 6% of complications in nipple-sparing mastectomy and direct to implant reconstruction. 1 to 2 risk factors, almost 20%, and more than 3 risk factors together, I have 30% of complications. And 30% of complications in 65%, I lost my implant and I have problems because it's another surgery, maybe a conversion to a flap reconstruction, and you increase the cost and patient dissatisfaction and other stuffs. So in conclusion, I think direct to implant is suitable, can be offered in the middle. And in my experience, these cases are not good. And sometimes you can have a more and less complications and better results if you work in this group with 2 stages. This is an old meta-analysis that included 13 studies, almost 5,000 patients with an average follow-up of 4 months. If you take a look, it's a forest plot graph, and everything that's greater than 1 favors direct implant reconstruction in terms of complications. So the great part of the diamonds in the groups are located in my side, which means that in terms of skin necrosis, direct to implant reconstruction, you have more of this kind of complication, as well as reoperation rates. So if you compare head by head, direct to implant and tissue expander 2 stages, all the studies are located in my place. So you can have a more predictable and favorable results when you work with a low pressure device. And of course, the worst situation that you lose the whole reconstruction, that the risk of implant loss is almost 2 times more than direct to implant than when you compare to tissue expander. So we arrive in a premise, and the premise here is that all patients who are candidates to direct to implant reconstruction are also candidates to 2-stage reconstruction, but the opposite is not true. So if you work with tissue expander, you can have more patients candidate to reconstruction just because the incidence and the possibility to have bad results and complications are lower. This is an example, a patient of my wife, that she had breast augmentation with me 20 years ago with a microtextured form stable implant, and she became pregnant, and she have a kid with malformation. And during the investigation of the malformation of her kid, the geneticist observed a P53 mutation, and she has a microtexture that I performed 20 years ago, and they arrived in a Li-Fraumeni syndrome. So it was a candidate for a risk reduction surgery. So in this case, with a young patient, no cardiovascular risk factors, small breast, no pitosis, previous breast augmentation in a premuscular plane, we indicate a direct to implant reconstruction. I'm not talking about the surgical technique here, but if you have a good patients and especially patient selection, you can have a good result with this approach, parallel approach, and a nipple-sparing mastectomy. Very thin flap is almost 4 millimeters, 5 millimeters of flap thickness, and you can have this result. This is microtexture form stable implant before the risk reduction surgery, and this is the reconstruction after bilateral mastectomy, nipple-sparing mastectomy in 30 days with ergonomics, 355 full projection. This is the post-op in 3 months, the post-op in 1 year, and this is the post-op after bilateral reconstruction with ergonomics implants in a premuscular space with very nice result. I use this platform CSPT, Comparative Standardized Position Alignment versus Time. Here you can compare the result between microtexture form stable with ergonomics in 1 month and 6 months, and the long-term result in 1 year with no cap cone, nice result, comfort, and the patient very satisfied with the aesthetic. Proper balance and symmetry, especially on the upper pole, as you can see here, after the reconstruction with 355 full projection. This is the patient in pre-op with microtexture, and after a direct-to-implant reconstruction, and I just recorded this video a couple of months ago with a post-op 7 years with a smooth silk ergonomics with nice result of after bilateral reconstruction. So the main topic here is 2 stages, and especially in easy cases as well as in difficult cases. I think the principles are well described in previous studies. The first stage is you insert the tissue expander with or without the ADM, and second stages with refinements, fat graft, and you change to implant. I think you have a wide indication, almost all no skin sparing mastectomy, even nipple-sparing mastectomy. And in patients with previous complications, you can have good results with these devices. Just because it's a lower pressure device, you can allow flap revascularization during the critical periods after the surgery, and you have more options and time to discuss deeply with the patients the different options of implants, sizes, shapes, etc. The timeline of a two-stage reconstruction, you know, it's a reliable process. We insert the expander, we have the expanded phase, then we exchange to implant. By the book, it spends 6 months, 8 months, 1 year, depends of the adjuvant treatment, but in our health system, and especially in public hospitals, we have a significant group of patients that the tissue expander won't be exchanged for 1 year or more. So this is a situation in South America, in other countries, that the health system have a lot of limitations. So this patient will stay with this device for a long period of time, and they have cancer, and they have to be submitted to different exams. You know that we have the traditional devices with magnet. There are a lot of ferritin, high density permanent iron, and different products. And basically, this magnet injecting port has a serious influence on the adjuvant treatment. And if you take a look to the literature, there are some problems, especially when we evaluate the total volume, OAR, its organs at risk, and especially the radiation isodose curves. In the literature, there are a number of studies that have been performed so far on this subject. In resume, the great part of these studies are related to cold spots and hot spots, were common findings when you have this kind of tissue expander during the radiation treatment. One of the first studies were published by the group from University of Michigan, the Ann Arbor Hospital, and they used TLD in order, in an ex vivo, measure the dosimetric changes around the metallic port in a 6 MV photon beam. Here, if you take a look, this is correspondence between the port and the graph of the dose that you can have around the port. So when you arrive at so close to the port, you have clear cold spots. In other words, this is under dosage of the radiation therapy close to the port, and so maybe the radiation planning will not be perfect or optimal. There are other studies that evaluated with more refined technology. This is a water phantom, and they use water phantom and TLD and film in vivo measurements to analyze the dose. Here you can see very clear that close to the port, you have a reduction of as much as 22% in a 6 MV photo beam and 16% in a 15 MV beam. So they recommend to increase the dose in order to compensate the negative influence to the port. So it's something a little bit confusion, because if you increase the dose, you can compensate this, but it's not so precise, and maybe you can have some complications into the skin and soft tissue. Other authors, this was published recently, that they compare the ideal planning versus the plan that was performed in Rio. And here you can see that they are totally different. In the upper part of the graph is the ideal treatment, but when you have the magnet port inside the body, inside the breast, the Rio, it's a more heterogeneous curve, and you have a lot of cold spots when you compare to the ideal treatment. So if you compare, and this is one of the larger platforms related to medical devices and the potential influence to the MRI environment, if you take a look, and it is available in your mobile, And if you text implant expanders or tissue expander, we have 165 tissue expanders analyzed and recorded, and 99.9% have a status unsafe 1. And unsafe 1, it's a potential or realistic risk or hazard to a patient or individual in the MRI environment. This is an interesting paper published a couple of years ago. It's a combo between Columbia, NIU, and Cornell, and they observed that tissue expanders with magnets create a big artifacts on the MRI. In addition, there are some reports of migration, burning sensation, pain, and even magnet polarity reversal for MRI. You cannot locate it anymore, the port, just because you don't have more the magnetism in the port. So these tissue expanders are currently labeled MRI unsafe, and it's a big issue for tertiary cancer hospitals, especially patients with advanced disease. And take a look at the dimensions of the artifacts that arrived in this kind of device: 17 to 10 centimeters, 19 to 9.7 centimeters, 50% you have the artifact inside the liver, 70% inside the lung, and 100% inside the heart. So it's a big issue in terms of the adequate follow-up for this patient. So we have an evolution of the tissue expander technology. And then we arrived in 2015 with the first magnet-free integrated port, and came with a roughness of 3.2 surface associated with RFID system. It's a smooth silk surface in a shaped format. I just want to clarify this aspect. It was published on last November. It's the new classification of ISO. And according to ISO, that I love it and I use it in my whole papers, we don't have the smooth anymore. And you have only two group, microtextured and macrotextured, between 50, more and less than 50. I do not agree with this classification. And we have the opportunity to publish in 2019 a standardization and different classifications available. And I have a great participation of my good friends, Maurice and Mark. And we published this according to ISO, the previous one that we have in 2018. And at the time, it's the classification that we have in our regulatory agency, is Anvisa in Brazil. So for me, it's very clear that if you cut off in the middle with the 50 micrometers, you put a lot of different apples in the same bag, and you cannot have a differentiation between these two systems. So between less than 10, we have only two. We have the traditional smooth that comes from the 70s and 80s, and the new generation one with roughness close to 3.6 at maximum 4 that have a different behavior. It's interesting that here you can see it's not totally smooth. It's a 3D electronic microscopy. You can see here the difference and details of a roughness of 3.2, hard valleys and depressions and presence of some peaks. It was published 1 month ago. It's a paper from Korea that if you increase the augmentation until 300 times, the smooth continue to be smooth with a roughness of 0.4, but with a roughness of 5.9, you can see that it's totally different. It's not a macro texture if you compare to the salt loss surface, but we have some irregularities that will contribute to the immunological behavior. So since all surface of tissue expander are made of silicone, do the surface aspects influence the interaction of the organism? Of course, that I don't have enough time to discuss all these different triggers, but I will just show our recent research. It's about the macrophage activation and migration. So we published this 3 years ago with different colleagues from all over the world. and it's available at the Nature Journal. You can check this online. But briefly, we compare at the MIT Langer, Professor Langer lab in Cambridge, Boston, that the response of different type of surface in terms of the macrophage activation and the process of capsular formation, especially capsular thickness and the macrophage infiltration. Two samples from the top and from the bottom. I move fast in this part. If you take a look from the control group, it's the traditional smooth, the old smooth. The light green is the new generation and smooth, and the purple one is the salt loss surface. There is a significant difference in terms of capsule thickness in 6 months when you compare the different types of roughness and surface area. And similar results were observed in terms of the number of the macrophage. Roughness close to 4 micrometers, you have less macrophage activation, so there is some correspondence to the capsule thickness, as you can see in the both graphs. This is very interesting because it's a live migration of the macrophage. The control smooth with 0.3 of roughness, and if you compare to the new generation of a smooth silk surface, we have almost 70% reduction of CD68 and CD11 in terms of percentage, as well as the number of cells. This is the impact in terms of inflammation of this type of surface. So it was the first proof of the difference in behavior of two smooth surface with different roughness. So is the reason that I do not agree with the new ISO classification that put all in the same basket, but the behavior is totally different, as you can see here. So the tissue expanders, the new generation magnet-free, we have this kind of surface with thin capsules, no tissue adhesion, and this has a significant impact in terms of reconstruction. But of course, we have different aspects, and especially that we don't have metal anymore. So we have two type of substance, two type of materials. It's a polymer, the PEEK, and we have the Cooper. With this device, we can have the possibility to infusion, to locate the port guided by the radio frequency without any kind of magnet. And we can have the possibility to have a device traceability because we have the same information that we have in the silicone implants. We start our research in 2016. It was the preclinical anatomical tissue expander with RFID system. We compare two type of RFID with ferritin and no ferritin in a scenario of a 7 Tesla MRI. We did this in São Paulo in our research hospital, the Hospital Sírio-Libanês, and we developed the first prototype of Flora tissue expander, where we used the experimental model, the mini pig. This is the first prototype of the port locator. It was in 2016, 2017. And here you can see the mini pig experimental model. And we analyze different types of RFID system, as well as different devices to measure pressure and temperature inside of the tissue expander, as you can see here. After the expansion, we removed the tissue expanders in a monoblock situation. Here you can see the ribs, you can see the skin, and we insert this tissue expander in a 7 Tesla MRI. It's a device available in the School of Medicine only for research. This is not for a routine in terms of the follow-up of patients. So here, briefly, you can see the quality of the image that we can have in this type of tissue expander. I will just rotate the image, and I will make a cut in the middle. Here you can see the ribs. This little hole that you can see in the ribs is the artifact due to the ferritin that we have in the posterior chamber of the tissue expander. In the anterior chamber, you can see it's a no ferritin port. So the quality of the image between the ferritin and the no ferritin is totally different. So in the flora tissue expander, we have the anterior one. The impact, the negative impact, is less when you compare to the ferritin. These results were observed in a 7 Tesla MRI. Of course, in a 3 Tesla and 1.5, you have a less artifact. We have the possibility to work with Professor Frank Shellock from University of Southern California, and we evaluate these tissue expanders and the MRI interaction in a phantom model. And here we evaluated the heating in 1.5 and 3 Tesla in terms of the artifacts and functional chains with different MRI conditions. And we have a very nice results in a phantom model. The higher temperature rises in 1.5 and 3 Tesla, 1.7 and 1.9 degrees Celsius respectively, which is almost nothing in terms of the variation of the temperature. And most important, no impact the ability to locate the RFID and read the serial number, and no risk to the patient in this environment. It was published last year. It's a very interesting paper because it was a clinical evaluation of between the two tissue expanders available. The traditional one with magnets, as you can see here, all the materials that are inside of the device and close to the port is a stainless, is a steel and neodymium, and the new generation of tissue expander, where we have the PEEK, the polymer, it's our organic thermoplastic polymer plus soft metal, it's copper. And it's not new because if you take a look to the literature, this material have been using for partial skull replacement and spinal fusion devices since the 80s and the 90s. And these patients were submitted in different times to MRI analysis with no negative impact. So the material, it's very magnetic environment friendly, and you can have a minimal interference into this system. And of course that it came with the RFID. This is the case number 1 in Brazil, where you did in 2019. It was a nipple sparing mastectomy reconstruction with this device. This is the post-op in 2 months. It was a parallel approach, and the insertion of the tissue expander. This is the template to simulate the position of the Flora device. And this is the patient in 9 months after the radiation therapy and this is the result with the tissue expander before the second stage. Here you can see it's very easy to find the port. We just scan the probable region of the location of the port, and the highest signal identified, the port flashes green, as you can see here. Then you can locate the port very easy, and you can expansion with the saline. And this is the MRI performed 2 months after surgery. If you take a look in this aspect, no influence in terms of the artifacts into the remaining glandular or skin tissue into the upper pole. But sometimes if you like a prepectoral reconstruction, it's not necessary to use the port locator, because you can identify by palpation the location of the port. Then you can locate this area, and then it's very easy to expand. It was other case of nipple sparing mastectomy. I used the inframammary approach, and here you can see a direct to implant prepectoral using the tissue expander, the location of the valve, the port here, and then with a needle and a syringe, you can expand the device, as you can see here, and it's very easy. It's not necessary to have the port locator in some cases. In more obese patient, sometimes you have to have the port locator to localize the port. We have another advantage, and this we have a lot of discussions during the development of this system, is to optimize the lower pole arc extra expansion. So it's a shapered format, as I mentioned before, and the conus of the expansion is located on the central and lower part of the breast. And we have also on the back a reinforced posterior region. We know that in some cases we have some deformation of the ribs just because we have a lot of resistance of the skin. So you have a negative footprint of the chest. So you have, if you have a base more reinforced, maybe the vector of expansion goes anterior and not posterior, and you can optimize your expansion. Here you can see the surgical planning. It's not complicated. It's similar to previous tissue expander. We define the lateral and the medial limits. Sometimes you have to lower the EMF, and sometimes you can maintain the same position of the EMF. It depends of the volume of the tissue expander and depends of the distance between the nipple and IMF. You have more than 15 options of tissue expanders with a base between 11 to 16 centimeters and a 8 between 9 to 16.5 centimeters, and a projection between 5.4 to 7.5 centimeters. We use the normal surgical technique, skin protection. If you have sleeves, I think it could be better. And we like saline. We don't use air infiltration. Here you can see that we also have some marks, and these marks you can identify in a normal X-ray in order to check any kind of rotation. And the most important, that we have suture tabs. This is very interesting, especially in cases of nipple sparing mastectomy and prepectoral reconstruction, in order to avoid any kind of rotation. It's a shaped device. So if you have the possibility to stabilize these devices with some sutures, it's better to optimize your results and avoid any kind of complications or displacement. So according to MRIsafety.com, this is the first device that is totally MRI compatible. So it's classified, and you can check this in your iPhone or in your mobile, that we have a conditional 8. And conditional 8, a device that has proven to pose no hazards in MRI environment with specified conditions of use. This is a very interesting paper published by my good friend Yves Harder from Switzerland. And in this paper, it was the first clinical one prospective that evaluated the impact by the radiologists of the system. It included 24 patients, 36 tissue expanders, no contrast breast, T1 and T2 MRI, 3 Tesla, and 3 breast radiologists blindly and independently reviewed all the image quality in 4-level scale: poor, sufficient, good, and excellent. If you take a look to the results, they are very impressive. 100% in T1 and T2 sequence had excellent image quality, with an artifact with minimal 11 millimeters, with a median of 32.5 millimeters. So the impact in terms of the image quality, according to the Switzerland research, is almost minimal, with a very predictable result. Just a clinical case example, a patient candidate to immediate reconstruction with some risk factors for direct to implant. This is the patient, and our marks that I mentioned before. It's not complicated. It's the same of traditional two-stage reconstruction. You have to define the pocket, the median and lateral limit. In this case, I tried to perform a nipple sparing mastectomy, but due to compromised surgical margins in the intraoperative analysis, we have to convert a nipple sparing mastectomy to a parallel skin sparing mastectomy. And this is the patient in pre-op. This is the patient with the tissue expander in 1 month during the expansion phase. And after we changed the tissue expander to ergonomics, full projection, 550 cc, and a contralateral procedure. And this is the final aesthetic result after the nipple areola reconstruction with nice result and symmetry with ergonomic implant. The same patient in oblique view here during the expansion phase, as you can see here, in 1 month, it's 490 cc tissue expander. And then after we change the tissue expander to an ergonomic implant, and then the nipple reconstruction and the areola micropigmentation. The CSPT that I showed yesterday with the pre-op during the expansion, here you can see an adequate lower pole expansion and upper pole fullness. And after 1 year, when you change the tissue expander to the ergonomics implant, and this is the final results, almost 5 to 6 years with a shaped format, natural balance between the upper and lower pole, and the patient is very satisfied with the result. Since there are metallic components, what is the impact of this technology on the artifact production and quality of breast MRI image? We already studied this not in Flora devices, but we studied this in the silicone implants, and we create a standard for our radiologists in South America, just because the artifact is very predictable if you have a good team of radiologists working with you. We have our data, but briefly, we have different dimensions of artifacts, and usually T1 is better than T2, and in the present times, you have different maneuvers in order to reduce the dimension of the artifact. And most important, in a properly positioned implants or tissue expanders, there is no interference of the artifact into the breast tissue and the skin. This is one example, so it's very important that you have to stabilize your implant to avoid this kind of situation of total flip, and the artifact goes to the skin of the breast tissue. But it was the generation 1 with ferritin that I mentioned before, and now with Flora, as I mentioned in the 7 Tesla MRI, we have the generation 2, and the generation 2 is available in this new type of implants that were available in the market. It's the Zen system that it's a microtransporter without a ferritin core. If you take a look and compare these two systems, and especially the components that we have in this new generation, and comparing the ferritin with new and the no ferritin devices, the quality of the image are totally different. And this is the system, and this is the quality of the image that we have in the new generation of the tissue expander. And this is the quality, it's very similar, this quality of image that we have in the Flora devices, especially in recon patients that have to have a restrict follow-up with MRI during the whole treatment. Just to finish, can you indicate this technology and in different type of patients, and especially high-risk patients submitted to nipple-sparing mastectomy and candidates to reconstruction? I think so. I have a lot of cases, especially delayed and previous complicated patients, that I think with this system we can have a good result. So this is the patients that came to my office or to the cancer hospitals with unsuccessful previous reconstruction. So with this system, we can remove the previous implant with this anesthetic result, and we can, with the device, we can expand the skin, we can perform fat grafting, and the concept of reverse expansion, we can have a better results. The surgical planning here are similar. We have to perform a contralateral breast in order to have a symmetry. This is the template of the location, the areas of fat grafting that I described before, the zone 1, zone 2, and zone 3. This is the patient in the operation room. This is the patient at fat grafting and tissue expander, the Flora 375 cc on the left breast. And this is the patient in pre-op. This is the patient in post-op 1 month with the tissue expander and fat grafting. And more 2 sessions, we can arrive in this situation with a better coverage in a patient with previous complications with alloplastic reconstruction. This is the patient in oblique view, very thin skin. This is the tissue expander working with a low pressure device. And this is the CSP, as I mentioned before, with the tissue expander in 1 month, the overexpansion, fat grafting, and the results after we change with a small implant with ergonomics. This is the patient from the view from the top and the results that we can arrive in risky cases with the tissue expander. We analyze also with 3D image and compare the benefits of the system. And if you compare the previous with a complicated implant, and this is the results and the quality of symmetry and worker with tissue expanders. So in conclusion, I think 2-stage reconstruction, the benefits of the surface, as I mentioned before, we can have a lower incidence of inflammation and cap cone, and these aspects can contribute to the outcome, less contracture, natural shape, and early rehabilitation. The use of this new technology, especially the RFID system with a no magnet tissue expander, can favor patients with advanced diagnosis and who require a more rigorous radiation and follow-up due to less interference in the MRI and the radiation. The traditional tissue expanders with metallic ports may present a significant interference in dosimetry during external beam radiation and are considered unsafe devices for MRI follow-up. And finally, these aspects can optimize the oncological treatment, especially in patients with advanced disease who require adjuvant radiation and a strict follow-up. Thank you so much for your attention.
Thank you, Alex. We almost don't have a time, but for 2 or 3 short questions. 2 questions, okay. So I have a question about the chip. If we use the expander for a short period of time, maximum 1 year, do you think now the chip is useful for you like a surgeon, or maybe it could be avoided in the expander because you register what kind of expander you use. It is completely, everything is written. So the question is of your opinion about the chip. And the second question about the perspective, because what will be in the future, Bobby? Because we expect something better, more data from the chip.
Yeah, I think it's the evolution of the technology. We have to do the first step. Of course, for a temporary device like a tissue expander, maybe traceability is not a big issue because you remove in an early period the device. But the good point to have this technology is because we don't have more the magnets. So with the same system of your credit card, that you have a communication between your card and the reader of the card, you can locate the port easily and with no ferritin, with no magnet. The perspective, the second question, once we have this technology, we can have in the near future, and it's available now, more informations that comes inside the body. Like, as I mentioned, in the prototype device, we can measure temperature inside the body and inside the tissue expander. Maybe in the future, subclinical infections or other stuffs can be evaluated because we have a measurement of the temperature more precise. The second point, that the first time with a no invasive methodology, we can measure pressure. And with pressure, you can measure with the transponder, and you can calculate the pressure, and you can make a comparison with the clinical situation of the patient. And if you compare our classification, that it's very subjective, like a baker, for the first time, we have the possibility in the same patient in 1 second to have a number of the pressure, and you can correspond this number with the clinical situation. Imagine that we have in your clinic 100 patients, and in 90% of a pressure of 10 millimeters, I'm kicking this number, you have 90% of complaints in terms of hardness and in terms of anesthetic result. And if you compare 2 millimeters or 3 millimeters of pressure inside of the implant or the tissue expander, the incidence of the same symptoms are less than 10%. So the first time we have a number and to evaluate our results in a long term and to define more objectively capsular contractors. So I think it's just the first kick. Yeah. So the serial number, it's good for traceability, especially with an implant that will stay good for 15, 20, 25 years with no CapCon, but it's the first door to open to new possibility to evaluate inside of the implant.
Do you think it is a space for app in the mobile
of
to
course,
connect?
Of course, and create a big data.
Yeah.
With no participation of human, when you have an operation room, maybe we can have a read on the top, and when you insert the implant, all the data communicate with this reader and go to a big data in the cloud, and the Plastic Surgery Society can have this number in life. So maybe in the future, we can have more control in terms of number of operations, reoperations, complications, etc. This is traceability.
Michael, one question and we must finish.
Yes, I go fast. Just for people that maybe came afterwards, I think the big advantage, and I want to repeat on that, is that compared to other kind of surfaces, expanders with other surfaces, when you do the exchange and when you have 1.5 year of period of time, this expander with this surface, would you feel safe not to remove the capsule that is formed and in order to put a new implant? So you don't have to remove the whole capsule. What's your opinion?
Yeah, I showed it yesterday and I showed it today. It's a smooth surface, and it's a smooth silk surface with different from a traditional smooth. So it's not necessary to remove the capsule. You know, I'm not totally against and I'm not favored to capsulectomy, but it's a benignant capsule, and we have no case in the world, according to recent data, related to this kind of surface and problems in the future related to ELCL. So it's not necessary to remove the capsule. The capsule is almost virtual because it's 1 year, 6 months using the tissue expander. If you try to remove the capsule, it's like peritoneal. You don't have anything. It's transparent.
Thank you.
Thank you very much. Thank you, Alexander. Dr.
Thank you so
Munoz,
much.
Yes, thank you. And we start the next session. Yeah. Thank you.
Okay, so we take the opportunity. Last night, most of you enjoyed the party, and there was a kind of a special outfit, a rock casual outfit. So in the night, Mark and me, we didn't sleep, but we were working hardly because we had to set up a committee in order to award the best outfit or last night, the best rock outfit. And the reason why it was awarded to one of the faculty participants that you were at the party, you know, was the outfit, is that he simply can have he had the perfect mix between madness and highly scientific rigor. And the award this year goes to
Dr. Peter Cordero.
So Peter, I'm not expert in madness, but I'm expert in scientific rigor. So on behalf of the European Association of Plastic Surgery, I'm happy to give you the official tie of the association. Thank you very much, Peter, for your madness and for sitting.
Should I wear it on my...
Exactly. Thank you. You can go.
I believe it's common knowledge that to understand and treat a disease, you have to understand first its epidemiology. So this is a session on my topic. I'm not a surgeon, I'm not a plastic surgeon, I'm an epidemiologist. And I'm very happy to be here and to introduce the session on tracking, epidemiology, and manager of BAA-LCL. So I will ask my co-chairs to introduce themselves and introduce the first speaker.
To introduce also myself, yes, I'm Nicola Rocco, breast surgeon from the University of Naples. And Dr. Swanson.
Oh, Dr. Eric Swanson, private practice, Kansas City.
Well, so we can start the session with Professor Lisbeth Holmich. It's my great pleasure to introduce you. She's a professor and plastic surgeon at the Herlev and Gentofte Hospital in Copenhagen, Denmark. So you will start with determining BIA-ALCL risk through a national analysis. Thank you.
Thank you so much for the nice introduction, Nico. And thank you to Fabio and Mark for inviting me. It's a great honor. I really appreciate this. I was hoping to go forward with the title of the talk, determining the BILCL risk through a national analysis. But unfortunately, our data are not ready yet, but they will be provided within this year. So I'll tell you about the study, and then I'll go on to tell you about the current situation in Denmark. I do have conflicts of interest to report because this study was funded by a research grant to me, but paid to the hospital and paying wages for Julie, who's a PhD student and our programmer, to do this study, which is only the start of a series of studies, and I'll come back to that. I also have received research grants from studies doing melanoma research, which is not relevant for this, but these are the other ones. We are, some of you may know that we actually started the first breast implant registry in the world back in 1998 in Denmark. We call it the Danish Registry for Plastic Surgery of the Breast because we also captured some mammoplasty patients. And it existed in the period of 1998 to 2011. And then we had to close it down because we couldn't get it financed anymore. We prospectively included women operated both for breast augmentation and reconstruction with implants, and also their reoperations and other reoperations. And also a control group of women who had breast reduction or mastopexia without implants. And we estimate to have about a national coverage of 80% over this period. And the establishment of the registry is described in this paper by my colleague Trine Henriksen, who was the initiator of this. And here you can see the implantations over the period of time when the registry existed. And we have about 12,000 women in the registry with almost twice as many implants. And for women with the first time implantation, we have more than 10,000. And these are the ones that we are focusing on the BILCL study. Most of them, as you can see, are cosmetic or having had augmentation, and a little less than 2,000 are reconstructive. What's unique here is that we have almost exclusively textured implants because that was the ones used in Denmark in this period, and still we use quite a lot of textured implants, I must say. We have representation of more than 7 different implant manufacturers in this cohort. And we have 3,500 control women, and then we have established a huge control group of women who have not had breast implantations and who are extracted from our national population by Statistics Denmark, matched by age and sex, of course. More than 200,000 women, which we are going to compare with in the next series of studies, where we're also going to look into connective tissue diseases, neurological diseases, offspring effects, etc. So this is a story ongoing, and you will hear more about this in the future. For the study of BILCL, we are also looking into other lymphomas and actually also trying to capture if we have any cases of squamous cell carcinoma. I'm not aware of any, but we'll look into this. We focus on the women who had a first-time breast implantation in this study. We calculate their exposure time, and then we we link up with different registries to identify cases of BILCL and other lymphomas in the cancer registry and also in the clinical lymphoma database. And if there are discrepancies or we need further information, we can also link up with the pathology database and the National Patient Registry. You may be aware that in the Nordic countries, we have identification numbers, personal identification numbers, which are unique and which makes us able to do follow-up studies without almost any loss of follow-up. And this is quite unique for the Nordic countries. We compare with our control groups, both the internal and the external control group, to determine both the prevalence and the incidence and potential risk factors for BILCL and other lymphomas. We will look into implant-specific characteristics, calculate risk estimates based on both implant manufacturer, type, shape, and type of texturing, and also patient-specific characteristics. We'll stratify or adjust on sociodemographic factors. We even get information about income and education, indication for breast implantation, other diseases, and we will also be able to, at least to some point, adjust for smoking history. So much about the planned study. We will have results from that later this year. Currently, we have, over the last 10 years, identified 18 cases of BILCL, and then we have another 2 cases with the OPS diagnosis, perhaps ALCL. It's not been verified. So in the next slides, I'll only talk about those that are actually verified. We have, on average, it's about 1 to 2 new case per year. Last year, we only had 1. This year, we already have 4. So I can't tell if it's increasing by now, but on average, it's been like this for this period. We have 14 who had augmentation and 4 with a reconstruction, 2 after DCIS, 1 after an invasive cancer, and 1 risk-reducing. So in rough numbers, it's 18 among, we think, about 80,000 breast implanted women. We're not sure about that number. So roughly 1 in 4,500 in this period. For those that only had 1 implantation, these are 13 cases. Their mean implantation time was a little less than 12 years, and you can see quite a large range of implantations from 4 to up to 24 years. And then we have 5 cases where there's a history of a prior implantation. None have more than 2 implants. And they had, on average, 9.6 years with their first implant, and then 7 years with the second implant where the disease was diagnosed. And you can see the range is also quite wide. And in the last cohort, last group, there was a range with 1 to 14 years, and the one with the 1 year time with a new implant, I think there was actually the disease was there with the first because she was reoperated due to fluid problems. But it wasn't diagnosed until in the second operation. And for the characteristics, we have a mean age of 49 years, quite a range from 26 to 78 years. We don't have any knowledge about BRCA or other mutations in this cohort, unfortunately, but at least not at the moment. You can see the most fortunately were stage 1A with only cancer cells in the fluid, 11 patients. And to my knowledge, only one of these had chemotherapy. This was the very first in Denmark. The other ones were treated only with surgery. And I'm the person, I forgot to tell you, I'm the person that my colleagues report to. So I try to collect these. I can't say that I've captured them all, but all that I'm aware of, I have data, some data on at least. We have one stage 1B to my knowledge, 2A and 2-3. And this one was the 1B patient I operated recently. You can see all this whitish debris within the capsule. These are actually the tumor cells, the T cells. And then there was a slight invasion on the back side of the capsule, which makes it a 1B. This is a patient operated last year with a stage 3 disease. She actually had pain in her breast for probably more than a year, and then eventually developed some swelling, but at the same time also had a palpable tumor mass. And just before surgery, she became also red in that area. And this is a specimen, the capsule plus the tumor. It weighed more than 200 grams. And actually, she was inoperable because I had to leave tumor in between her ribs, couldn't get it out. And this is a special story. She was early pregnant and wanted to keep the baby. So there was a delay before she had chemotherapy. And in that time, she actually developed lymphatic metastasis as well. She now delivered, and I hope that she is well, but we'll see. Yeah. So I think this slide might interest you. We looked at the implants, and for these 13 patients that only had one implantation, 5 of them had mentor implants. Some, I think 50-50 about contoured and round. 3 had Magan, Inamed, Allergan. These are the same. 1 Eurosilicone, 1 Nager, 1 Polytech, and 2 unknown. It should be noted that the major stakeholder at this time of this calendar period were actually Mentor. They sold the most implants, and they are heavily represented in the registry. So of course they should also have a surplus. But if it's too much or not, we'll see in our upcoming study where we can calculate the incidence. And for those with 2 implants, 2 of those were unknown. 1 was a Eurosilicone, 2 were Mentors, and you can see the second were Magan or Eurosilicone. So my conclusion is we seem to have a pretty stable incidence, 1 to 2 cases in a population of 6 million people, men and women, and the risk is roughly about 1 in 4,500. We will produce much more detailed data when we have the analysis later this year, and estimates for different implant types will be produced. So far, we conclude that none of the textured implants seem safe with respect to BI-LCL, and that's, I think, a major take-home message. And secondly, we have to discuss this with the patients. They need to be part of selecting what kind of implant we should use. And I always advise that we should use smooth implants if possible, but of course it has there's an individual weighing out with the patient of what's her anatomy, etc. Thank you so much.
Thank you. Thank you, Lisbeth, for sharing with us your experience and your data. So, are there some questions from the audience, Professor Santanelli?
Thank you very much, Lisbeth, for your presentation. I appreciate very much the conclusion. I only have some doubt about some data that I don't understand. How did you? Probably I made a mistake, but the active population. So I counted in the Denmark from 17 years old to 85, something like 5,700,000, not that much as you say. It's 60 million. The total population of breast implant, I found it 60 million. If you remove 3,000, which is the smooth population, it end up with 5,700, which give a risk of 1 in 3,000.
Yeah,
something
yeah.
like that.
You had. We don't know the real number, but you used in your paper, you used from 17 to 70 That interval,
70 to 85, according to data website
no,
available
that's
of the
not what the
population.
table says. It says 17 years to 8 to 70. And we have a lot of women over 70 who have implants. So that's why I figured that we have more.
Which paper do you mean?
The one with the where you have calculated
the old
European,
one. No, sorry, I'm telling about the data that I'm following up continuously now.
Okay, yeah.
So we went up to 85. The active population is about 60 altogether, 60,000, including smooth too, and that makes something like 1 to 3. Anyway, it's
it
much
higher,
higher compared to the average in Europe. So you are
It is
doing
high,
quite a good tracking
Yeah,
anyway.
we're trying to, but
Okay, thank you.
we'll know more soon.
Are there other questions? Okay, thank you, Elizabeth. So.
Okay, the next paper will be Evidence of Case Tracking to Assess Prevalence in Brazil by Dr. Groth.
Thank you. My name is Anne Groth. I'm from Brazil. I'm a plastic surgeon, and thank you, Dr. Clemens and Dr. Santanelli, for the invitation. It's really an honor to be here. So I'm gonna try to navigate you through BIA-LCL in Brazil. This is my disclosures. So what's the importance of case tracking BIA-LCL in Brazil? We happen to be the biggest textured breast implant market in the world. And these are the brands that are now selling breast implants in Brazil. It's more than a dozen, and we had more in the past, but now that's the market we have. And what's the preference for texture in Brazil? We don't have sales numbers, we don't have registry, we don't have breast implant registry. So we did a survey to try to understand what's the preference for the plastic surgeon in Brazil. And this was done 2 years ago, and the preference is for microtextured implants in more than a half of the plastic surgeons. A fourth of the surgeons prefer polyurethane, and 22% smooth. When we compare this survey with a previous one before 2018, it's important to say that before 2018, we didn't have, actually, almost didn't have any smooth implants in Brazil. So before that, we have microtextured and polyurethane divided country. And why is important? Because we might be in a unique position to contribute to this discussion here today. So, some numbers. Brazil happens to be the country with the most surgical procedures in the world. We have a very heavy appetite for cosmetic procedures there, and we have almost 250,000 breast augmentations a year in Brazil. And according to the survey I just showed you, almost 180,000 of those implants are textured. So I'm still not giving the risk in Brazil, but I'm trying to understand our process of thinking on that. When I happened to be in the board of directors of the Brazilian Plastic Surgery Society in my state, Paraná, we held a lot of meetings and lectures because there were some FDA statements in 2018, the allergen recall in 2019. Everybody was really upset and confused about all these statements. And we did this task force, invited other specialties to the Brazilian Society, and we did increase awareness about the disease. And that led us to the only database that we have on BIA-LCL cases in Brazil. We published the 14 first cases before, and after that, we add another 19 cases. So right now, in 2024, we have 33 cases of BIA-LCL in my state, Paraná, and all many brands, cosmetic and reconstructive cases also. So this is a very important slide because as I showed you, we have a lot of brands in the market. We have a lot of brands with cases. So 12 of the 33 cases are Silimed polyurethane, 12 are BioCell, and we have other brands here with lesser cases. So 70% of all cases are microtextured. And why this happens in Paraná? I've been accused in a national meeting in Brazil, actually, that something's wrong there, that we might be fabricating cases or not reading it right. And it stands out because we are one of the Brazil 27 states, and we account for only 5% of Brazil population. So how do we have 33 cases in Brazil, and according to the latest global network, might be another 2 or 3 in the country? So it doesn't make sense. One possibility is that we are sitting in the highest incidence of P53 mutation. It's 1 for every 400 in my state, but it's a Brazilian variation, so we don't know if there's any relation to developing BILCL. But I just believe that we are more capable of diagnosing BILCL there. So Dr. Clemens asked me to try to track some cases in Brazil, and I started thinking, where are those cases? So I went to publications. When we publish in Portuguese or Spanish, we don't go to PubMed, we go to a place called Lilacs, which is a Latin America database. And we were able to find all these cases, numbering 16 cases in total in the literature. And since I've been publishing and presenting this, many surgeons contact me to relate or get some advice in some cases. And in the past year, I started to count them. Why not? Of course, I don't have all the data. These cases are not so close as the Paraná ones, but I have another 10 cases from states outside my state. These are only personal communications to me. And we did this survey to understand trends in breast augmentation. And in this survey, one of the questions was if you had a BILCL case, and 24 plastic surgeons answered yes from 414 answers. Almost 6% of the plastic surgeons had a case. 16 of them were not in our database. And finally, we went to the place where all adverse effects on breast implants are reported. So Anvisa is our FDA, our regulatory agency. It's responsible for authorizing medical devices and for post-surveillance. But the thing is, in Brazil, who reports some issues or problems with implants is the manufacturer. So there's a compulsory notification by manufacturers to Anvisa. And it's a really hard to navigate on database, but we are managed to, in the past years, understand it a little bit, because everything from needles to surgical gloves is in the same database. But we are able to find 55 T lymphomas, 1 death from lymphoma, but the vast majority of cases of problem are not informed, almost 500 from the 800. So we had those 3, trying to give you numbers, Mark. We had those 33 cases from Paraná, the other 16 from publications, the other 10 from personal communications, and we end up with 59 cases with 2 deaths. But we have also those 16 cases from the survey, and we also have these 55 cases from Anvisa. We don't know if they are extrapolate or they are the same. We don't have a registry. It was very important to hear in the previous session. This is not a registry. We need a registry to understand these cases and to see how these patients are today. So having the cases is very different to having a registry. And a few observations from Paraná database. Even having the only database, we can see that almost half of the cases, they didn't have a diagnosis prior to implant exchange or implant removal. So we had some things that we had some patients receiving another texture implant, even with a BIALCL diagnosis. We have patients didn't receive incomplete capsulectomy. So we are interfering with the staging and treatment of these patients, unfortunately. And there's also a lot of misinformation. I think this is the deal in the world right now. So we have, I can't tell you how many times I saw this paper, it's in Portuguese, in national meetings saying that there's no relation, we cannot confirm there's a relation of this disease with breast implants. And even in the Brazilian Society Regulatory Agency site, which was updated in 2022, there's no significant reports of the disease in Brazil, and they're even citing me. I just figured out that yesterday. So they're saying that I'm saying there's no cases in Brazil. And of course, there's misinformation in the non-medical media too. This is the most read magazine in Brazil. And the journalist asks very promptly, is there a smooth or texture fault in this silicone causing cancer thing? And this piece was a breast surgeon and a plastic surgeon were interviewed, and they said there's no evidence to confirm the texture has increase on developing this disease. So this is a very read magazine in Brazil. Can we hope for change? Maybe. We are not, we don't have in our culture in Brazil a very litigation, we're not a very litigation country, but just last year in October, the first lawsuit was lost for, a company lost this lawsuit for recognizing the BILCL patient. And of course, $25,000 doesn't hurt the industry, but it might have some effect on how the industry thinks about that. So to conclude, I'm going to go back that because I think that's important. To conclude, without a robust registry, I think BIALCL will still be dismissed as a disease in Brazil, and doesn't require any practice changes. And also that the perception of the BILCL being rare is very dangerous and is affecting patient care in Brazil. So we do prefer texture implants. We do love polyurethane. And in Paraná, we had these 33 cases with only textured implants, but many brands. And increasing the scope a little bit, we were able to find another 26 cases and possibly another 21 cases to the total number. Thank you so much.
Questions for Dr. Groth? Okay, I'll start with one. Polyurethane implants, do you think that they're at higher risk, and why are they used so much in Brazil?
I think it's a kind of historical point. The birth of plastic surgery in Brazil was in Rio de Janeiro, and all the opinion leaders in Brazil, the pioneers of plastic surgery there, they were very heavy on polyurethane. So there, yes, it's still very used. You saw in the previous survey, it was almost half and half. Now I would say 25%, but that's, we don't have the sales. We don't have the real numbers. That's just a survey. And well, if they are higher risk, that's, I think Dr. Santanelli will say that it's hard to say risk when we don't know sales. See,
You don't have the denominator.
We don't have it. So we just heard the colleague from Denmark, and she said it's mentor there. I don't know if you noticed, we don't have any mentor in Brazil, but I cannot say how many mentor implants were sold in Brazil. So it's really relative.
That's
Dr.
true.
Santanelli.
Thank you for your excellent presentation. As far as I remember, probably here, Arianna Di Napoli, here it is, she can confirm, TP53 in our research only increased the early onset of the disease, but not the incidence itself. So once we exclude this as a risk factor, special risk factor in the Paraná population, I mean, how can you explain? Do you see any other possible reason for that? I mean, are you doing something that promote the BLCL, or should we believe the authority data because they're not your data? So are you inventing the cases, or it's underreported from the Ministry of Health in Brazil? That's my question.
Yeah, so no, I'm not fabricating the data. It happens to me because I had one case, one of the first case of this database was a case of mine, and I had all kind of problems to do the diagnose. So I happened to be in a position where I could do something about that, and that just increased awareness. So that's it. And I can't assure you that I have much more cases in Paraná than what we have, because breast surgeons are treating now BILCL in Brazil, and they don't necessarily report to our society. So I know that by fact that there are some other cases, but and we don't have any authority number. I don't know who reports to Dr. Clemens about the global network for the global network, but we do not have those national numbers.
Thank you very much, Dr. Groth. You clearly presented the cause in an epidemiology of BLCL in your country. Congratulations again. And now let's move forward to our next speaker, who will present risk assessment of BLCL in 3,500 patients. It's a very interesting number of cases. It's by Dr. Cordeiro. Thank you.
Thank you. And thank you, Fabio and Mark, for inviting me to this very important meeting. It's an honor and a pleasure to be here. So I was asked to talk about the risk assessment of BILCL in my particular cohort of patients. And in addition to doing that, I will also try to touch upon my current management of patients with implants, which might be useful to the audience. I have no disclosures. So BILCL has clearly changed my practice with regard to the discussions I have with patients and clinical recommendations. What information do I share with patients? What are the numbers? The FDA update in 2020, 733 cases. There's now 12 or 1,300 and 36 deaths. I think there's now up around 60 worldwide. I think the one important thing that I try to pass on to patients is that there is no well-substantiated case of BILCL in any patient with a smooth implant. So what's the risk of developing BILCL? And I'll just touch upon some of the current literature and societies in the American ASPS, 1 in 3 to 1 in 30,000. I think somebody mentioned 1 in 10,000 today. The TGA, which is Australia, 1 in 1,000 to 1 in 10,000. The Netherlands, 1 in 7,000, et cetera, et cetera. And I think the large variations are mostly based on reporting and perhaps a little bit of genetic predisposition. But as we learn more about it, I think there will be more explanations for the wide variation. Looking at the literature, you can see starting at the top and then moving down, 1997 down to 2018 here. The risk went from 1 in 3 million all the way down to 1 in 3,000, and I think it continues to slowly increase. The problem with much of the current literature is that it's all retrospective. It does not often capture all the cases. It's dependent on reporting from patients and physicians. The case data is often incomplete or inaccurate. The denominator, I think this is the important point, is often extrapolated. It's not accurate. And follow-up is very limited and short-term. And we know that the onset of BILCL is delayed. It's usually 8 years plus. So what's been my personal experience with implant-based reconstruction and BILCL? So over about a 30-year period, about 7,000 implant-based reconstructions. I have 3,500 patients with textured implants, and my routine yearly follow-up, as I mentioned yesterday, is patients come in every year for 10 years and then every 2 years. All outcomes are recorded and put prospectively into a database, which I've maintained since 1992. So the point here is long and careful follow-up. This is the standard follow-up. Also, for silicone implants, I do routine MRI scans at year 3 and then every 2 years. The recent recommendations have changed, so it's now at year 5 and then every 2 years. The data is prospectively entered, and within my cancer institution, most of these patients are also carefully followed by the oncologists and the breast surgeons. So what we have, I think, is very robust and detailed follow-up, which is, I think, important to understand. So based on this three-decade experience, what's the risk of developing BILCL with a textured implant? This was published in JPRAS, and I'll summarize the results of this publication. So there were 3,546 patients, and the median follow-up was 8.1 years. And I would stress that that's very important. If you look at most of the other literature, the Australian data, for example, is 2 to 3 years. But in this group, the median follow-up is 8 years. You can see 70% of patients had bilateral reconstructions, half and half silicone versus saline implants, and a vast majority of my patients have had the BioCell textured surface, about 97%. Most of these were reconstructive patients, thus many of them had breast cancer. And then there's a variety of patients who had received chemo, radiation, et cetera, before. So what's been the experience and what's the calculated incidence? I had in this publication 10 patients with BILCL. Of these 10 patients, you can see 8 presented with seroma only, 2 with mass and seroma, and 2 presented with metastatic disease. About half had received chemo. 1 of the 10 had received radiation. You can see that the median timeline to development of BILCL for this particular cohort was 11.7 years. So it takes a long time and a long follow-up to really start picking up these cancers. Every patient had total capsulectomy, and if the patient had bilateral implants, bilateral capsulectomies. And I think for this disease, that's not a question in terms of surgical treatment. And then 1 had chemo and radiation. So the crude calculation, the incidence would be 1 in 354. And that's with a median follow-up of 8.1 years. Since we know that BILCL increases with time, just following this cohort, we would expect to see an increase in cases and incidence. And now in 2024, I have 2 more patients, which makes it 12 out of 3,500, which makes it approximately 1 in 300. And I think that number will continue to go up. If you do a more accurate estimate of what the risk of a risk calculation using a Kaplan-Meier type curve, I'm not sure if you can see it, but by about 15, 20 years, that risk estimate is about 1 in 100. What about the institutional experience? Everybody accuses me of not washing my hands. We have 11 surgeons, and we looked retrospectively at the entire group, over 6,000 patients. The median follow-up is 6 years because many of them are junior associates who haven't been around as long. There were 11 cases, which made it an incidence of 1 in 559. So slightly lower than my personal incidence, but that's based on multi-surgeons and a shorter follow-up. So to conclude on the incidence, the incidence in the literature has rapidly increased, and it's going to continue increasing. The risk with highly textured implants is much higher than has been previously published. And certainly as more registries and databases are established with longer follow-up, the accuracy of estimates will be much better. And I think these risk assessments will help patients and surgeons in the decision-making process. So that's what I was asked to talk about. I just wanted to comment on what I currently do, which, since it may be useful to some of you. What's been the impact on my practice? What are my current recommendations? My current discussion for patients, and that's changed over time, but currently I tell them that there are still no well-documented cases in patients with smooth implants. So that's very important to tell a patient who's about to get an implant or who has a textured implant. I also say that the FDA does not recommend routine replacement of textured implants with smooth implants. And I tell them that the risk of ALCL is much higher likely than of what is currently published. And it's certainly higher in patients with a longer age of implant. So it's important for them to understand this. What are my recommendations? Only smooth implants and tissue expanders. That's the only thing I've been using since 2017. They're recommended for new reconstructions, for replacements, and breast augmentations. In bilateral reconstructions, I previously used to only replace the problem. So for example, a leaking implant, I would replace only the problematic implant, now replace both with smooth round implants. What's the difficult thing is, what do you say to patients and how do you manage them if they've had long-standing textured implants? And I see these patients every year, and they read the articles on the internet, the websites, etc., and they're all panicked. I currently offer them 4 options. One is just observation routine follow-up, which is in theory what the FDA recommends. Replacement of the textured implant with a smooth implant, replacing the textured implant with a flap, removing the implant completely. And some patients, this is what they want. And I tell all these patients that, yes, if I remove and or replace your implants, I can't guarantee that it will completely eliminate the risk of developing BILCL. And I think this is very important in patients with textured implants to make them understand that you may reduce the risk, but you may not eliminate it. So increasing numbers of my patients want to replace their textured implants with smooth implants. And I think there's certainly benefits. Reduction of risk is likely. We still don't have, good, accurate data. Peace of mind is huge for these patients. And they're getting a new implant with better technology and potentially a longer period before leakage or requiring an exchange. So I'm now willing to replace textured implants in some patients with other reasonable indications. And these would include the age of the implant. Many of these patients have 20, 30-year-old implants. I think it's reasonable. Capsular contractures of any sort, aesthetic issues. So if you combine that with a textured implant, I think it provides some indications. So what are the current changes in my practice? Notifying patients. Patient education is key. Exclusively using smooth implants. A much lower threshold to replace textured with smooth, and very aggressive evaluation of implant-related problems and seromas. Thank you.
Thank you very, very much for your nice presentation and the detailed information you provide us with this robust database. We have several questions. So please.
I think there's going to be a lot of questions. Great presentation, Peter. Thank you. A couple of questions. First of all, when you're recommending change of implants to smooth, capsulectomy or no? Do you do a capsulectomy at the same time? And is it a total capsulectomy? Is it a non-block capsulectomy? What do you do?
I always do a capsulectomy. I do not do on blocks for these cases, totally asymptomatic patients. I usually do a partial capsulectomy, and the extent is just based on what is safe. And patients who have read, they come in and they say, well, I read about this and, I need a total capsulectomy. I'll say, look, if it's not safe, or if you want to keep your implant, most of the time I can't really remove the capsule because our skin flaps and the soft tissue is so thin, it'll destroy the result. So if you really want to replace it, I'll do what I think is safe. In the patients who want their implant removed, I do a total capsulectomy, not because I think it makes any difference to reducing risk, but In those scenarios, if you remove the capsule, it heals better. If you don't remove the capsule, they end up with seromas, and it's very hard. So it's based on what I find.
And just very briefly, I didn't pick up the exact number that you did cosmetic augmentation on the contralateral side. What's
I think it's somewhere between 300, 400.
all right. So you should have a couple of cases there as well. Have you got any?
Have not, but I usually with cosmetic augmentations use a round implant, sometimes smooth. It used to be textured, but I have not had one in the. But that's a small number. I would expect one in the next few decades, maybe.
Congratulations on one of the largest personal series in the world, just like Dr. Groth. I know that you've personally taken a lot of unfair criticism, and just want to say we appreciate it because we're better for you sharing this, despite that criticism. A lot of patients ask, is it possible to be screened in any possible way? Is there anything that's in your mind where you're trying to screen them beyond the obvious symptom? And did all of your personal experience have that classic seroma? Was there anything unusual? And was there anything asymptomatic that you then found some?
Pretty much all the patients had seroma. There were, except maybe one or two, they presented with a mass or with metastatic nodes that were picked up on a scan of some sort. But vast majority, more than 80% with the classic seroma. And it's not a little seroma, it's a large seroma. It's very obvious. We published something recently looking at seromas. And because I have over 1,000 patients with serial MRIs, et cetera, there are those patients that have asymptomatic seromas. They just show up on the MRI. They're not clinical. They don't come in with a huge. So there's that group of patients. And then there's a group of patients that walk in with a delayed huge seroma, et cetera. What we found, approximate numbers were in my total group, I think it was 18 to 20 patients in each of those categories. 30% of the patients with symptomatic seromas had BILCL. So we test them all now. We're very careful. If you have a delayed seroma, you have to test it. About 30% will be positive. Of the asymptomatic seromas, there was not a single patient, we sampled the fluid, et cetera, who had the lymphoma. So it's the symptomatic patients are the ones that are most worrisome.
Peter, for sure you developed some theory or some idea for explaining why you have that kind of incidence of ALCL compared to other countries. We should expect 60,000 cases in Italy if we had the same rate of incidence. And so for sure you have thought about this.
I think it's follow-up for sure, the length of follow-up. The Danish registry, for example, I think as they follow these patients out, and I didn't get whether that median follow-up, it was a median follow-up of 10 years or they've only followed patients for 10 years. I followed patients for over 30 years routinely, very important. And I have a very high sensitivity being in a cancer institution. I've always biopsied, sent fluid for cytology, et cetera. So I've picked up patients even before we knew that BILCL existed. I think it's those two things. I'm not sure about whether the high population of cancer patients might be part of the reason. There was a Danish group, the Dutch group recently published a paper about probably an increased risk with the BRCA gene. So, there are other factors, but I think the biggest reason is close follow-up. And if you don't test, you're not going to find it.
So you think we are missing, we have not detected about 59,000 cases in Italy?
Absolutely. I think, so just one more point. I've had lots of patients with those delayed seromas in the past when we didn't know about this. We didn't test the fluid. And my general approach to them, if they don't respond to a drain initially, is to take out the implant, remove the capsule, because that was causing the problem, putting in a new implant. So I think I've treated a whole bunch of patients who had the disease, and I think there's a lot of good surgeons out here, and that's how they approach the problem. And if you're not thinking and you don't send all the, and either you don't know about it, you didn't test for it, etc., you're never going to know, and you may be treating these problems. It is, you know, often a very benign lymphoma, and maybe a lot have been treated and we don't know about them. And the Italians are just that much better.
Thank you, Professor Cordeiro, for sharing with us your very interesting data. Now we go ahead. We invite on stage Dr. Konashinsky with his experience and risk assessment of BA-ALCL in 1,503 patients in cosmetic breast augmentation. Thank you.
First of all, thank Fabio and Mark for inviting me to present my my study. But nobody said about the yesterday evening. I conducted a short study during the party, and what I find, the conclusion is that during the rock party, everybody looks at least 10 years younger. So thank you for a nice study, and let's do again. Okay, that's my disclosure. We know, of course, I will start from the global information and come to the level of one practice. So we know the breast BIL was identified in 1997, recognized by FDA 2011, and classified by the World Health Organization in 2016. And we know that mainly all cases are detected on the texture implants. BIL can develop in patients who get texture implants due to the breast reconstruction, cosmetic augmentation, transgender, and tuberous breast. And when we look to the analysis of the publication, there were more than 600 publications about this, and most publications were done in PRS. Mark Clemens is the more exceptional, has exceptional productivity. Probably now is more publications. I did it in, and the University of Texas Anderson Cancer Center was the most productive organization, and it cooperates with Mayo Clinic and in Sapienza University. There are more than 56 different countries from which we have the publication. Of course, the US is on the first place, but Italy on the second place. I'm happy that there are some publications from Poland as well. Okay, so the risk estimated, we just listened the lecture of Peter Cordeiro, and he presented a very good rate, high rate of BILCL. The prevalence for 3 years, the highest was reported by Peter. So theoretically, the higher prevalence should be expected in cosmetic patients. And today, Professor Santanelli talked why we can expect bigger prevalence in the cosmetic. But there's a lack of high level of prospective research, particularly on cosmetic patients, and the fact that most countries are not yet equipped with full functioning breast implant registry. So aim of our study was to assess the BIA-ILCL epidemiology in a cohort of patients who have received texture implants for a cosmetic breast augmentation. We measure all these parameters. Thanks, Fabio, because he helped me a lot for the analysis of this data. The data came from one private clinic, and it was experience of 2 plastic surgeons. So a prospective cohort observation study was conducted on 1,508 patients observed from 2006 to 2016. Inclusion criteria was the cosmetic indications, and we record this data. So the results, the 7 cases were excluded because there are reconstructive cases, and there were one case of BILCL. So the final group was 1,501 cosmetic, and they were included in the study, and there was 5 cases. There were 95% of primary augmentation and 4.5 secondary augmentation. The complication rate of both group was the same. The cold seroma was found in 21 patients, so in 1.4%. 12 were microtexture biocell allergen, and 9 was microtexture Siltex. So finally, there were 5 cases where we have in the cosmetic patients 4 biocell and 1 Siltex. So the EFT risk level analysis, so mean EFT of all 5 patients was shorter than in literature, 5 cases shorter in EFT than the mean value of literature, and 1 case was similar. Onset of the was in accordance with the expected peak of the risk per number of replacement. And the overall risk was in the literature. We looked that there was a difference in our study was 1 to 299 per 3.1 year. And implant specific prevalence against for Siltex was 1 to 769, and for biocell 1 to 145. And the BILCL incidence rate was in the past was like this, and in our study was 1.0.7 per 1,000 microtexture BIL patient a year. So of course, everything depends on the dominator. So and unfortunately, because of only fragmented, time limited, and incomplete sales data are available. So we know not all brands of implants are sold within a particular country. Not all sold implants have been implanted into patients. Not all implants within a country have been implanted into the residents. Some residents in the country have been implanted abroad, and no amount of sold implants have been explanted or have been replaced. In 95% of cases of BILCL occur only in one or of the 2 implanted devices. So conclusion of the study was this is the highest BILCL prevalence reported so far, but it could be underestimated due to the limited mean follow-up time of 3.1 year and lack of awareness in the early phase, suggesting a potential increase over time as the follow-up expects. The unexpected event reconstructive cosmetic distribution of BILCL in the literature can be accounted either to a underreporting in the cosmetic population due to the poor follow-up and awareness, or to a genetic predisposition in oncological population. But it's only the theory. So implementation and validation of the stratification risk analysis can help guiding surgeons and patients in the decision for the prophylactic explantation. And what should be the next step? And because the data are very strong, and my experience of my clinic, so of course I know the data coming from the literature, but I was sitting in front of my patient, and I have to come to the conclusions. So if we make the other kind of analysis, that finally there were 5 cases in macrotexture implants, so the prevalence was 1 to for the macrotexture 1 to 115. So what should the surgeon do with such data? Ignore it or take a step forward? And yesterday, Fabio said the same, but I wrote at the slide before. Try to imagine that your daughter has a macrotexture implant in her breast. Okay, I have a daughter sitting here. And will you share with her the information about the associated risk? Or will you give her any suggestion, or you simply not talk about it? Yeah, so this is the main question. And I think the patient should be for us like a daughters, for me as well. majority of my patients are on the age of my daughter. Okay, so we have decided to contact patients who have undergone surgery at our clinic and have been implanted with microtexture implant from Allergan. And the material, there was the group of 579 patients with microtexture implants were operated on the Klinika Kolaczynski. And I stopped to use the microtexture exactly in 2015 because the double capsule, yes. And since May 22, we have initiated phone call with all patients with Allergan implants who have not revision surgery or have not attended a checkup in the last 2 years. I have the same rule like Peter. Every year, the patient comfort control. Of course, this is my offer. Not everybody came, but this is the free of charge control, ultrasound and control. So when I calculated my time, I spent about 8 hours a week free of charge controlling my patients. Patients, of course, were asked to make the ultrasound examination before the consultation. During the consultation, up-to-date information about the risk of BIA, LCL was provided. Now we have more and more educated patients. Even this meeting was watching by several patients online, because I remember 2 years ago when I came back from Rome, from the same kind of meeting, one of my BIA LCL patients said, okay, you doctor attend to the meeting and you have to know, okay? And she is a member of the group. I don't know how it's in Europe, but in US, there's a group of patients, BIA LCL patients, and they take from our debate only some short information. Okay, so quickly, all right, there was the decision finally, 95 patients and sent to check up. Okay, and we operated on 35 patients. Fortunately, we didn't find any BIA-LCL. So in conclusion, the risk of developing BIA-LCL in patients with microtexture implants, in my opinion, is high, according to my experience. The surgeon should feel responsible for the patient who have been operated on by him and inform the patient about the risk of BIA-LCL associated with microtexture implants. The policy to exchange microtexture implants in all patients is justified, but the decision should be left to the patient. So taking home the messages, don't leave the patient alone with BIA-LCL issue. Thank you very much.
Thank you, Dr. Kolaczynski. We have some questions from the audience. We also have a question
yes,
from Dr. Swanson, please.
Yes, congratulations for the presentation. Maybe patients in Italy are different, but I'm curious to know, how do you transmit the message to this patient, knowing that you have the high risk to be sued by this patient? Has ever happened?
Yes, this is interesting. There's a very good question. Thank you, Gianluca. I think that 2 patients with BIA-LCL tried to sue me. Yes, first patient was during the pandemic, and I diagnosed, I treat her very quickly, probably from the first step with the seroma to the final operation takes, I think, 1 or 10 days. Of course, she doesn't sue me because of the BIA-LCL, but because of the lack of information. She said, why you didn't send me information that the Allergan implants are withdrawn from the market? So this was the issue. I answered, okay, I informed the patient during the annual checkup. She said, okay, but I asked the other doctor, I visit the other doctor. So I said, okay, to ask the other, sue the other doctor. But of course, sometimes we must be aware that we are involved in this problem, because majority of the patients are our own patients. We placed the implants 10 years ago or 12 years ago. So I think it's a very delicate issue.
Very delicate.
Yes, but openly inform is, of course, and we play. I think the biggest problem is with asymptomatic patients, because nobody paid them back for the surgery. If they have a broken implant, Allergan pays. If they have the capsule, Allergan pays. If they have BIA LCL, Allergan pays $7,500 US dollars. So the bigger problem is, and sometimes the patient needs 1 year to consider a replace or not, but finally they come and we exchange.
Thank you.
Dr. Kolczynski, earlier, Dr. Santanelli was showing us that microtextured implants have a higher risk than we once thought. Do you think we should be more vigilant and maybe having the same discussions with these patients?
No, I didn't start this. Of course, now majority of my patients are smooth implants. I think 99%. But of course, I have done for 35 years the surgery, the breast augmentation, and I'm afraid to start to call for all my patients. There was like maybe 10,000, so too much to talk about because there was a area of mentor when I use a lot of mentor. So I think it's too early. It's too early. It's not for me. Oh.
May I have a quick one? Okay, so I have to disclose a conflict of interest because it's my father-in-law, but I respect policy of our research publication, which participated also Professor Panagiotakos, and I did not give any information about the incidents in micro and polyurethane to my father-in-law before I presented here. So he was totally unaware of my results. So we have to, I apologize, Daddy, for it. I'm sorry.
Okay.
Oh, yes. I think we're done then. Yes. Thank you.
Thank
you. Okay. Yes. The next presentation will be by Dr. Hunt. Advanced BIA ALCL. Are we closer to a standardized approach?
All right. Thank you. Good afternoon. And thanks to Mark and Fabio for the invitation to participate. These are my disclosures, all related to breast cancer, so not relevant to this presentation. So first of all, to understand what is advanced BIA ALCL, I think we have to understand that there is a TNM staging system. It's evolved over the years, so many of the earlier cases were using the standard lymphoma staging classification, which we understand now is really not the best strategy. So we need to look at the tumor extent and also the lymph node status and evidence for distant metastasis in order to properly stage the patients. So from the last conference here in Rome, we developed the recommendation for practice, and what you can see in the red box here is that there was reported to be no prospective trials to guide the management of patients with advanced ALCL because the treatment options had been previously extrapolated from cutaneous or systemic ALCL treatments. So there were no real standardized protocols of adjuvant treatment such as radiotherapy, chemotherapy, immunotherapy, and patients have been treated with protocols based on their own institutions. But there was a recommendation that immunotherapies, and specifically brentuximab, should be employed as first-line treatment for non-surgically treatable ALCL cases in place of the traditional considerations of chemotherapy and radiotherapy. So this is a recent publication from the group here in Italy looking at clinical recommendations according to a systematic review from the literature, and you can see how many records were screened and how many reported studies were in review, so 74, and how many were excluded. So many of the publications that are out there are excluded from these reviews because they don't really contain enough information to guide us on what should be clinical recommendations. But they did provide some diagrams. I'll show this one here, which is how to evaluate a patient who has signs that are suspicious for ALCL based on effusions, lymphadenopathy, a mass, or capsular contracture. And I think most of us have seen the patients with effusions, which were mentioned earlier, to be quite evident, on exam, but sometimes the effusions are quite small. And we found them in the contralateral breast, that if we send that small amount of fluid, sometimes we are diagnosing ALCL. So I think some are going undiagnosed because they don't have that typical very large effusion. And then this is another algorithm which they presented for doing PET and staging the patient, and then giving treatment recommendations based on whether they were confined to the capsule, whether it was locally advanced, positive lymph nodes, or disseminated disease. And you can see many different pathways here in terms of recommendations for lymphadenectomy, chemotherapy, immunotherapy, and then adjuvant radiotherapy. So one of the things that they did look at was stage 4 ALCL, and I highlighted this in red here because it was recommended that tumor debulking be considered as the initial approach in disseminated ALCL. And I think there are some considerations for this, but in most cases, it's probably a better situation to consider systemic therapy first before submitting the patient to surgery. So from our experience at MD Anderson, and I know Mark Clemens will present a more recent series, but we published this a few years ago of patients from 5 years of our database where they all had biopsy or cytologically proven ALCL. And then we had demographics. This shows the different types of treatments. And again, this was over a period of years. So you can see some patients received chemotherapy, about 40%. Some even got stem cell transplant in the earlier part of the series when that was thought to be the way to treat these patients. The vast majority did have surgery, and also most of the patients had removal of the contralateral implant, and only a few, about 20%, were treated with radiation therapy. If we look at the stage of disease, you can see that most were, or the majority were stage 1, but we also had some more advanced stage 2A, 2B, 3, and even some stage 4 patients. If we look at some other recent series that have been published just in the last year or so from the UK and from Memorial Sloan Kettering, smaller numbers of patients, so 18 from the UK cohort, no local or systemic recurrences or death, 100% disease-free survival. So most of these were effusions, only a few had mass or lymph node involvement, so not really more advanced disease. And from the cohort, none had recurrence. They both stated that it was important to do en-bloc capsulectomy and to use a multidisciplinary approach in these patients. This was another systematic review published recently from the UK, also with Mark Clemens, looking again at a number of publications, this time 362, and again, distilling it down to the ones that are really able to provide information, only about 39. And you look at the pathologic stage here, again, the majority are stage 1, but there's some presenting with more advanced disease. And these are the treatments employed. So you can see kind of all over the map in terms of chemotherapy. Even some of the stage 1A patients received chemotherapy, stem cell transplant in only a few, immunotherapy in very few. And so it's really challenging, I think, to say what is the best treatment. And it looks like from these publications that we don't have consensus about advanced ALCL, but it's certainly with en-bloc capsulectomy being considered as the most important. In this publication, they did say that targeted immunotherapy in advanced disease should be considered. So when we look at event-free and overall survival that's been published, looking at outcomes according to treatment approaches, I think is really challenging to make anything out of that because so many different treatment approaches have been employed. It's probably more important to look at TNM staging. And then again, total capsulectomy, I think, is the key. But first, we need PET imaging for all of our patients in order to map out the extent of disease. This is a total capsulectomy with a large mass seen there where we're getting a negative margin along the chest wall, which again is usually the most challenging part. And then the next most critical piece is having the pathologic assessment, a standardized pathologic assessment of the capsule. So we need to look at it both grossly and histologically. And this just shows some of the work from my colleague Roberto Miranda, where he's suggested the amount of assessment of the capsule based on different zones. And it should always be marked for orientation so that we know about the margins. And in the top figures on the right are just where it's the ALCL is limited to the capsule, the luminal side, whereas in the lower ones, you can see staining through the capsule and more advanced disease into the breast and the chest wall. At the top pattern here, you can see the histology of the breast specimens with extension of these CD30 positive cells into the breast parenchyma. And then a lower panel examination of lymph node specimens, and they can have many different patterns of involvement of the lymph nodes, which is really critical for pathologists to understand when they're examining these lymph nodes. So you can see the staining in the lower part for CD30 positive cells in this very unusual pattern, which is not what we typically see for more solid tumors. So I want to just show a couple of clinical cases, one with limited axillary nodal involvement, one with residual disease involving axillary and subpectoral nodes, one involving the chest wall, axillary nodes, and internal mammary nodes, and finally chest wall and nodal involvement. So this is a case where the patient presented with a large infusion, you can see there, and on PET imaging, she had this lymph node noted. So this patient actually had had several previous surgery for effusions over the last couple of years, and we weren't able to obtain any pathology specimens, but I would submit she probably had ALCL for a few years, and then she presented with this lymph node involvement. So we did the capsulectomy with this targeted axillary dissection. It's important to note that you have to localize these nodes with something before you remove them, because just trying to examine them by palpation is not really useful. And this shows a patient with, you can see, very extensive axillary nodal disease and subpectoral nodal involvement. So she had had her implants removed in 2018. We saw her in 2020 with this lymph node involvement. And so she probably had this disease at the time of the capsulectomy, and over time it was evident. So this is probably more residual rather than true recurrent disease. So after chemotherapy, she had some response. You can see it was a partial response based on PET imaging. We talked about local therapy. She was an artist using her right upper extremity for her work, did not want to have surgery, so she had radiation. And what you can see is about a year and a half later, she has no evidence of disease on PET imaging. So with chemotherapy and radiotherapy, it looks like it was able to control the disease. This is another case of a patient who had breast implants removed somewhere else. She had apparently a second surgery for incision and drainage of after the implant removal, probably was ALCL. And what you can see is that she has this large mass in the breast. When she presented to us, she has both axillary and internal mammary nodal disease here. She received chemotherapy, had a complete response based on chemotherapy. And then when we were talking about local therapy, obviously it looked like she would need a mastectomy with that large mass. She would need a complex nodal dissection in the axilla internal mammary nodes. So we elected to do radiation. And this shows her PET imaging after radiation with what appears to be a complete response. And finally, this is the unfortunate patient who had chest wall extension, and she had had breast augmentation over about 8 years prior. When she came to us, she had extensive chest wall disease, so she got chemotherapy. She had progression. You can see the chest wall extension here with the nodal involvement on PET. She had progression of disease, so we actually did the debulking capsulectomy, and then she continued to progress. So biologically, her disease was very extensive in the chest wall and nodes. She got multiple lines of therapy, but unfortunately died of progressive disease. So now we have NCCN guidelines just came out recently. And what you can see in the red box is that for stage 2 to 4 disease, it says to consider systemic therapy first and then to think about other treatments if a complete response is achieved with systemic therapy. And this just shows the response criteria. Based on the response, then which algorithm to take. And then finally, if for relapse or refractory disease, these are the recommendations based on other T-cell lymphoma types. So in conclusion, I'll say I think ALCL is a very heterogeneous disease. It can involve the breast implant capsule and surrounding soft tissue, but regional lymph node involvement is seen in both early capsule invasion and more extensive chest wall invasion. So we should involve or assess for nodal involvement at diagnosis to avoid these very advanced cases. We have to target those PET avid nodes for resection and consider systemic therapy for advanced disease and consider radiation therapy for local regional consolidation. And this is our multidisciplinary team at MD Anderson that I've been happy to work with for many years. Thank you very much for your attention.
Well, that was an excellent review of a very complex topic. Thank you. Dr. Clemens.
Yeah, thanks so much, Kelly. Very elegantly put together, and thank you for being a partner on so many of these cases. Can you maybe talk about something that's not in the literature at all, but something that you've been faced on multiple times? And it's one is when it looks like you can still take the patient to the operating room versus when you say, no, this patient needs neoadjuvant immunotherapy. So just your thinking on what you're seeing on imaging that might make that difference. So neoadjuvant immunotherapy. And the second one is the lymph nodes, because FNA is, we've seen it be unreliable. We've seen it in real disease where it said that it was negative. When are you going to go after a lymph node versus when are you going to maybe watch a lymph node? These are tough things that nothing's written on. So what do you do?
Right. So Mark and I have shared a number of these cases, which is, I think, why he's asking this. But, you know, for the patients that have subpectoral implants where they have a clear mass on PET CT, and I think one of the previous speakers mentioned this as well, is that when it's on the posterior aspect of the capsule extending into the musculature of the chest wall, we've had cases where I resect that and then we have, you know, exposed lung. And sometimes these patients that have had previous radiation for breast cancer, the ribs are extremely brittle. And so you think that you can take it off the rib, but the ribs are so brittle that they just basically fall apart. And so you end up with a much more extensive sort of reconstruction of that patient. So I think those are certainly the ones that when they present with a mass like that on the posterior chest wall, that I would say we should definitely consider neoadjuvant therapy or preoperative induction therapy, whatever you want to call it. But those are definitely the more challenging ones. As far as the lymph nodes, I think that when you have lymph nodes that show up on PET like this, we've tried to biopsy them, you know, using interventional radiology because they can kind of map out which node it is that's FDG avid. But that's not always reliable when it's just a needle biopsy. So usually we have them biopsy it. If it's positive, then you have your answer. If it's negative, we have them put a marker in so that we can then go and remove it at a surgery and then have more definitive histology.
Thank you for your presentation, Kelly. Excellent. And Mark partially asked my question as well, because we have a case with the invasion. So I was a little bit, confused by the recommendation of this paper that was done in collaboration. This is not clear with the Italian Ministry of Health. And I'm a bit confused also because one of the author is associate editor of the paper of the journal, and that was not disclosed. And so it gives a serious bias on this paper. So now the NCCN guideline says something, and the Ministry of Health suggests us in Italy something else. I don't know which one to follow. There are evidence to do the bulking and then chemo, or there are evidence on the other way around?
Yeah, I think it's challenging because, as I said, over the years, the treatments that have been utilized are so varied. Even in our own series, we had some that received stem cell transplantation, and that's really not something we would consider currently. But from that Ministry of Health paper, they did say that for stage 2 and 3 that you should consider neoadjuvant therapy. That's why I was confused with the stage 4 guidelines doing debulking first, but that's from the systematic review that they did and also a Delphi process that they were using. So thank you.
Thank you very much. And now let's proceed to our next speaker, which is Dr. Martelli. And he's going to talk about control of risk recurrence in BA-LCL, advanced stages. Thank you, Dr. Martelli.
Thank you. First of all, I want to thank the scientific committee to invite us to this outstanding meeting. This is my disclosure. I am an hematologist. Non-Hodgkin lymphoma can involve the breast as a primary or secondary disease. The most common lymphoma in the breast is a diffuse large cell lymphoma or marginal zone lymphoma. The association with the anaplastic large cell lymphoma and the breast implant is well known. Breast implant LCL show a favorable clinical outcome if clinically identified and diagnosed and followed by a complete bilateral breast implant removal. However, some patients may have an aggressive disease, and the course and the managing may be controversial. Multidisciplinary approach between oncologist, pathologist, and the plastic surgery may improve the outcome of these patients. The first question is, when and for which patients we can consider the systemic chemotherapy? This is the TNM, this is the MD Anderson TNM staging, and we consider the chemotherapy, systematic chemotherapy, in all 2 to 4 stage of disease. This is the update just mentioned before of NCCN guidelines of 2024 that considered a systemic chemotherapy for all patients with a stage 2 to 4. The most recommended chemotherapy is a chopper-like regimen, but now we consider the best option the combination of brentuximab with the CHOP or with CHOP standard. These for the results of the Echelon-2 trial. Echelon-2 trial is a randomized trial who compare CHOP to a combination of brentuximab to brentuximab, cyclophosphamide, and doxorubicin, named the CHIP. Brentuximab vedotin is a new antibody conjugated with the monomethyl auristatin. This is the patient characteristic. We consider the only patients with anaplastic large cell lymphoma, and is well known that the progression-free survival is much better of combination therapy if compared with the standard CHOP. Also, the overall survival is improved by combination therapy. Here, I want to discuss with you a case, in our case, of a 53-year-old woman that in our institute. In 1998, she received a silicone-filled implants of the microtextured with a breast augmentation. On December 21, 23 years after, she presented evidence and mastodynia in the lower outer of the left breast. On February 22, the patients observed a palpable mass in the lower quadrant of the left breast by cutaneous lateral erythema of the breast. This one. But unexpectedly, the ultrasound ecography and the magnetic resonance was negative. An anti-inflammatory treatment was given. After 3 months, June 22, worsening of mastodynia, the erythema expanded in the lateral region of the costal region. So now, bilateral breast MRI was positive for a mast-like of 5 centimeters with the multiple lymph nodes in the left axillary cavity. So a corneal biopsy was made. A proliferation of a large cell anaplastic CD30 positive was found. With CD15 ALK1 was negative. The core biopsy of the left axillary node was negative for lymphoma. So was a diagnosis of a BIL ILCL was made. At this time, the PET show a high metabolic active mass. SUEV was 60. Yes, it's not easy. Okay, this is the mass. This is the mass of the peristaltic area. Also, the lymph node of the axillary is positive, and also in the left intermammary. The bone marrow was negative, and so the stage was a stage 3. It was the first stage 3. The patients start with immunochemotherapy with brentuximab CHP for 6 cycles. And on November 22, after 6 cycles of chemotherapy, the patients obtain the complete metabolic response. So we move to the removal of a breast implant, of the breast implant with a capsulectomy and block. Also, the cutaneous resection corresponding to the site previously done was biopsied. Pathological immunohistochemistry examination of the breast capsule and the skin reaction show no sign of residual disease. Clinical radiological follow-up every 3 or 6 months was planned, and until now, the patient is in complete remission and off therapy from 18 months. This is the Italian Ministry Health Guidelines published in 2022 after confirmed the breast after BIL diagnosis and adequate staging. All patients with a stage of 2 or 4 were treated with systemic chemotherapy, and now with a combination of brentuximab and CHP. Is well known that the patients that present a breast mass around the capsular implant have a poor outcome. But if you receive the chemotherapy, this poor outcome may be improved. Finally, I would highlight the role of the chest wall infiltration as a critical prognostic factor. Here we can see a stage 2 with anterior extracapsular infiltration. And this is a stage 2 with a posterior extracapsular infiltration with near the pector pectoralis and the ribs. This is a retrospective study of Italian registry, 63 patients treated. The most of them, 50 were localized stage 1, the other 14 was stage 2, stage 3, 4. As you can see, the event-free survival is good, but patients with stage 2 with chest infiltration have a poor outcome. Compared with the patients with stage 2 without chest wall infiltration. The prognosis, the outcome of event-free survival for stage 1 and stage 2B is the same, but the outcome of the patients with the stage 2 with the chest wall infiltration is the same of the stage 4. So chest wall infiltration is a critical prognostic factor in BLCL, and then may compromise radical surgical treatment. In select cases, a new adjuvant immunochemotherapy may be quickly required. Stage 2 with a chest wall infiltration had the similar prognosis and treatment of the stage 4. In conclusion, systemic chemotherapy reduces the risk of advanced stage in BILCL. Involving radiation therapy without systemic chemotherapy should be reserved only in patients with any evidence of a radiologic disease. Chopper, cioè chemotherapy regimen, are the standard therapy for advanced disease, but brentuximab, but the combination of brentuximab CHP should be considered now the best option for more advanced stage. Chest wall infiltration is a critical prognostic factor and may be compromise a radical surgical resection. So in selected patients with a chest wall infiltration, a neoadjuvant chemotherapy should be quickly started, leading to a complete radiological response, allowing a complete excision with a considerably less extensive surgery than initially anticipated. This is the case that we have presented. Thank you very much for the attention, and we are waiting for your question.
Thank you. Thank you, Dr. Martelli. Are there questions from the audience? I just have one quick question for both you or Professor Hunt. I don't know if we have an answer. In the post-neoadjuvant setting, if about local control in the post-neoadjuvant setting, if we had a patient who was positive with lymph nodes, and the lymph nodes completely disappear after the neoadjuvant setting, do we have to go only for capsulectomy or en bloc capsulectomy, or we should also remove the nodes that was previously
This
positive?
is a surgical decision.
Yes. And what is your opinion?
I prefer I think that it is better to remove all capsules in en bloc. I am an hematologist.
But what about the nodes that was previously positive?
So as far as the nodes, I think it depends on the response to therapy. So that's why I tried to show you a couple of different scenarios. So in one case, after she received the chemotherapy you're recommending, brentuximab and CHP, she still had evidence of FDG avidity in the nodes. So we talked to her about either doing a lymph node dissection or doing radiation therapy. If you do a lymph node dissection, about 30 to 40% of patients will get lymphedema in that extremity. Now, we do have some techniques of doing prophylactic lymphovenous bypass and things of that nature that might not be readily available to all patients. So radiation therapy was an alternative provided to her, and that's what she received. And a couple of years later, she's still without evidence of disease. I think in someone who has a complete response on imaging, such as the other case I showed where she had internal mammary and axillary nodes, you could consider not doing radiation or surgery, but doing both axillary dissection and internal mammary nodal dissection is extremely morbid. So I think doing radiation as a consolidative approach is probably more reasonable.
Thank you.
In my opinion, if the patients obtain a complete metabolic response, as in our patients, I think that a surgical approach maybe a pathological remission. This is the most important, and then we don't use obviously a radiotherapy. If the patient do not obtain a complete metabolic response, so maybe go with radiotherapy and also.
Okay, thank you. So we go on with last talk in this session by Professor Clemens on breast implant-associated malignancies, a 10-year prospective study. Thank you.
Thank you. Once again, my disclosures are the book that I wrote last year, but all proceeds from that go to cancer research. MD Anderson participates in FDA clinical trials for Allergan, mentor, and establishment labs, but I performed no consulting since 2015. I'm going to go through 2024 updates. There has been a lot that's happened in the last 18 months since last we spoke, and also give you outcomes from our 10-year prospective outcome study on this subject, and then really dive into what does this mean for future research priorities. First off, I want to give our numbers for global tracking. As of today, April 20th, 2024, we are aware of 1,618 cases and 49 deaths around the world. This is due to our global roundtable that tracks these diseases. I'm going to call out just some numbers, though, because there's some challenges with updating numbers. We see that Brazil has jumped up quite a bit thanks to Dr. Groth. tracking, but still not as high as we would expect. We have some challenges that we rely on government authorities to give us our updates. And if they update every 2 years, some numbers can stay the same for quite a while. For instance, France, we noticed that Lymphopath is really meticulous at tracking cases, but only tells us about them every couple of years. And so that's kind of stayed the same for quite some time. If we look around the world, we see that some cases have jumped up, whereas other ones have stayed remarkably the same. For instance, Mexico staying at 14 for several years now. We just don't really believe those numbers, particularly considering it's the third largest breast implant market worldwide and one of the largest textured breast implant markets worldwide. So I'm frequently asked is, why are these numbers, some not changing, some where we know that cases are developing, the number doesn't go up. We collaborate with government authorities for some of these numbers, but it's a challenge. This is imperfect, but this is the best that we can come up with at this time. Also, I was very pleased that NCCN guidelines, in anticipation of this meeting by our special request, came out with their guidelines 1 week ago. We really appreciate them stepping forward and updating those. What I can say is that there was no major changes in management, but what did change was the richness of the information. For the very first time, they included this 8 pages, essentially a white paper on breast implant associated ALCL, current understanding from risk assessment to reliable diagnosis to treatment strategies to a statement on prophylactic explantation. Really going a deep dive that they've never done before. In addition to that, they focused on immunotherapy and chemotherapy in advanced disease. They also focused on the safety, that it is safe to do an immediate reconstruction with either smooth surface implants or autologous reconstruction, and the addition of this background and discussion through a literature search and guidance. So a big change. I highly recommend reading this. Really gives needed background for all the other guidelines. Also say during this time, same time period a few months ago, we came out with this article, which was a collaboration with Marshall Caden, developing a lateral flow assay as a low-cost method, only requiring 1 milliliter of fluid that could detect ALCL and differentiate it from benign seromas. This is a big step forward that could be done in just 20 minutes. And we hope that in the future, this will lead to rapid, low-cost tests. For instance, this on average only cost 40 cents, US cents, compared to immunohistochemistry, which costs anywhere from $500 to $600. In addition, I've showed this figure before, is how textured implants break down by all implant manufacturers. However, I've added a very big square right at the front, which was never on there before, and that is the 2024 update to the ISO classification. Big change. For the very first time, we are no longer talking about textured versus smooth implants. We need to change our vocabulary because ISO did. Now they have no texturing, intentionally textured, or what they say intentionally modified surface after manufacturing, and shell surface coating where polyurethane would fall. This is an enormous scrambling of all of our previous classification systems. And the challenge is that our previous classification systems broke down smooth by 0 to 10 microns, and then micro and then macroed everything there else after that. We had polyurethane as a macrotextured implant scramble all of that as we know it. And this new classification, unfortunately, is not have clinical ramifications. There's no studies to support this type of a classification. So we need to perform those studies ourselves to determine what does that mean to be called a no texturing? What does that mean to be called intentionally textured surface? What does that mean to be shell surface coating? Implications for anything from ALCL to capsular contracture. So enormous change that we will have to learn this new language. In addition, the last conference I had talked about this paper when it first came out, but now we have new implications that a implant surface can affect the immune system just by the surface area of that textured surface, having implications for the number of T cells as well as B cells and the inflammatory cytokines that are released. This has been accessed 10,000 times in just the last 2 years and cited 117 times. What we have not seen in the last 2 years is any further implications for bacteria as a source of ALCL. In fact, we collaborated with Harvard on this systematic review, demonstrating that there is no compelling evidence of bacteria being linked to ALCL with pathogenesis. And so therefore, it's important to realize that international clusters, as you've seen earlier today, have meticulous implant practices, rigorous follow-up protocols, proactive approach to CD30 screening, but do not recommend, they are not breakdowns in actual technique. We've also seen just in the past year, the FDA announce squamous cell carcinoma and various lymphomas. And so we now see a spectrum of disease that can develop from mostly textured surface breast implants, which leads us to our prospective 10-year study. In 2014, we did an IRB study studying all the patients that we treated, and we have 79 BIA ALCL patients that we treated to date with moderately good outcomes. So we do have one death of disease. When we compare ALCL outcomes globally to our own MD Anderson, statistically they're equivalent, but I have to say ours are a little worse. I attributed that to we're a tertiary center, and a lot of times we're getting reoperations that have been treated outside or more advanced diseases. But in general, this is what you can expect survival with, which is usually pretty good. If we look at our squamous cell carcinomas, we have 21 cases, both in the literature and that we've treated to date. Vast majority, 95% being textured surface. So while there is some smooth surface implants, it is a vastly majority textured surface phenomenon, just as we've seen with ALCL, and that's not been previously reported. We also see that squamous cells tend to be mass at presentation and sternal pain as the symptom, not necessarily a fluid collection. This just demonstrates one patient. We do recommend 1 centimeter margins at time of excision, which is more extensive than ALCL, usually requiring a chest wall resection. So we usually say include a thoracic surgeon and a thoracic oncologist for these cases. Also, we have picked up 6 cases of squamous cell metaplasia. They look very similar on pathology. It just depends on where the cells are. Usually they're marked by a P63 staining, but they're usually isolated in metaplasia, whereas they're diffuse in squamous cell carcinoma. We treat these as disease, but we're not sure if we should. We need more data on this. We only have 6 cases worldwide. If we look at B-cell lymphomas, we see that they usually have a good prognosis with 90% also, or a predominantly textured implant phenomenon, as you can see from textured to smooth, and that was statistically significant. So still seeing textured implants implicated in these disease. If we lay all 3 of these against each other, we see squamous cell carcinoma having the worst prognosis and outcomes in the long term, with B-cell lymphoma, fantastic. We're aware of not a single death worldwide, and that's inclusive of our own personal series at MD Anderson. And actually, ALCL is somewhere in between, even though we know that that's an indolent disease. This compares all 3 diseases against each other, and we can actually see very different presentations, very different markers that you're testing for, and very different prognosis. So while they all start around a breast implant, having very different pathways afterwards. Because of this, we need complicated algorithms for treatment. I've included on this slide NCCN guidelines for ALCL, but now let's expand it to B-cell lymphoma and squamous cell carcinoma. And I've color-coded it by what's specific to that disease. So squamous cell carcinoma in green, B-cell lymphoma in dark blue, and ALCL in light blue. This is in an upcoming manuscript. Most important slide, and I'm out of time. The AAPS consensus recommendations I'll be speaking about in about 20 minutes, but part of that was defining our future research priorities, both near term, midterm, and long term. Just going to call out a couple. In the near term, we must establish a registry that is worldwide for sharing of data. We must get our implant manufacturers to release their information that they already have on these diseases. It's easy, low-lying fruit that has incredibly high impact. And so I would ask the manufacturers that are at the back of the room, please consider doing that. We need that data. On the horizon is low-cost diagnosis tests, animal models, and treatment in advanced disease. Lots to come in the future. So in conclusion, knowledge is power. These are just a few of the studies that have happened over the 2 years, which seems a quantum leap. It is our collective responsibility that together, we need to work together, share our data to be able to overcome this disease. Thank you.
Thank you. Thank you very much, Dr. Clemens, for your presentation. If there is any question, there is one. A couple of questions, yes.
Hi, Mark. Thank you very much for this overview. I just wanted to point out something regarding the B-cell lymphoma that you mentioned associated with BILCL, with the breast implant, sorry. Yeah. But the point is that that kind of tumor is not restricted to breast implants. Yeah. We have several cases that now it's called fibrin-associated large B-cell lymphoma that occur in pseudocystic spaces or in association with other implants like the endovascular prosthetic, the cardiac prosthesis, pacemakers. So it is a completely different disease. Mm-hmm. And if you test this aroma only for CD30, you may miss those cases because are more B-cell lymphomas, so express more B-cell markers. So I think that to test for CD30 and the seroma could be very quick and cheap, but you should always test for the cytological, morphological aspects of the seroma to exclude the other malignancies as well as the squamous cell carcinoma. But I would just to point out that the fibrin-associated large B-cell lymphoma is completely a different disease. It is not only related to breast implants. That's
Could completely agree with that assessment. The marker is CD20, and a critical component of this appears to be the Epstein-Barr virus. So completely different pathogenesis, not necessarily around a breast implant, but because it's a seroma or a capsular space, it can occur, and we should think about it, particularly if our tests are coming back negative for ALCL.
Okay, thank you, Mark. I would like to have a clarification about the new classification of the surface that you show us, because I'm a little confused. In the conclusion, you state that the type of the surface has a big impact on the etiologies of the disease. And on the other side, the new classification put all the texturization from the nanotextured to the microtextured in the same category. So I would like to have a clarification about this fact, because you put all them together, apparently without any differences, but then finally you say that there is a difference in the etiology.
Yeah, so I am also confused. We will stop using this idea of smooth, micro, and macro textured, and we will start thinking in terms of surface area. And so we know that from 0 to 10 microns, there are no ALCL cases to date, nor have there ever been any. And then we will need to think about microtexture will change to anywhere from 10 to 50, and macrotexture being over that. We're just changing the words of what we understood before. But now as new implants come on the market, they will have to actually report their surface area. And so it's like learning a new language. You need to know, what does 50 microns mean? Well, that means that there can be some cases. What does 8 microns mean? Well, that means there's been no cases to date. So there's a lot of confusion, but we need to learn it because this is a reality now.
Thank you.
Thank you very much. We will close this session now. And may I ask the next chairpersons to... Thank you. Thank you very much.
So we will start immediately with the next session, okay? So stay with us.
Okay. Maybe we can have a program.
Yeah.
First one is Dr. Di Napoli. She's standing right over there. So.
Session on the wrong. Session 3.
Yeah.
Yeah. Ah, Jesus.
So first speaker is Dr. Di Napoli.
Okay, so we're going to move on to the next session. And the first speaker is Dr. Di Napoli, BILCL, mutation burden, and the progression to aggressive disease.
Okay, thank you very much for the invitation. These are my disclosures. So now we know that BILCL manifests primarily as an effusion, but that up to 30% of the patient may present with a tumor mass. But back in 2016, we didn't know if these two different manifestations could represent two different variants of the same disease with different clinical behavior. Then we understood that one could be just the progression of the other, with the tumor mass being the late stage of a seroma. But what do we know about the genetic that are behind these two variants of disease? Well, we know that the chronic inflammation is something that started everything. We know that antigens, which can be represented by the bacteria biofilm or the particulate from the implant itself, could stimulate chronically the T cells, which start to proliferate. But about the microbiome in BILCL, we have heard that it could be enriched in Ralstonia in 2016. But then in the scientific reports, they didn't find the Ralstonia, and they said, well, we don't know. But there is no difference between BILCL and the non-neoplastic capsules. We repeated the same work using just the seromas, and as you can see here, we actually found the same results of the scientific report paper. But going back to the chronic inflammation, we know that at a certain point, mutations in the pathway of the chronic inflammation, the JAK-STAT, occur. And these occur in up to 60% of the patients. This means that the T cells become independent of any other antigenic stimulation. But we also know the STAT3 mutation is not unique for BILCL. It is also recurrent in different other T-cell lymphomas, not only anaplastic large cell lymphomas, but also some indolent lymphomas, like the T large granular lymphocytic leukemia, in which there are 40% of cases with STAT3 mutation and is an indolent lymphoma. So we think that maybe the STAT3 mutation in particular could be an early event in the pathogenesis of BILCL. We also know that there are mutations in the epigenetic modifiers that control the transcriptions of different genes. And we know that this can occur in up to 25% of the cases. But the epigenetic mutations, again, have been found also in other T-cell lymphomas. In all of them, is thought to represent an early event in the tumorigenic process. In the clonal hematopoiesis model, which is a model in which a stem cell in the bone marrow become progressively tumor cells, the mutations in the epigenetic modifiers are early events, so are the first step in the tumorigenesis. So we can think that also in BILCL, the epigenetic modifier alterations occur earlier in this tumorigenic process. But if we go back to the clonal hematopoiesis model, we can clearly see that as a late event has been mentioned the TP53 mutation, and also that TP53 mutation have been reported repeatedly in the transformation of indolent lymphomas into aggressive lymphomas. So we think that TP53 is important for the aggressiveness of a lymphoma. Indeed, in the anaplastic large cell lymphomas, the systemic forms, the combination of STAT3 and TP53 confer more aggressiveness and a poor prognosis. We found in our case a patient with a double mutation, STAT3 and TP53, and in this patient we had a lymph node involvement at the time of diagnosis. So we think the TP53 mutation may represent a late event. But TP53 can be mutated also as a germline mutation. In patients with Li-Fraumeni, they develop earlier BILCL with also lymph node involvement. And as stated this morning by Professor Santanelli, the patients with BRCA or TP53 mutations has a significant shorter event-free time to BILCL development. So it seems there could be a risk factor for the transformation of a T cell. Indeed, the genetic predisposition to lymphomas have been reported for different genes, including TP53, but also another gene, the PALP-B2 gene. This gene is important because it interacts with the BRCA2 gene that is necessary for the repair of the DNA damage. As you can see, very recently has been published a paper in a patient carrying the PALP2 germline mutation who developed after 4 years from a prophylactic bilateral mastectomy, the BILCL. BRCA1 and 2 germline mutations and the risk of BILCL. We have the paper from De Jong, 2020, that she said that the BRCA carriers have a higher risk to develop BILCL. There's also this abstract from this congress published in Hematological Oncology in 2023. They reviewed the 526 patients with breast cancers and tested for BRCA genes, and the age-adjusted rate of developed BILCL was in BRCA mutant 11 times higher than the BRCA wild type. In Italy, there's this paper in which they had 12 patients with BILCL. One was a BRCA mutant, and the patient developed BILCL after 5 years from implantation, but the stage was PT1, so it might be possible that also the time of diagnosis may impact the stage of the disease. We know that TP53, BRCA, PALP2 are crucial in the maintenance of genomic integrity, and that if this is impaired, then the tumor cells accumulate mutation and the tumor mutational burden rise up. So you can see that BRCA and TP53 are associated with high tumor mutational burdens in different tumors, including lymphomas. We know that BILCL are genomically unstable, and the loss of chromosome 20 has been reported in up to 60% of the cases. But we also know from these two different papers that the tumor type versus the in situ samples are different. In the tumor type, there's a high rate of mutations in the JAK-STAT and in the cell cycle genes, meaning the TP53, but not in the epigenetic modifiers. And there's also an higher genomic complexity. However, in the paper from Daphne de Jong, they say that in the tumor type, there's a lower copy number number load and a lower intratumoral heterogeneity. This means that there can be a clonal selection of the clone that will become more aggressive, invasive. In this last paper published in 2023, they found a higher tumor mutational burden in 2 cases. These 2 cases have something in common, have a longer period from the first implantation to the development of the ILCL, and they also have in common mutations in this gene, the MUC16, which has been associated with high tumor mutational burden, but also to the response of immune checkpoint inhibitors. This is because the tumor mutational burden is responsible of a large number of neoantigens that stimulate the immune system. However, in the ILCL, tumor cells, we know, had some different ways to escape this immune system, with the PDL1 copy number alterations found in a good proportion of cases, and also to produce high level of the anti-inflammatory cytokine with it, which is the IL-10. So just to conclude, what we can say that somatic mutations in the JAK-STAT and the epigenetic modifier, we think could be likely early pathogenic events. Somatic mutations of TP53, conversely, may be late event. Germline TP53, BRCA1 and 2, PALB2 mutation are instead predisposing factors. Complex karyotype suggests that BILCL have a very highly unstable genome, which favor high tumor mutational burden, which has been found in tumor type, in longer time from first implantation cases, and with the presence of MUC16. In tumor type, there may be a clonal selection, so there's less heterogeneity because it has been selected the most aggressive clone. The PDL1 and the IL-10 can be instead involved in the immune escape of the tumor cells. Thank you.
Do we have any questions from the audience?
I have a question. Where do you switch now?
Okay.
Okay. So thank you for that presentation. So what you're showing is that the ones that have more aggressive behavior are more likely to have these TP53 mutations. So patients who present with mass lesions where maybe we actually get a good resection with surgery, but perhaps they're more aggressive tumors, should they be tested routinely for these somatic mutations?
I think that the time is very important, meaning if you have a TP53 mutated tumor, but you resect completely the tumor, then you may not have any additional risk of recurrence. We have a couple of patients with TP53 mutation. One had a bilateral tumor with a fusion, but after resection, and she's completely free of disease after, I think, 5 years. So it doesn't mean if you have a somatic mutation that you still have a risk of relapse of the disease. It is a different thing if you have a germline mutation, because all the cells of your body are carrying that mutation, they are prone to develop tumors. Indeed, the lead from many patients not only develop the ILCL, but different tumors as well, the BRCA carriers or the PALB2B. So it's completely different to have a somatic mutation and a germline mutation.
And then just one other quick question is about the individuals who have germline BRCA1 and 2, who we know have textured implants, who are undergoing surveillance. Would we suggest that they might be better candidates for explantation, or should we have a different follow-up strategy for those individuals? What's your thought on that?
Well, for also the BRCA mutation, it is important to note that it is not sufficient for the transformation. It just gives you a risk. So who can predict if you will acquire additional mutations or not? We can be sure. We are sure that to have BRCA mutation is a risk factor for accumulating additional mutation, but this is not something that can be surely assessed, you know? So it's something that it should be discussed with the patient. And we know, for instance, that there are BRCA carriers that never develop tumors. So it doesn't mean if you have a BRCA that you will for sure develop a BISL. So I think that you should, monitor this patient closely, maybe more than the other patients that are wild type.
Yeah, exactly. That was Ariana.
Question.
Can I? Yes. My question to be more clear, of course, skip somatic mutation and taking consider germline. So what does it mean predisposing and risk factor for being predisposing to have the incidence, to raise the incidence compared to those patients that do not show the germline mutation, or predisposing to have an early or more aggressive onset, early onset or more aggressive disease? I mean, it's a predisposal of what exactly? And the risk factor is acting on which aspect?
These mutations affect genes that control the genomic stability. It means that these genes are mutated, your genome acquires additional mutations that may impact the aggressiveness of the disease. So if you have a BRCA mutation that is germline, and then you acquire a somatic TP53 mutation, the disease will behave aggressively to me.
Thank you. Okay. Okay. You want to introduce the next speaker?
Sure. Go ahead.
Okay. So we call to the podium the next speaker. It's Dr. Wolfram. No, Dr. Highmaker.
I was going to say, okay. Hi, good afternoon, everyone. Great to be with you today, and thank you to the organizers for the opportunity to share some updates on how we are attempting to decipher the immune response in BIA-ALCL. Here are my disclosures that are not related to the study or presentation. So what we have been doing at MD Anderson is attempting to build a translational cohort of patients that have been diagnosed with BIA-ALCL. We also have a series of cases that are from patients that are considered negative. This is, of course, following a deep pathology assessment in the context of diagnosis, which is utilizing flow cytometry, tissue phenotyping, karyotyping, and TCR profiling. Whenever there are samples then that can be available for research, if you look in C&D, what we're attempting to do is look both in the tissue as well as in the seroma to understand the immune response in both locations, see where we can have any type of degree of overlap, and then try to take a deeper dive in deconvoluting the immune response using single-cell sequencing profiles. In terms of the samples that we're going to be talking about today that were available for analysis, you can see in the upset plot that there are considerable paucities in that these are retrospective samples that were available for research. So I do always encourage everyone to try to think about this prospectively. And in the next data set that I'll hopefully be updating on in the near future, you'll see the difference between what we can do prospectively versus retrospectively. But in this context, we're talking about gene expression profiling, as well as single-cell sequencing and cytokine analysis. So when we look in the tumor tissue and we try to understand the overall transcriptomic profile, the majority of our cases were not available to pass QC for a bulk RNA-seq, and so instead we utilized nanostring technology, which allows us to assess 770 genes. So you can see we obviously have a reduction in the number of transcripts that we can assess using this technology, but we are able to identify that relative to the negative cases, there is a strong degree of inflammation in BIA-ALCL positive cases. This can be reflected, of course, both with the presence of CD30, which you can see maybe here, as well as other types of pro-inflammatory genes, as well as anti-inflammatory genes. This is a very complex microenvironment, as we'll touch on in a minute. This is looking at 28 positive cases with 5 controls. Now, when we break this down and start to predict different cell types that can be present within the microenvironment, we saw that overall the level of immune infiltrate just based upon pure CD45 counts was actually fairly similar between our control cases and our tumor cases. However, the T cell scores were significantly higher in our cancer cases, as you can expect, and this was interestingly comprised of different cell types. We could see enrichment for CD8 positive T cells, we could see enrichment for CD4 positive T cells, we could also see exhausted T cell scores and some NK cells. We did not see any difference in various types of innate inflammation, such as neutrophilic infiltrate and mast cells. We also didn't see a difference in macrophages, dendritic cells, T regulatory cells, or B cells. When we looked at the ratios of these cell types within the microenvironment, we were kind of surprised to find that we had 2 unique transcriptomic signatures that we could identify. We're calling these cluster 1 and cluster 2. When you look at the differential gene expression on the right and the volcano plot between cluster 1 and cluster 2, you can see that on the left side, we have this kind of a higher myeloid population, because again, we're looking at ratios of cell types to each other, not just the specific predictions, versus other types of innate features that are interferon related, such as ISG15. Now, we were very excited about this initial finding, and so we went back to see how our patient demographics and other types of clinical variables might differ based upon cluster 1 and cluster 2. And we were a bit disappointed to find that there's no clinical difference that we can determine at this time. But we do have these unique clusters that we're going to continue to follow in our patients. Now that is in the tissue. So what about in the seroma? Do we see the same type of inflammation signatures in the seroma that we do in the tissue? And so in this context, we utilize a Luminex assay where we're able to look at the proteins that are present within the seromas. And what you can see on the left here, we received a number of negative cases from our collaborator, Dr. Caden, and we compared those to our positive cases from MD Anderson. And you see that there's actually a good degree of similarity. We have a lot of pro-inflammatory as well as anti-inflammatory proteins that are present within the microenvironment. And we were excited to see this overlap between the seromas and the tumor tissue. And we can also see how that can relate to what we can predict from what we see in the seromas. For example, here on the right in the box plots, I'm showing eotaxin 3 and eotaxin, which suggests eosinophil presence. And when we go back and look at the tissue, we can in fact identify eosinophils in the pathology. So what we wanted to do, though, is to really track the complexity of this disease at the single cell level. And so we have 4 cases that I'm going to talk about today as well, where we have both the seromas that you can see there on the left, as well as the tissue profiling on the right. Here we are single cell profiling the cells from the seromas because that was available and conducive to the assay. This is using the 10x 5' TCRC. 10x 5' RNA sequencing with TCR enrichment, because we were also interested to see whether or not we could identify a unique TCR clone or loss of the T cell receptor. Now, when we looked at our 4 cases, we were able to identify CD30 positive and CD30 negative T cells. And this was interesting to us, but also supportive by what we see within the other types of analysis that we'd previously done, where we might see some cell types that are a bit more pro-inflammatory. And you can see those color-coded in pink for CD30 positive and in the teal for CD30 negative. On the right side in the box plots in A, you can see the breakdown, if I can make this work, the breakdown by patient. You can see patient 177 has the highest frequency or proportion of CD30 positive cells. Of course, these are present in all the cases assessed. And then we also have varying degrees of CD30 negative T cells, as well as low level of myeloid cells. Now, if you look in B at the bottom, where we're understanding the TCR restrictions, we can see that in the CD30 negative cases, we actually still have a TCR that can be detected by TCR sequencing. In the CD30 positive cases, we do not. We do not detect any type of a transcript that shows a potential for the TCR to actually be expressed. Now, when we look at the CD30 negative T cells, however, we can also identify that these are not clonally expanded in this context. They are actually single or small clones that are present within the microenvironment. So very interesting biology here. When we break this down and look in C at the overall cell types that can be predicted, you can see that, for example, CD8 positivity, CD7, CD2, CD3, and CD4 are mainly in the CD30 negative compartment, where these other receptors are actually more lost in the CD30 positive compartment. Now, if we look at the expression of activation markers and inhibitory receptors in A and in B, you can also see that there's a very distinct segregation in terms of receptor expression between CD30 positive and CD30 negative T cells. We see a high proliferation and high CD25 or the IL-2 receptor expression in the CD30 positive T cells. These cells are rapidly dividing. They are responding, looks like, responding to some type of a signal that could be through IL-2, and they are very differently profiled than their CD30 negative counterparts, where instead we see more classical activation markers such as ICOS, 4-1BB, and CD69. Now, when we look at the inhibitory receptors in terms of thinking about transcription factor profiles that could be driving immune dysfunction or other types of immune regulation, such as TCF, TIM3, CTLA4, TIGIT, PD1, and LAG3, these are mainly expressed on the CD30 negative compartment and not the positive compartment. So we then asked, okay, well, what else can be different about these cell types that we're identifying in our BIA-ALCL cases? And so now we're looking at hallmarks of cancer here in C and looking at different pathways that can be upregulated in this context. We see that TNF alpha signaling is very high in the CD30 negative cases. We also see that there are signals for hypoxia response, interferon gamma response, P53 pathway activation, whereas in the CD30 positive cases here at the bottom, we're seeing more signaling related to glycolysis. We still see hypoxia. We can also see a high rate of proliferation, which is reflected again in the genes that I'm showing you in A, as well as in the previous slide. And then we also see that IL-2 STAT5 signaling, and again, really reflecting that these are actively cycling cells that look a little out of control. So in a quick summary in the last 50 seconds, what we're seeing so far in this cohort is that within the tissue, when we look at positive and negative cases for BIA-ALCL, we see a very complex microenvironment that's comprised of different types of cytotoxic cells. These can be NK cells, these can be CD8 positive T cells, and we also see very complex degrees of inflammation as well as the anti-inflammatory response. We see, as expected, a large degree of CD30 expression. This cytokine microenvironment, again, heightening the complexity here, is very complex, but interestingly similar between seroma and tissue. And when we look at the single cells sequencing within the seromas, we can see unique immune clusters that are really comprised of various T cell subsets, as well as myeloid cells, and these CD30 positive, very hyperproliferative IL-2 receptor positive cells. Finally, we have our clonality analysis that shows very minimal oligoclonality and, in fact, the lack of a TCR in our CD30 positive cases. And we have very different expression receptors and hallmark pathway regulation in these cases. So in terms of what we're trying to do now is to just confirm using multiplex immunofluorescence of our cell blocks from the seromas, the findings that we have with the single cell sequencing, and then to publish these findings. And then really trying to take now this a step forward and doing this in a prospective fashion to see if we can utilize single cell based technologies to track tumor origins, as well as trying to track specific alterations, similar to what the speaker before me was just discussing, and how we can relate this back to clinical severity. And then finally, within the malignant and reactive cells, how do they interact in the microenvironment? We actually don't know. And so now we're going to be applying some high degree imaging and spatial analysis to try to understand those interactions a bit better and how some of these cell types might actually be talking to each other. So with that, I would like to just say thank you to everyone that is involved, our amazing BIA-ALCL team. The work that I described on the single cell side was led by Dr. Tomczyk and my team, our biostatistics group, as well as our hematologic pathology team and our collaborator, Marshall Caden. Thank you so much, and I'm happy to take any questions.
Thank you. Sorry, it's just something that is not clear to me. What do you mean for CD30 negative T cells in the seroma? Are the reactive ones the normal ones?
Yeah. We don't know that for 100%, but we think they might be. Yes,
exactly.
That's the way we're thinking of them. But
So you are
I'm hesitating to call
exactly.
them that.
So they are, not TCR rearranged.
Yes.
They do not express CD30, so they are normal T cells that are,
Yes.
Within the inflammatory background.
Exactly.
Okay.
Exactly. And we think that's probably also some of the source of some of the pro-inflammatory cytokines that we're seeing, right? It matches in kind of what we're seeing across the tissue in the seroma on the cytokine front.
Exactly. You know that we show in the mouse models that IL-10 and IL-6 were both produced by tumor cells that we injected in mice.
Yes.
So at least part of these cytokines are produced by the tumor cells.
100%.
Then the others can be also, acquired by the other cells. For sure.
No,
Okay.
absolutely.
Thank you.
Yeah, completely agree.
Thank you, Kara, for summarizing this as well as leading this laboratory effort. I just want to relate it back to pathogenesis. With it being so complex between both the controls and the positive cells, trying to differentiate or tease out something that's different is incredibly challenging. Can you say anything about what might be a driver, part of the pathogenesis? It looked like you said IL-2 was different. Is that coming from somewhere else? Does this imply what the cell of origin is? I'm just trying to relate to how we can take away this information.
It's a great question, Mark. So in terms of the cell of origin, we don't have enough cells. We've tried to do some lineage tracing to see if we can identify a cell of origin, and we really need more cells. That work is currently underway, and we're going to also be trying some single cell ATAC profiling to identify certain chromogenic marks that might be changing through disease progression. We've spent the last few years building up a data set where we can profile at the single cell level the cells from the tissue as well as the seroma, because that's a big paucity here. We can't apply these techniques into a fixed tissue setting. There are new technologies available that might allow for that in the future, but they're not geared towards analyzing this disease. And so that is something that we're hoping to be able to address with the second series. And then in terms of the high cycling CD25 positive cells, they lack a T cell receptor. They have CD30. They look very malignant. Where the IL-2 might be coming from could actually be the reactive cells in the microenvironment. I can just say that they have a high upregulation of that pathway. And so they appear to be really utilizing that in some way. And we can see IL-2 on the protein side as well. But it could be very easily coming from other cells, not necessarily the tumor.
Thank you, Dr. Haymaker.
Thank you.
So our next speaker is going to talk about the common pathway, immune-mediated chronic inflammatory reactions to a textured surface, Dr. Wolfram Braunecker.
So good afternoon, ladies and gentlemen. I think you can relax a bit. So we are switching back from breast implant-associated ALCL, next gene sequencing, to a bit, let's say, understandable topic for us as surgeons. Sorry to state that. This is my disclosure, and I think it's important now to state that because we had this, I think, an important discussion. So my work within the last years has been funded by establishment labs in the form of study materials, means implants, and as an educational grant. But I am paid by the medical university, and I don't receive any funding from the company. So I'm not into breast implant-associated ALCL. I'm more the one who's interested in capsular fibrosis. So our group clearly postulates that fibrosis is always a sequel of tissue injury. And this injury leads to inflammation. And in case inflammation is not resolved, we kind of have chronic inflammation finally funnel into fibrosis. So we were able to show in several publications that when you put in an implant, expander, implant, whatever, we don't know what the exact cause is, but we know that biofilm formation, silicon particles, eventually also proteins that are here on the surface and then are altered, kind of activate the immune system. And it's mainly the unspecific or the innate immune system that is activated. And so these macrophages are able to activate T cells. And what we found in the capsular tissue is a Th1, Th17 immune response. And these cells produce the profibrotic cytokines and lead to the kind of formation from fibroblasts to myofibroblasts. So within the last kind of 5 years, also due to breast implant-associated ALCL, I kind of focused interest more on the immunobiocompatibility of surfaces. So the first project was an in vitro project, and we received several surfaces, important empty shells. And kind of we punched out these shells, put them into a 24-well plate. And what we did, we took peripheral blood mononuclear cells from female donors, and we incubated the surfaces with RPMI, with cells. And after 4 days, we said, let's measure with what these cells are doing. So a very important finding, I think, for the whole industry was and is that no surface does kind of induce or alter the number distribution of T cells. However, on some surfaces, as you can see, the immune cells seem to produce more pro-inflammatory cytokines. In parallel, in 2021, I think an important publication came up, and this was the work by Josh Doloff and his group. And they were looking into the question, how does surface topography mediate, change the immune response? And as you see here, this study was mainly undertaken in rodents, and they could clearly show that the surface influences, first of all, capsular thickness, and the surface also influences the amount of CD68 positive cells within the capsular tissue, means macrophages. So higher texture, more macrophages within the capsule, but inversely, kind of with the capsules where you, around a smoother implant, you see more FOXP3 positive cells. These are kind of the T regulatory cells, and these are, for us, the good guys, as you can say. So they are the positive ones. However, we have to state that this was mainly prospective, mainly done in rodents, and I think many immunologists would say, do not compare the human system always to rodents. So what we did is, let's go in vivo. So we performed an intra-individual analysis, namely with 2 different devices, 2 different structures, and we included 7 women undergoing simultaneous prophylactic nipple-sparing mastectomy and expander-based breast reconstruction. So healthy women without no cancer. And we randomized the textured one versus the smooth one to either right side or left side. So for the design, only pre-packed, we said, okay, let's go to pre-packed. We don't want to mix it up. Pre-packed for the expander placement. And we combined it with this Teton bra bucket. Why? Why not with ADM? Because here in Europe, specifically in our area, we don't use so much ADM. I mean, a lot of gynecologists, a lot of people use this Teton bra bucket. So this was the thing. So this study has 2 arms, you can kind of say. We wanted to know what happens within the first days when we put in these expanders, when we put in the different surfaces, and we collected the drainage fluid, And we analyzed kind of here, what kind of proteins do we find? What about the immune system? What about inflammatory cytokines, profibrotic cytokines? And in the next step, after 6 to 8 months, when we exchange the expander to the definitive implant, we have access to the capsular tissue and we have access to the expander. So what we did is, first of all, analyze not only capsular thickness, composition of capsule, inflammatory response, but we also wanted to know what kind of proteins adhere to these expanders and are there differences in the proteome, let's say, on the expanders. So these are the early results. First of all, interesting, we saw within the first days in the drainage fluid differences between right side and left side. So it means that the protein or the proteome around the smoother device kind of resembled decelerated, modified, kind of better, smoother immune or inflammatory response. And we saw right side versus left side, less expression of interferon gamma and also IL-17. And the same thing could also be seen within 6 to 8 months. First of all, when we kind of stripped the expanders, we saw, okay, we have a lot of proteins, common proteins that bind to both expanders, but we see also difference, kind of a bunch of proteins only like either surface, you can say. More important, the same story that Dolaf already showed in the rodents. We also see more FOXP3 positive cells connected to this smoother device. And important for us as surgeons is, what do patients say and what does the surgeon say? So first of all, surgeon was more satisfied with the footprint generated by the smoother device, and also the patient said the smoother device feels better. This expander, this side feels better, more comfortable than the other one. And before we did the exchange, means expanded to implant, we also assessed via ultrasound seroma formation, and we saw less fluid around the smoother device, and also immunohistochemistry confirmed that the capsular thickness is kind of thinner with the smoother device. These are some samples, kind of, you see the woman with 2 different expanders. A lot of people ask me, how did you get this through the project that the woman has 2 different devices? And do women want to do this? And I didn't have to convince any woman, because I told them, you know what, after the 6 to 8 months, probably we know how your body responds and how what is kind of better for you. And they really all agreed to undergo this procedure. What was important? The most important thing as a kind of side effect was that the most immunogenic part was the Teton mesh. Independent of the texture, the mesh was the product which is kind of highly immunogenic. So this is kind of next project where we also want to have a look on meshes, because I think we must consider and we must think, what do we put into the breast and what might come out also long term. So I need to say thanks to a lot of people here, specifically my postdoc, Dr. Schoberleitner. She did a great work within the last 4 or 5 years. And I hope to continue this work and to come up with new data. Thanks.
Do you have any questions? Or I'd like to hear your thought. If the mesh increases inflammatory response, what do you think ADM does? I would think that if you put a dead piece of skin in someone, there's going to be a lot of response. Yet people say that the capsular contracture rate is lower.
Interesting point, and we were kind of thinking of doing this. The problem is in Europe, or specifically Austria, but also in Germany, that we don't have so much access to ADM. We don't use them. Also, the the hospitals say, okay, it is very expensive. We're not able to go for that, honestly. So I think the market in the United States versus in Europe is here different, and we try to do that. But without a mesh, it's like within a following study, I probably want to go for Galaflex because this is a thing a lot of people nowadays use, and I want to just check what's going on with that.
Hi, great presentation. I was wondering, given the importance of the surface architecture, do you happen to have any idea of what the surface of the mesh might appear like, or what the properties of that material might look like?
The first thing with this Titan, I mean, I don't use the Titan mesh because it's not degradable. I think if you use a mesh, I absolutely favor things that are degradable and do not stay in the body. This is what I think and what I will prefer.
Quickly answer to Peter, I think he asked. Well, ADM has been demonstrated to polarize macrophages in M2, so it's anti-inflammatory, the ADM. And so far, there is no cases of BLCL with ADM.
Okay, we can go on with the presentation and call Dr. Pitenis.
Hi, I'm really grateful to be here. Thank you so much to the organizers, Mark and Fabio. I'm delighted to be here. And I'm in a fantastic session, so thank you so much. Now for something completely different. My lab is located at UC Santa Barbara. Please do give us a visit. I'm a tribologist by training, which means I study friction, lubrication, and wear of sliding interfaces. And my current focus has been on biotribology. How does friction and lubrication work in between device tissue interfaces? And so I have some disclosures. My group is funded primarily through government organizations. Currently, I'm only funded by the government, but I did work with establishment labs. And so much of the work that you'll see today came from a collaboration between them and our group. And they provided us with samples, and they just helped us with securing some research dollars to do the work. But I'm paid by the university. And so we all understand that texture is important, not just for engineering applications, but also for implants. And so as a mechanical engineer, I'm coming at this from a very surface science kind of perspective, and recognizing that the breast implant is a device, much like any other biomedical device that we put in our bodies, but it's primarily the largest that we put in our bodies. It has the largest surface area. It has the most engagement with cells and tissues, and it's mobile. It's going to be moving in the body. People are moving. They're going to move against this interface. So what do we do about it? We can look at the surface. We can look at it top down, but to me, I think it's most informative and helpful to look at it in cross section. So here are some breast implants that we've taken from commercially available products. I'm not going to give you any product names, just the roughness. So this is the average roughness reported over all these different types of implants. But it's helpful to know where these numbers come from. So we use the average roughness, RA, even though there are about 40 different parameters that you can use. This is probably the worst parameter, but it's what everyone uses. So we're going to use that one. And even in the bottom left, you can see that we use an old ISO standard for how we start to characterize these surfaces and qualitatively describe them as smooth or microtextured or macrotextured or now intentionally textured, which is interesting. So now we have to ask ourselves with these very poorly qualified terms, what is the link between surface roughness and BIA ALCL? And so in my lab, I use multiple tools, one of which is the atomic force microscope. We use optical profilometry and stylus profilometry, and we can get really good data from the surface. This is an example of an elastomer. This is some kind of a sphere, and we used optical profilometry to get out a surface roughness. But it's helpful to look at, again, in perspective. What are these surfaces doing in contact with cells? Here I've drawn to scale what some cell layers might be doing in contact with some of these very rough surfaces. And so on the left to the right, you can see as we increase the surface roughness, that elastic modulus of the surface texture of the implant side is not going to change. it's going to be much stiffer than the cells. And in fact, if you make it so rough and so textured, they might be poking into multiple cell layers, and that those regions of high contact pressure could actually damage soft tissue just in static contact. On the bottom, you can see these are profilometry scans. These are optical techniques. And so for these extremely textured surfaces, if we're measuring and documenting these roughnesses that are derived from optical techniques, you might be missing a lot of data too. So looking at the surface area is extremely important, but how we make these measurements is equally as important. And so when we talk about pressures and stiffness, what I really am thinking about is elastic modulus, which is a measure of a material's deformation to a load. And so on the right-hand side, you can see that there's a scale of elastic modulus for multiple different materials that you might find in a picnic. Perhaps when you're enjoying yourself in Italy, you can enjoy some beautiful wine and some cheese. But most breast tissues are softer than 1 megapascal, which is the starting elastic modulus for the shell of a breast implant. Now, in total, the sum of the elastic moduli of a breast implant, it's multifactorial. You have often a liquid inside or some kind of a gel inside. That all changes its rheological and mechanical properties. But to the cell, which is only really concerned with the shell is going to be much stiffer than the tissue. Okay, so I talked about sliding. So what is sliding? To me, I'm a turbologist. I'm looking at friction. And so the friction coefficient is really a ratio of two forces. It's the friction force, here resistance to motion, that force, all divided by the normal force, which is your applied load. And what really matters is the surface over which that interaction occurs. So the surface area really matters. Of course, in the breast pocket, that buried interface pretty much precludes any kind of real measurement of the surface area, but we can make some estimates. On the right-hand side, maybe you can see this is friction coefficient as for multiple different types of interfaces. Friction is a systems property. You can't look at a material and tell what the friction coefficient is without doing the measurement. And everything impacts friction. Contact pressures, sliding speeds, the material pairs, everything impacts it. There's no first principles derivation of friction coefficient. It's still a mystery. But we're trying to do it experimentally. So let's continue. We use turbometers. These are friction measuring devices that we build in the lab. And we mount them onto confocal microscopes so that we can make measurements of device tissue interfaces in vitro with cells. So on the right-hand side is a blown up image of one such experiment where we have a control well where there's no friction and another well that is subjected to friction. These are all cells in monolayer that we can grow. On the top right is really the heart of the instrument. This is a double leaf cantilever assembly, and it allows us to make measurements in the normal force by applying loads. This cantilever deforms just like you would if you're going off on a diving board. You're bending that board. That's your load. You're deforming it, and you can measure that deformation. But you can also do it in the tangential direction too. And so the friction coefficient that we know and love, the ratio of those two forces, is great, but a scalpel is a really low friction coefficient. You would not want a scalpel kind of material against the tissue. You'd want a low frictional shear stress kind of material, which is a combination of low friction coefficient and low contact pressure. So spreading those contact areas, distributing those loads, reducing contact pressures really matters. So let's do some experiments. So let's make a tissue. We have no tissues in our lab. We're going to make our own. We're going to deposit some collagen on polyacrylamide gels. We can tune the elastic modulus. We can match the stiffness of the breast pocket. And then we can do some friction loops. So this is an example of that friction force as a function of position going forward and reverse. And so we can see right away that the friction force as a function of position is not really that dependent on the average roughness. Looks like it's kind of, random. That's interesting. But again, it's not really all about the friction coefficient. It's really about the frictional shear stress. Here's a video showing the collagen that we've dyed in green for the topmost surfaces, the 0.2 micrometers surface roughness. That one on the bottom, middle is the intermediate, and one on the bottom is 32 micrometers. This just tells you that the collagen that was deposited on our polyacrylamide is getting removed much quicker than the others. You can see in the black is everywhere that collagen's been removed. More roughness or higher surface roughness for us is more damage. And so this could be a proxy for what could be happening in the breast pocket. Again, we know that we're not dealing with tissues here, so we also grew cells. We grew cells in monolayer. These are MCF10As. These are breast epithelial cells. And we ran the exact same experiment. And so this is after testing. You can see that on the top, where you see little specks of red is where dead cells are. It's a little bit helpful to show that those cells on the bottom were removed. There were no flecks of red that you can see because those cells are gone. They've been completely delaminated. So again, increasing surface roughness, increasing cell damage. And so what's interesting here is that, again, it's about the frictional shear stress. You want to reduce friction coefficients and reduce contact pressures in concert. And all of this will basically increase as you increase your surface roughness, whether you're having implant collagen interactions or implant cell interactions. In our lab, we've also done gene expression profiling on another types of cells. We've used corneal epithelial cells, and we've demonstrated that by increasing the magnitude and duration of sliding on these cells, using even hydrogel probes, by changing that frictional shear stress, you can increase gene expression for pro-inflammatory and pro-apoptotic gene expression. And so on the left-hand side, you see that huge increase, percent change in IL-1 beta, IL-6, MMP9, DDI2-3, and FAS, which is generally quieted under low frictional shear stress conditions by half. And you can also reduce it by just sliding for fewer cycles. Okay, great. So we've got a little bit of in vitro data. That's well and fine, but what's really happening is, I think, a combination of these very fragile, rough surfaces and their tendency to potentially break off and become instances of wear debris. And so we've all reported, at least I've seen it, that debris winds up in the capsule. Debris kind of just floats around. Maybe it's an elastomer, silicone debris, maybe it's something else, but debris, I think, matters. And so to accelerate the production of wear debris in our lab, we slid two surfaces against each other. We slid an implant against an implant. And that's the most tribologically challenging environment that you could possibly imagine. This is the worst case scenario. It might happen during a fold or some kind of a wrinkling event that you might actually see in the body. But here we took all the different roughnesses from 0.2 all the way to 80 micrometer surface roughness. When we do this measurement, we see that right away, as you increase the roughness, you increase the frictional shear stress. That smoothest one, by the way, is not on here. It just stuck and it would not move. All that to say, to make an actual measurement, this is what we could do. So what we found is that the wear debris particle count for the highest surface roughness sample correlates roughly with the range of macrophage phagocytosis. So to confirm this, we took the debris and added it to some bone marrow-derived macrophages, about 50,000 cells per well in a 96-well plate. And we ran an assay. We used PBS as our negative control and bacterial lipopolysaccharide as our positive control. And we found that, yes, macrophages are consuming our wear debris. They're consuming our silicone particulates. We can tag the silicone with rhodamine, and we can find them with confocal microscopy. More than that, we can see that from the data from our BD mouse inflammation kit, that the debris from our 80 micrometer surface roughness experiment is in excess, significantly in excess of what you'd find for LPS, which is known to provoke the immune response. So we also see shape changes. The debris seems to make the macrophages more round, much more circular, which kind of is an indication of apoptosis or going into a more cell death kind of a state. And moving forward, we're going to do this for other types of implants as well, looking to continue collaborations, and I'm happy to take any questions. Thank you.
I think we have time for a question. No question?
So what were the different surfaces, the smoothest versus the?
I'm happy to talk about that. So the smoothest one was an Allergan surface. The middle one was an Establishment Labs surface. The 32 micrometer surface roughness one was a Mentor, and the far right was another Allergan that is no longer on the market.
So the smoothest surface, least inflammation, for my simple mind?
Maybe. Sometimes you need a little bit of roughness just to separate those two surfaces too. The super, super smooth ones seem to be completely stuck. And maybe that could have led to higher static friction. That may have led to some debris, but we never got a chance to make that measurement. So from what I could tell, lower surface roughness is good. Maybe need some surface roughness, especially for handling purposes and positioning.
Good afternoon. Thanks very much. What a fabulous presentation and piece of research. Something I didn't even know you existed. It was amazing. But one of the questions that came up this morning when we were discussing capsular contracture and the effect of elastomer shells, one of the big issues, of course, is gel bleed and the whole aspect of gel bleed and how it affects capsular contraction, the inflammatory response and everything else. And have you looked at that as well?
Not looked at gel bleeding, but I'd be willing to give it a try in our in vitro models. Our cells don't say ouch. And we can run through lots of cells.
Okay.
So the last speaker on the program is not going to join us today. The last speaker won't be joining us today. So the last speaker in the session today will be Dr. Sortes.
Thank you very much for the invitation. I would like to invite myself to the 10th International Breast Surgery Workshop and the 6th World Consensus Conference on BLCL in Tampa next year. I invite you, of course. So I think that this session is very important, and it has been very important since the first World Consensus Conference on BLCL, and we all expect some kind of definitive answer. I don't think we have it yet, but let's look at some of the things that we talked before. So I'm going to focus my talk on some etiology theories and mainly friction. I'm going to give you some background. These are my disclosures. So during the first World Consensus Conference on BLCL, there were 4 talks about etiology, and it was Professor Di Napoli speaking about genetic background, Susan Turner about reactive compounds, Alan Diva thing about biofilm, and Dennis Hammond about particulate. So leaving apart genetic background, which was something that, you know, we can't put it together with etiology itself, we can say that all those theories are connected to chronic inflammation. And then we have the SHARE committee and the following World Consensus conferences, and we spoke about the same things, but we added friction in the game. And again, chronic inflammation is where it all converges. So regarding the reactive compounds theory that was proposed in 2019, the whole thing is based about an AH receptor that is expressed on BALCL cells, and this means that maybe a specific chemical that is present on the surface of the implant can be what triggers the whole thing. There is currently no evidence about that. We didn't find anything else after that study, and I'm not aware of any studies confirming this etiology. Then we have a very interesting theory, biofilm theory. We discussed this theory in the conferences, and we debate a lot. There's this study from who said that Ralstonia species are present in BALCL capsules. This is a theory that has been reproduced widely to explain the whole thing. And then Mempin also said that there is a lipopolysaccharide stimulation, which increases the proliferation on BALCL cells. The fact is that other studies found completely different results, the opposite. So we have Walker, who said that there is no bacterial diversity of bacterial microbiome in the different capsules, and then that he found Ralstonia species being more present in control capsules compared to BALCL. And then a systematic review with Mark Clemens as a co-author revealed that there is actually an absence of evidence for a link between bacterial biofilms and BALCL. So the whole biofilm, I would say, etiology has settled recently. We don't have any new studies confirming that. And if you see, for example, animal studies, they've actually found that when you're testing different surfaces, you have thinner capsules, less inflammation in the smoother side of the capsules compared to polyurethane and textured, even if you inoculate the animals with bacteria and you give them or not give them antibiotics. So I don't think this is a factor. Now, the whole biofilm theory has also been discussed. when we are talking about specific cohorts like the one that Dr. Cordero presented with a prevalence that was really high for everybody, got everybody scared. But of course, he has an oncological cohort and there are genetic mutations. But then another study came out which is a pure aesthetic cohort and found more or less the same prevalence. So, what should we say about that? Of course, everything goes down to poor surgical technique and the whole pure institutional hygiene concept that was, repeatedly, unfortunately, reproduced. So let's leave biofilm behind, I think. Now let's talk about particulate, and Angela spoke about it a bit. So we know that surfaces might shed particles, and this would lead to frustrated phagocytosis and inflammation. There is this interesting work about particulate shedding in orthopedic implants. What's weird about those implants is that they shed a lot of particulate. And although they do that, we don't have cases, similar BLCL-like cases with orthopedic implants. We have some, but we don't have the same numbers that we see with breast implants. So it might be the anatomical position or it might be something else. In our study, where we tested different surfaces, we found that microtextured surfaces produce thicker capsules and increase inflammation, which could be explained with particulate, although it is hard on this animal model to identify that. But what we also saw is that we found synovial metaplasia, and synovial metaplasia together with inflammation is actually a defense mechanism against friction. If we look a bit about also what Dr. Wolfram spoke about the immune system and how it reacts with a foreign body, we know that macrophages can be polarized into M1 pro-inflammatory and M2 anti-inflammatory. I'm not going to bore you a lot with that, but what we found in our study is that both the microtextured surfaces behaved worse. So they had a decreased number of anti-inflammatory macrophages, both at 60 and 120 days. And that was really interesting to us. And if we look at other clinical settings, there are studies regarding human atherosclerosis, and they found actually that the stable part of the plaque is more populated with M2 macrophages compared to the part that is exposed to stress. And another study also confirmed that, saying that the anti-inflammatory macrophages are more prone to be present where there is shear stress. And shear stress is what Angela spoke before about friction and tribology. Now, something very interesting that I found in literature the other day when I was preparing this presentation is about ADMs. And of course, we can disagree about how useful they are in breast surgery, aesthetic, or reconstruction. But it has been demonstrated that they create a pro-regenerative microenvironment through downgrading M1 macrophages and promoting M2 polarization. And as of today, as far as I'm concerned, maybe I'm not really informed, there are no cases of BLCLs where patients had ADM. And ADM will not protect you from particulate, but it might protect you from friction, which is a very important factor, as we discussed. Now, there are a lot of studies, in vitro studies, that they say that textured silicone implants create higher frictional shear stress, and that shear stress will lead to fibroblast apoptosis, and shear stress will lead to pro-inflammatory cytokines, and that the foreign body reaction is actually driven by those forces that are generated at the implant surface. We know how important those forces are. And Hal Finlay noted first that biocell capsules, those high macrotextured capsules, created these weird double capsules and laid seromas, and she herself couldn't explain and identify an infectious or a biofilm etiology on that, as she thought it was a mechanical problem. So again, the friction here. Now, in our study that we published a few years ago regarding a review of the 248 cases of BLCL present in the literature, we found first that, and it was later confirmed by other studies, that implant replacement delays the incidence of, reduces the risk and incidence rate of BLCL and prologues the event-free time. So we can see that we are moving forward the problem a bit. So when we put new implants in, we should increase particulate. This is how I see it. But we should have a shorter event-free time. But when you put a new implant in, you have this period, I call it the honeymoon period, where you have some small seroma and there is no friction. That's why I believe friction is more important than particulate. Now, you all seen this study presented this morning by Professor Santanelli di Pompeo, and where we analyzed and did the case control study. What I take from this study that I would like to use in my talk is that BMI was strongly associated to higher likelihood of BALCL. Breast implant volume was positively associated with BALCL, and implant replacement from a texture to a smoother implant will lower the risk of BALCL. And for me, this is all something that is controlling the friction and the forces that are between the two surfaces. Now, in conclusion, I say that we should go back and look at what we discussed a few years ago in the first World Consensus Conference. I say we should still keep looking, yes. I don't know if Professor Di Napoli will bring us news from the genetic background in the next years, or someone will come up with a chemical that will explain the reactive compound theory, or someone will find a bacteria present only to patients with BALCL, or if someone will explain the particulate theory. But I believe that we should focus our study on what is happening between the two surfaces and the friction and the chronic inflammation. Thank you very much for your attention.
Do we have any questions from the floor?
Okay.
Time for the break. No?
Angela.
Great presentation. Given the interest in friction, I was wondering.
You are the expert.
I was wondering what the community feels is more valuable to have animal models, human clinical studies, in vitro models. Is there a perfect model that you would like to see that would be addressed in the scientific community?
Well, I think I like your question. So the thing is that we all started studying implants and their behavior together with BALCL announcement. And I think we are stuck at a point where we are too much in the lab, you know. So I think the next step we think, and that's what we're doing, is to study real capsules and create studies that will analyze the same parameters we see in the animal models on human real capsules, you know. So I think that's where we can work. Regarding the friction, I'm open to discussion. We can collaborate and do something together.
Wonderful. Thank you. Looking forward to it.
Great presentation, Michael. I have a question. You said that if you replace an implant, a texture implant with a smoother implant, you will reduce the friction. But do you think that it will be enough to reduce the risk of BILCL? Or do we need to remove also the fibrous capsule that was formed around the textured implant?
Okay, you're right, Ariana. So, of course, I think that we need to remove the capsule for sure. And I didn't say that texture to smooth reduce the risk. Professor Santanelli said, and he studied. So I'm quoting that. Yeah, but I agree with you. I would definitely think that we should remove also the capsule. We need to remove that tissue there.
Because the effect of that friction could be still there.
I agree with you. Okay.
I guess time for the break. Thanks.
So coffee break, 15 minutes. No. So for the next session, who is participating for the Q&A? So the authorities and the presidents of the societies, they should sit in the front row. Thank you very much. Okay. I would like to speak about BAL.
just a section, and then I'll say the names.
So thank you very much to be here to the end. So we will start the BACA government authorities guidance and perspective and the National Society to give the voice to the National Society. The session will be moderated by Mark, Clemens, and me. And yes.
Yeah, and we're also joined by society representatives, which will be able to join the discussion as well. We want to first say how much we appreciate how many societies endorsed this conference and its findings. And I particularly want to just go through the representatives. And I apologize on my pronunciations right now. Eurosecon from the Slovenian Association of Plastic and Reconstructive Surgery, Elias Athensapoul, Hellenic Society of Plastic, Reconstructive and Aesthetic Surgery, Abdulia Canadas from SECPRA, Augusta Cardosa from Portuguese Society of Plastic, Reconstructive and Aesthetic Surgery, Cenk Demirdevur, Turkish Society of Plastic, Reconstructive and Aesthetic Surgeons, Frank Dutil, French Society of Plastic, Reconstructive and Aesthetic Surgery, Alexandru Georgescu, Romanian Association of Plastic Surgeons, Ricardo Gionta, Espras, Henrik Mank, German Society, Nenad Stepik, Serbian Association, Andrei Suko, Czech Society of Plastic Surgeons, Dolores Wolfram, Austrian Society, Daniel Yankov, Bulgarian Association, Rado Zik, Croatian Society, Dirk Schaefer, Swiss Society, Jack Kelly, IAPS, Irish Association of Plastic Surgeons, and Raitis Rimdaika, Lithuanian Plastic Reconstructive Surgery, who are either joining us in person in the front row or online. This should be a robust discussion. We'll start with a few presentations and then go on to the authority guidance as well. Let's start with our first presentation, which is on clinical updates and our understanding of BIA ALCL epidemiology by Dr. Panagiotakos.
Good evening, everybody, and many thanks to the organizers and co-chairs of this session, Professor Santanelli di Pompeo and Mark Clemens, for inviting me in this meeting. In the next 10 minutes or approximately, I would like to summarize what we know about the epidemiology of BALCL. Most of what I'm going to present have already been presented and introduced today in this meeting by several other speakers. But working in the field of epidemiology, because I'm not a plastic surgeon, I'm not a surgeon at all, I'm an epidemiologist, and I'm working in the field of epidemiology last 25 years of my career. When I was first involved in the case of BALCL, I thought that it would be an easy case because based on our understanding of cancer epidemiology all these years, assumed that BALCL would be not so difficult to understand and evaluate, at least its prevalence and risk. However, working as an expert for the European Commission, and this is my only conflict of interest I have to declare, is that I am one of those that were responsible of the opinion came from the Scientific Commission Committee on Health and Environmental Risk regarding BALCL back in 2019. I was the rapporteur of this opinion, and this was my first involvement on the BALCL epidemiology. Since then, I realized that understanding the BALCL epidemiology is very triggering and very challenging. especially when we try to evaluate which is the current prevalence, which varies extensively from 1 per 3,000 cases to 1 per 500,000 cases. And this prevalence, as you have already heard, varies depending on the type of implants, depending on the cohort study you study, depending of the profile of the patients, depending on several issues. For example, in the US, the prevalence of BALCL, according to published papers, seems to vary from 1 to 300,000 to 1 to 500,000 women. But when you focus on textured breast implants, this prevalence is much, much lower. In the data that we had from the European Commission, the prevalence of BALCL seems to be around 1 per 9,000 women with breast implants. But here we have to understand that the vast majority of breast implants in Europe are textured. Information from Australia and a very good registry that they have already there provides information about the prevalence of BALCL in around 1 per 3,000 women with breast implants across all types of breast implants. Going further to understand the epidemiology of BALCL, the published data till now refer to a median age at diagnosis of 54 years old, but this is a value with a wide range from 25 to 90 years old. And I would like now to introduce another measure that in epidemiology we call it uncertainty. Through uncertainty, we can measure how robust is this estimate of 54 years old. And the uncertainty is considered low when this percent is below 10%. So regarding what we know about the median age of diagnosis, the uncertainty is approximately 20%, which is called moderate or medium. Why do we have such uncertainty? There are many reasons reported. Maybe one of the reasons is lack of awareness among professionals. Another reason is that the patients are not also aware about this new entirety. And all this may lead to a serious underreporting of cases, making difficult to understand its real prevalence. Also, the symptomatology of BALCL varies, and this also makes us difficult to understand the accurate level of the prevalence of the disease. Another issue, which is very important, is to understand that in order to evaluate the prevalence of a condition, of a disease, we have to verify very clearly the referent population, what you usually call in common language the denominator. It is very difficult to know which is the referent population, as you already know, because the industry does not provide us the sales data. If they have provided this information, this would be an easy exercise to evaluate which is the prevalence of the disease. A few years ago, a method was proposed in order to estimate which is the prevalence of BAI in the world, using information from X-rays and extrapolating this information to the general population. This was first presented by De Boer and then validated by Santanelli di Pompeo. In few words, what they have tried is to allocate this small piece of information here on the top, in which we want to evaluate how many people in the world or in the population have a breast implant. What they have done is that they have focused on women that had already X-rays, and based on this information, they calculated the prevalence of breast implants among women that they had under X-rays. Then, using, let's say, reverse engineering, they moved back and they estimated which should be the prevalence of BI breast implants in the total population. Numerically, it seems very easy to do that because you know which is your population. You may know how many women have X-rays, and of course, you know how many women of those that they have X-rays they do have a breast implant. However, this is a very, let's say, triggering approach to evaluate the prevalence of breast implants in the total population. And why is this? Because in order to do this simple calculation, all these numbers should be independent entities, one of each other, which are not. It is not independent whether you have an X-ray or not, based on the conditions and the reasons that you are doing an X-ray. And of course, based on this dependency between N and PI, you cannot simply calculate this product of these three figures. So the evaluation of the denominator through the X-rays may seriously lead to biased estimations of the true prevalence, either underestimating or overestimating it. Another issue is the median time from implantation to BALCL diagnosis. The majority of the papers present a median diagnosis between 8 to 10 years. I tried to calculate what has been presented, and the median diagnosis, it's 9.3. However, what is important is that we have a very wide range of median diagnosis and a great uncertainty of this point estimate, which means that we have no idea, in simple words, which is the true median diagnosis from implantation to BILCL development. Here I would like to present again another figure that was already presented, I believe, today, based on a systematic review of approximately 200 cases that were retrieved from the literature by Bitoretti and colleagues. And in this review, they gave a clear identification that the median diagnosis between implantation to the development of the disease varies depending on the implant replacement or not. So when we want to understand the duration that the disease needs to be developed, we have to take into account replacement. In a similar analysis and using more or less similar cases, together with Santanelli di Pompeo, we evaluated 248 cases, and we presented similar point estimates, of course, as the Bitoretti and all regarding the median diagnosis. But we also observed that when we compared microtextured with other types of implants, the survival-free time was quite similar, which gives another view of the information. Previously, it was presented also another figure regarding the hazard density function, which is not commonly used in epidemiological studies in BALCL. What is the hazard density function? Hazard density function is a function that gives the hazard of developing BALCL through the entire evaluation period. Usually, what we see when we present data from the epidemiology of BALCL, I'm finishing, is the survival functions or the cumulative hazard function. Based on this function, what we found is that it's not a very clear association between time and development of BALCL. As we can see, the horizontal axis is in months, that we have an increase during the first 10 years, then we observed a decrease, and then we observed another increase after this. We dip further on this finding, and we observe that what we have to take into account to understand better the hazard of developing the decrease across time is that we have to take into account the number of replacements these women had. So based on this information, we provided another view of how to understand the risk of developing BALCL through time. All this has also to do with the log latency period that the disease has. In cancer epidemiology, one of our major problems is not only that the diseases are more or less rare or with a very small prevalence, but are also another problem is the duration we have to wait in order to observe a case. This makes difficult for us to establish clear risk estimates. What we need is long-term studies, and I was very happy that I heard today that there are already ongoing cohort studies based on personal data sets or hospital-based data sets that evaluating this new entity, BALCL. And probably in the future, we would have accurate data regarding the risk estimates and the factors associated. This was presented today by Cordero and Toll, and this also was presented today by, I believe, Michael Sorotos with the Polish data. These prospective studies, they are biased. It is true, because both studies are based on single centers. They are based on the approach that the surgeon had in their evaluation, and they are not, absolutely not, based on the reference population. So what we need is registries, and it was mentioned before, and this is an opportunity now that we have such authorities here to open this discussion, this conversation regarding the urgent need of authorities in order to understand the epidemiology of BALCL. Finally, as we always say, last but not least, the effect of confounding is also a serious problem, because we usually evaluate it in other cancer cases, but not in BALCL. For example, I have never heard, and I have never read in any study whether age of the patients is considered as a competing risk factor and not just as an adjusting factor. Another issue is the global variation of the disease. Today, we heard from the Brazilian data that were presented that might be a hypothesis regarding genetic predisposition of BALCL. What we can see here is something that gives us food for thought to understand why there is such discrepancy in the world in the reporting BALCL. So, conclusively, we are far away to understand the epidemiology of BALCL. It is hard to know which is the causal pathways and the related risk factors. It is very difficult to have clear estimates regarding the prevalence and, of course, the risk of the disease, the incidence. And it is very also difficult to understand all this because the number of cases is significantly underreported. Thank you very much.
Thank you very much, Demosthenes. We go with the further, then we have a discussion at the end. Thank you. Then I invite Mark Clemens. He's going to present the American Association of Plastic Surgeons consensus recommendation on BALCL.
Thank you. Once again, these are my financial disclosures. I've started lectures with this quote before, as well as a recent commentary for the Aesthetic Surgery Journal. I think it's particularly apropos to the AAPS consensus recommendations, which is that all truth passes through three stages. First is ridiculed, second is violently opposed, third is accepted as being self-evident by Arthur Schopenhauer in the late 1700s. I would add to it now, 200 years later, it was updated essentially by Joseph Overton in the 1990s, breaking down what he referred to as the Overton window, which is that ideas start in a range of unthinkable or radical, and that they go through this evolution process from acceptable to sensible to popular to policy, popular to sensible, acceptable. And it is important to understand where this window is to decide what is a radical idea versus a completely acceptable idea. One of the questions that was thrown back to Overton at the time was, he said, was it up to policymakers to push forward this window? And he said, no, actually, it's up to policymakers to figure out where this window is in the general population, and then make their rules and their policies and their recommendations based on where the people are. It's up to researchers, essentially people in this room, to push forward this window. And I would argue we today are pushing forward Overton's window for what is acceptable and what is reasonable. That brings us to the AAPS consensus, which was just published about 1 month ago. And I'll point out the society came forward to myself and Terence McCatton approximately 2 years ago asking for a white paper consensus. They said that they would fund it, that it would not be industry funded, and that any of our findings would be independent of the society. They said that we could choose 8 content experts from around the world. We chose 19. We couldn't narrow it down. We wanted every single person that had been relevant to ALCL research, driven the field forward, and could tangibly make a comment about where we should be going forward and to make recommendations and to importantly fill the gaps between when the data had shortcomings. We had representatives from the World Health Organization, National Institutes of Health, as well as major cancer centers and centers of excellence across 5 different institutions. We also had a methodologist from Johns Hopkins University who did the background information. We started with NCCN guidelines just as a general area that we could all agree on, and we tried to go beyond this in our recommendations. Our process was not just a systematic review. It was those 19 individuals taking the results of that systematic review and then going through a Delphi consensus, making recommendations based on it. And these are the recommendations, and I'll go through most of them pretty quick, but it's that the use of macrotextured breast implants should be discontinued. The surveillance of patients who received any types of textured breast implants or any implants should be followed in line with FDA recommendations. Implant manufacturers should publicly release internal surveillance data on BIA ALCL and the respective breast implants. Currently available evidence is sufficient to show a causative relationship between textured surface breast implants and ALCL. An unblocked capsulectomy is the treatment of choice. Addition of chemotherapy and immunotherapy may be considered in patients with stage 2A that is unresectable. The addition of radiation therapy, low grade, 25 to 30 gray, should be considered in patients that were unresectable or there's questionable advanced disease. And it's this last recommendation that I'm going to slow down on, which is the evidence supporting explantation as a risk-reducing procedure in the setting of BIA ALCL is limited. Explantation may be considered reasonable for patients with textured surface implants following an informed discussion of the risks and benefits of explantation surgery. It was this key recommendation that caused probably the most consternation among critics. And so I just want to point out that it specifically is about risk reducing. We're not recommending routinely that it should be performed, but that in high-risk individuals, based on the literature, that it may be considered. It's essentially giving cover to those surgeons that would do it, though not asking for widespread for it to happen. The FDA came out with a response, which we completely agree with, which it says that given the occurrence of BIA ALCL is uncommon, prophylactic removal of textured implants is not recommended in asymptomatic patients. However, individual patients should discuss possible benefits and risks of removal with their healthcare providers to make an informed decision about their health. Let's just break down the components of that, is that it's not recommended, routinely recommended across the board. We completely agree with that. However, and then it gives way for exceptions to be performed, that surgeons may take their judgment, that they may decide in collaboration with their patient what is right for that patient. They are evaluating the risks and benefits, and they are observing that risk reduction may be possible in some limited cases. American Society of Plastic Surgeons also came out with a response shortly thereafter. I've included the exact words on the screen so that there's no question about what it was saying. In general, it was saying that prophylactic explantation is not advisable for all patients. It says women are encouraged to partner closely with their board-certified plastic surgeon to create a personalized risk-benefit analysis that considers personalized goals and risk tolerance. In essence, I took that to mean that they're calling for caution, a conservative approach, and more research on this topic, for which we also agree with that, those statements as well. This response, both by the FDA within 1 week and ASPS, drove a lot of traffic to this paper with over 1,500 reads to date, just in over about a month and a half. Just with regards to prophylactic explantation as risk reduction, I won't go through this detail because you've seen these papers in other literature, but that it is mainly based on these 2 studies. Dr. Santanelli has added a 3rd study, unpublished, which we got to see this morning, further supporting this information. It does have control groups, it does have hazard ratios, and so I think that it is clear that in select individuals, it can be used for risk reduction. Importantly, in NCCN guidelines, when they updated, they also included that exact same recommendation, which is prophylactic explantation of textured implants is not routinely recommended. However, that big however, following risk stratification, it may be deemed reasonable for risk reduction in select patients following informed discussion regarding the benefits and risks of surgery. Again, completely in line with our recommendation, and they actually cited our recommendation. So diagnosis and management follows best practice standards of care performed in a timely manner. That sums up 5,000 words that are in this manuscript. The journal allowed us to do almost 2.5 times a normal article. And so I've gone through it incredibly fast, but all aspects of diagnosis and management are encapsulated in this white paper. Textured implants have a relative indication for prophylactic explantation. Risk reduction is possible in select patients. Breast implants are safe and efficacious and have a high degree of patient satisfaction at long-term follow-up. Welcome to this year's Overton window. Thank you.
Let me thank the leader of the European Association, National Society of Plastic Surgery, for the importance they gave to this session by attending it. I'm going to present briefly the EURAPS 2024 expert consensus on safety of breast implant and the anaplastic large cell lymphoma. These are my disclosure. Change it, only the picture compared to the other. So that was the project from EURAPS, and we had as a member Jan Rank, who is the Secretary General that participated ex officio to this project, and myself as the president of the project, and Michael Sorotos as the secretary of the project with non-voting capacity. So the project included more members than the APS because I wanted to be above, and so included 19 plastic surgeons, 18 European, 1 from United States, and they were the selection was done by where they were appointed by the respective national society or by EURAPS or by AAPS, so was not selected by me. And then we added 5 basic science experts. I was the president, and Jan Ranks as a Secretary General participated. So we, at the end, selected 23 members participating to this consensus panel. Of each member, we went through the conflict of interest, and we discussed any potential conflict of interest of all of this member. No member was rejected because of relevant conflict of interest. So the methodology of our consensus, we did a systematic literature review from any date to November 2023 using PubMed, Scopus, Web of Science, Google Scholar, with the following keywords. And a consensus-based discourse was used to accept, reject, or revise any statement. Delphi process gathering 24 expert panelists with 5-point Likert scale was used. Median response interquartile range were used to state the level of agreement of each statement. So we end up in 1,025 records after this systematic literature reviewed. Some of them, 500, were excluded because non-BLCL, because non on breast, because not on implant, because of duplication. Finally, we end up in 519 records to be studied and included in this project. We divided the material in 3 different chapters: a chapter of epidemiological and causal aspect with Demosthenes Pagiannotakos as chairman, chapter B, etiopathogenetic aspect, with Terence McCarthy, and Chapter C, Diagnosis and Treatment, with Mark Clemens as moderator. So the chapter, I try to go quickly among all the statements, and the one with the star, they are different from the APS statements. The one without the star, they're just confirming what was already stated by the APS. So what is the current state of international breast implant registry with regard to device tracking? And it was basically stated there are 7 implant registry that are operative at the moment so far, and 4 of them combine and they talk to each other, their data, and data from registry must be publicly available. We have to be able to have access to those data easily and by annual report from each country. Then what type of breast implant registry provide the best, the optimal BSL case tracking? Of course, the registry should be mandatory, option out, and it should be also include explantation. What are current rates of national, European, and world BLCL prevalence? And this was established as in the European Union, a prevalence, a mean prevalence of 1 in 9,000. And USA, 1 in 900. In Australia and the Netherlands, it was recognized to be 1 in 3,000. It's interesting because any of this area has a different market share of texture and smooth implants. United States, 1 in 900 is 87 or 95, the best. I mean, it's a smooth market. So what is the relationship between disease prevalence and public awareness across different countries? We noticed that countries that have implemented specific measure by increasing the awareness with tracking, and they show a higher prevalence of the disease. So there is a direct connection between information and the number of cases. What is the relationship between BLCL occurrence and any type of surface characteristic? It was confirmed that BLCL has a high occurrence for a specific type of microtextured device and uncertain for other types of microtextured device and low for microtextured device. No confirmed case for smooth implant below the 10 micrometer. There are sufficient evidence to support the causal relationship between texturization and BLCL. Yes, there is a moderate weight of evidence sufficient for a causal relationship between BLCL and textured breast implant. Is there any possibility to reach a strong level of evidence? Since we just stopped at the moderate level of evidence, it is impossible. So we cannot reach a higher level of evidence because we cannot identify the exact etiology so far, because it's a multifactorial, the disease, and implants with a higher prevalence, the microtexture, though that it's easier to have the BLCL has been banned from the market, they are not more on sale on the market, and further will be also unethical to put implants that may lead to a cancer. So can patients be risk stratified for the developing of BLCL based upon demographic for comorbidity? This is quite new and important. So risk stratification can be based on following factors: history of seroma, history of breast cancer, genetic predisposition to cancer, age at first implantation, higher than 45, number of replacement, and time for first implantation. What is the general consensus? This is just confirming what was stated before about the etiology and the theory, the genetic predisposition, chronic inflammation due to bacterial, allergic, particulates, friction, and oncogenic compound. It has not been identified a precursor so far. And what are the trigger in etiology? So patient with BRCA 1, 2 on TP53, we saw today Professor Di Napoli, they may have, they be more likely to develop BLCL or even earlier, but so far there is no evidence about this, strong evidence. And this is the same for the role of biofilm, that I would say that there is much less evidence, and it has been done more or less dismissed as a theory, you see from the arrow going down. What is the role of inflammation associated with digestion of particulate? Particulate from implants may induce inflammation, but also for that theory, there is no evidence that, that this serves an upstream trigger in the development of BLCL. It seems that it's going up the importance of tribology. So micro movements of the implant can cause the lamination of periprosthetic capsule and mechanical tear forces, which cause pseudosynovial metaplasia and inflammation. Still further, there is currently no evidence that this is a trigger for it. What is the role of implant surface manufacturing? Compounds there can lead to chronic inflammation and lymphomagenesis, but there is no evidence. What are the trigger in etiology of BLCL? What is the potential role of gel bleeding? That was not taken in consideration in any of the previous consensus statement. So chemical leaching across the implant shell may induce formation of mutagenic reactive spaces, which can cause inflammation, DNA damage. Currently, also for this hypothesis, there is not enough evidence. The ISO classification of implant surface, it classifies so far, but we saw the information that are coming from the 2024 version of the classification, ISO classification. They will mix everything, but so far we need future classification should be including a well-defined clinical relevant categorization, which seems missing from this revision of the ISO classification, should be based upon physical properties and the level of host inflammatory response more than only on the physical characteristic. What are diagnostic criteria for BLCL? It's a confirmation that you need to do a morphology, cytology, histology, the LK, CD30. So that's nothing new, just a confirmation. Is capsular, this is new because it's not been investigated before. Was a consensus. Is capsular contracture a sequel of BLCL or part of the disease diagnosis? A grade 3 to 4 Baker capsular contracture may rarely be present in BLCL, thus not representing a possible diagnostic criteria. Then what is the role of this imaging study for diagnosis? This is also confirmation as having the ultrasound and the first line diagnosis, and then we go on with the other. Is there an imaging modality to screen patient at risk for BLCL? Yeah, we have to suggest a periodic surveillance at 5 to 6 years after implantation, then every 2-3 years using ultrasound on MRI imaging. There is international recognized definition of partial, total, and block capsulectomy. And are these procedures standardized across surgeons? There is currently no international recognized nomenclature. The term radical, we invite not to use for capsulectomy. Total can be preferred synonym for prophylactic surgical management of patient at risk for BLCL. It can be divided into total intact or total not intact, depending if removed in single specimen or not. Partial, when of course part is left behind, and the term en bloc should be used for surgical management of BLCL. So what are the risks associated to specific type of capsulectomy? Partial, total capsulectomy, intact or not, have similar low morbidity rate and negligible mortality independently from their indication as for surgical management of BLCL or not. Capsulectomy for treatment of breast implant-related malignancy are associated to a possible risk of pneumothorax. What is the treatment of choice? That is still a confirmation of what was previously presented by Mark Clemens and the NCCN guideline. This is just remained the same, and class stage 3 and stage 4 also are exactly the same. Is there, that's very interesting and new statement, is there a risk reducing role for prophylactic surgery in asymptomatic patients? There was a long discussion about that statement, and finally we found a consensus of this definition. For asymptomatic patient with texture implant, routine prophylactic surgery is not recommended, and we agree also before. However, this is the most famous word will become, however, in case where other risk factors for BLCL are present or patient is worried about the risk of ALCL implant removal or replacement may be considered. So it's still a relative indication. I thank you.
Okay, now we're going to hear from the Italian Society of Plastic Surgery, Dr. Portacasa.
So thank you very much. I bring you the greeting from Stefania De Fazia, our national president of the Italian Society of Plastic and Reconstructive Surgery. And I have no disclosure related to this presentation. And some words about epidemiology in the last 10 years in Italy. On average of 59,000 breast implants sold every year to April 24, the ministerial database, the official ministerial database records was about 111 cases. Now, today we know that 112 cases of BSLCL and 2 deaths. Why I'm presenting the ministerial guidelines? Because these were released, the official data, this comes a couple of days ago, the curve of ALCL, and this data were released from the our Ministry of Health and were released to all these national societies, and our national society is sticking to these guidelines. So the document was prepared by the Permanent Scientific Technical Table established in the General Directorate of Medical Devices and Pharmaceutical Services and approved at the meeting of the 29th of November 2022. Pursuant to the legislative decree, there is an obligation for healthcare professionals to report every case diagnosed on Italian territory using the online form. All cases that may be reported must provide this information: type of breast implant implanted and the time of diagnosis, history of implants if present, retrieve information on the type of each prosthesis implant over time, including the data of implantation removal of each, data of onset of symptoms, even of only indicative, typology of symptoms, diagnosis process performed, staging of radiological and pathological disease, therapy carried out, and follow-up. What about the guidelines for the diagnostic and therapeutic process? To date, there is no indication in the absence of suspicious symptoms to carry out preventive explantation of any type of breast implant. And this could be our conclusion as well. So, you know, this was already presented. Prophylactic explantation of textured implants is not routinely recommended. However, following risk stratification, it may be deemed reasonable for risk reduction in select patients following an informed discussion regarding the benefits or risks of surgery. So we are almost on the same line. So in presence of these suspect symptoms, increasing of volume mammary tension due to a late seroma, presence of palpable mammary mass, axillary lymphanomegaly, or more seldom, Baker-4 contracture and cutaneous ulceration, in this diagnostic pathway, if in the presence of one or more symptoms listed above, the patient must be sent to a radiological center for breast and axillary ultrasound. In the ultrasound of suspicion of prosthesis rupture or in the presence of a mass, it's advisable also to perform magnetic resonance imaging and or computed tomography associated with the positron emission. In the presence of late seroma, an ultrasound guideline fine needle aspiration must be performed in an appropriate healthcare facility or in a breast unit. In the presence of a periprostatic mass and or locoregional lymphadenopathy or capsular contracture Baker-4 type associated with seroma and locoregional lymphadenopathy, the patient must be sent to the relevant breast unit for a multidisciplinary evaluation involving the specialist to charge the patient in order to plan the surgical intervention aimed at removing the mass, the breast prosthesis, the periprosthetic capsule, and examining the lymph nodes involved. And this removal must be unblocked. So what about the management of material to be subject to cytological examination? In presence of a seroma, perform aspiration at least 20 cc with a thin needle 25 gauge under ultrasound guidance and send the fresh material within 12 hours, possibly storing at a 4 degrees temperature, to the reference pathological anatomy center. If the spillage is more than 20 milliliters, a portion must be sent to the microbiology laboratory for a culture test. If not possible to send the fresh seroma, it can be fixed by adding an equivalent quantity of 10% neutral buffer formalin. The fixed material must then be sent within 24 hours at room temperature to the pathological anatomy laboratory for preparation of the smear to be stained
with Papa Nicolau methods and set embedded in paraffin. What about the material to be subject to histological examination? In the presence of periprosthesis mass and local regional lymphadenopathy or capsular contracture Becker-4 type associated with seroma, the removed material mass, entire periprosthetic capsule and lymph node must be sent to fresh, possibly within an hour, or fixed in a 10% buffer formalin within 24 hours to the pathological anatomy of the breast unit that took care of the patient. The surgeon must indicate, using reference wires, the upper pole and the anterior face of the capsule. What about the surgical procedure? The capsule, where possible, must be removed and blocked with the prosthesis. In cases where this procedure provides to be high risk, the capsulectomy must be radical, making sure not to leave any portion of the capsule in place. If necessary, to orient the sample with the suture thread, indicated the upper margin and the anterior one, and in capsule is removed in fragments, indicate its topographic location. In that case, in the present difficult to interpret diagnosis situation, all the material must be sent to one of the reference pathological anatomy centers indicated by the Ministry of Health. Every certain diagnosis must be reconfirmed in one of the reference centers. At the end of the investigation, the material examined will be returned to the pathological anatomy center of origin. What about the management of the patient with confirmed diagnosis? In the present confirmed diagnosis placed on the fine needle aspiration of the seroma, the patient must be sent to multidisciplinary team on the relevant breast unit to undergo preoperative total body CT PET examination. And in the presence of confirmed diagnosis placed on the histology of the periprosthetic capsule, the lymph node or the mass, the muscular cartilaginous tissue of the chest wall, if not performed preoperatively, carry out a total body CT PET examination at least 30 days after the operation. You know this classification, so I quit this. So in case of disease confirmed to the serous effusion to fibrin curve present on the periprosthetic capsule, infiltrating all the periprosthetic capsule in stage 1A, 1B, or 1C, removal surgery of the prosthesis and radical capsulectomy possible and block. If the resection margins are clear, RO, send the patient for follow-up. In the event that unblocked radical removal of the capsule was not possible, or in the presence of residual disease, R1, the possibility of subjecting the patient to postoperative radiotherapy or chemotherapy, according to the chemotherapy scheme we have seen this morning, or with immunotherapy in case of resistant relapses to chemotherapy. So I quit this because we've seen already this morning. And in any case, I quit this also. In the case of stage 4 disease, which is the most important thing, the patient must undergo neoadjuvant systemic therapy or with chemoimmunotherapy combined scheme. Immunotherapy should be performed in cases of resistant relapse to chemotherapy, and based on patient clinical condition, the patient may undergo surgery to remove the prosthesis, possibly unblock radical capsulectomy, and all the infiltrated tissue behind the periprosthetic capsule. Based on response to therapy, the breast unit will decide whether to perform local consolidation radiotherapy. What about the therapeutic path of the patient according to the stage of the disease? Breast implant removal and radical capsulectomy procedure must be performed bilaterally, even in case of unilateral localization of the disease. Based on current scientific knowledge, in event of diagnosis by ALCL, a replacement implant with any type of prosthesis is not indicated. In all cases, the patient must undergo clinical radiological follow-up every 3-6 months for the first 2 years, and annual check for up to 5 years. I thank you for your attention, and I thank you, the organizer, for the wonderful evening yesterday. Thank you very much for your attention.
Okay, we'll be continuing on with a new standard of vigilance and surveillance from the MHRA. The MHRA's blueprint for tracking BIA-ALCL cases and enhancing implant safety in the UK by Dr. Reeve. Dr. Reeve?
Good evening, everyone. I just wanted to say to the organisers, thank you for inviting me to speak today. It's a pleasure to be here. I've learnt a lot already and really enjoyed my time. And thank you all for those in the audience who stayed to the end as well. So my name's Sophie Reeve. I'm a benefit risk evaluation assessor at the MHRA in the UK. Sorry, I did have a disclosure slide as well. I don't have anything to disclose, but it's missing from there. Sorry about that. So this is going to be a bit of a whistle-stop tour into a bit MHRA's BIA ALCL processes, a bit of our BIA ALCL data, and our ongoing and future work. So for those of you who don't know, the MHRA is a Medicines and Healthcare Products Regulatory Agency, so we're responsible for regulating medicines and medical devices in the UK. So we ensure that these healthcare products meet acceptable standards of quality, safety, and efficacy. So my team is a benefit risk evaluation team, and we're in the safety and surveillance function, and we're responsible for the post-market surveillance for medical devices. So just a quick overview of our BIA ALCL processes. So we've been continually monitoring the risk of BIA ALCL in the UK and internationally. We received our first case back in 2012. We monitor it closely with support from our independent expert advisory group, which is a plastic, reconstructive and aesthetic surgery expert advisory group, who are known as the PRASIAG. We also have a MHRA BIA ALCL information page, which we keep up to date. As I say, keep up to date. We're in the process of updating that at the moment. Unfortunately, it wasn't quite ready in time for this talk, but it will hopefully be updated very shortly. So as I said, we work very closely with our expert advisory group, and we have representatives on this group from the three professional associations within the UK, the ABS, BARPS and BACPRAS. In addition to that, we also have representation from oncologists, epidemiologists, toxicology, and we've just recruited a lay member as well, which will be really important in giving the patient voice in this committee. The EAG is also really important in making sure that any regulatory action or any recommendations that we make is put into that clinical context and make sure that it will work in clinical practice. So moving on, the majority of our data that we collect is from adverse incident reports that are reported directly from the breast implant manufacturers, and also adverse incident reports directly from healthcare professionals and members of the public, which are collected via the yellow card scheme. Just wanted to clarify, I think maybe someone referred to the yellow card scheme earlier as the UK registry. It's not a registry, it's a spontaneous reporting scheme. So obviously has the limitations that go along with spontaneous reporting. So as you may know, this might be a little bit technical, but reports to allow manufacturers to report to the MHRA, the reports need to conform to the manufacturer incident reporting form standard, and that uses certain terminology to code the reports. And we're making use of that to improve and streamline our tracking of the cases in our database. So these reports are entered onto our Halo case management system, and then all reports that contain an IMDRF Annex E code, which is the adverse event reporting terminology within the standard for the incident reports. For ALCL or symptoms such as seroma will get flagged for extensive review by an assessor in our team. These reports then go into an extensive follow-up process with the original healthcare professional. And this is in the form of a healthcare professional follow-up questionnaire. It's also really important to note that this is like a baseline process, so we can also adapt this process for new and emerging issues. So we can amend the codes to flag them really easily for us for review for emerging safety issues. So we can capture the codes for lymphomas and cancer, so we can look at things such as SCC as well. So all of these reports go onto our database and then they're made available for signal detection. So signal detection is our process of reviewing all of the data from any available source and to try and identify any new signals of a new risk or any changes to an already known risk. So there's lots of different aspects of that. So I've already kind of covered our individual case review and follow-up, but we also do literature reviews. We do trending on all of the adverse incident reports for breast implants that we receive. And we also have a risk list monthly search. And then, as I said already, we're supported by Presiag, and we'll take assessment papers to the committee when needed. It's also important to note that the Presiag will also advise on any strategic papers as well, such as our BIA ALCL processes and other projects as well, which I'll come on to later. So I think this is probably the slide that most people have been waiting for. So this is our data up until the end of December 2023. So at the moment, we have 117 reports of BIA ALCL confirmed to meet the WHO diagnostic criteria. 103 of these were UK implantations, 6 were non-UK, and 7 we don't know where they were implanted. But we try and gather more of that information through our follow-up processes. 64 of these were primary implantations, 48 cases reported previous breast implants as well. Our average time to diagnosis is just under 9 years. 57% were for cosmetic augmentations and 31% were for reconstructive indications. We had one report with fatal outcome. The graph at the bottom there also shows the number of reports and the year of diagnosis, not necessarily when we received a report. In the UK, we've also been calculating incidence based on the number of implants sold into the UK market. We're still currently collecting up-to-date data on that. So when we're updating our web pages shortly, then we're hoping to provide an updated incidence. But at the moment, this is the incidence that's on our web pages at the moment. Moving on, the presentation of our cases, 91 out of 117 cases report with seroma, and 57% of those report seroma only. 64% are treated with capsulectomy alone, and also provided a breakdown of the surface textures for the primary implantations as well. And we've got 57 out of those 64 primary implantations that are with textured implants. So moving on to, we mentioned that there's quite an extensive follow-up process with our healthcare professionals as well. So we want to make this as easy for healthcare professionals and surgeons to report as much as possible. If it's easy to report, then it'll be more likely that we'll receive the information that we want to. I think I forgot to mention earlier, reporting to the yellow card scheme is not mandatory. So if we can make it as easy as possible for those surgeons who are obviously very busy to report, then we're more likely to get the data that we need. So just last month, we updated our yellow card reporting form for breast implants. It's the healthcare professional form, and this is to capture key information at the time of reporting. So at the moment, we send quite a large follow-up questionnaire out to our healthcare professionals, but if we could add that information, make it available for them to provide it at the time of reporting, or hopefully it will negate that need to follow up. This is adding additional fields outside of that manufacturer incident report standard that I referred to earlier. So we've added additional questions and prompts, and we're trying to make these forms a lot smarter. So the reporter will be asked if the patient's currently being investigated or diagnosed with BIA ALCL, and if they answer yes, then that will open up another load of questions that they'll be able to provide extra detail. So we'll have more prompts for diagnostic markers, symptoms, and treatment. We informed our stakeholders recently, and we've got quite good engagement with our professional association. So they're going to disseminate that down to the surgeons, and that's in a pilot phase currently. Sorry, overrunning a little bit, but I think this is my last slide. So this is our future work. So as I mentioned, we're in the process of updating our web pages to reflect the data up until 2023. We've also been working on a project known as a Patient Perception of Risk Project. So this is investigating how patients perceive and recall information about potential risks with breast implants. So we've committed to looking at how verbal and written information is provided to the patient during their consultations. And we commissioned a study which involved interviews and questionnaires where patients would look at how they recalled the risk. And we will be hopefully we've committed to publishing that by Q3 this year. And then we'll also be initiating a project to review our data in comparison with the data in the Breast and Cosmetic Implant Registry, which is the registry that covers England, Scotland, and Northern Ireland. So I suppose our take-home messages is that this is a constantly evolving process, and that we're trying to make things as easy as possible for everyone to keep track of. And we'll be updating our websites very soon with more information. So thank you very much, everyone.
Thank you so much. We're going to turn now to Dr. Piscoy, who will be speaking on the update from the EU Task Force of the European Commission. This will be by recording.
Good afternoon, everybody. My name is Paul Piscoy. I work for DG Santé in the European Commission, and I will present you an update from the EU Task Force on BIA-LCL. To start with, this is the governance map of the medical devices system under the current regulation. You see in the middle an entity which is called MDCG, Medical Device Coordination Group. It is chaired by European Commission, and the members are competent authorities from the member states. The fourth group, which is called Post-Market Surveillance and Vigilance Working Group, is the owner of the task force that I'm going to talk about this evening. This task force has been established towards the end of 2012. It has currently 12 member states as members. And the purpose of this task force is to pull the data and share information on the BIA-LCL, cooperate with international regulators. So far, we have worked with USA, Canada, Austria, Brazil, and Japan to share information on national measures and to discuss and coordinate national regulatory measures. Some highlights of the work of this task force. We are holding teleconferences, both at EU level and international level. At EU level, we had so far about 25 teleconferences, and at international level, I think 4 or 5 teleconferences. This task force helped with defining the mandate for 2 scientific opinions for the scientific panels of the European Union. You have also the links in this slide to the opinions themselves if you wish to access them and read them, but most probably you know them already. And this task force also provided data to scientific committees, which I'm going to show in a second. Also, we participated to various scientific and regulatory consultations, one of which is the World Consensus Conference we have been presenting before in these meetings. This is the data from the scientific opinion. In July 2020, there were 345 cases, out of which 279 were with textured surface. The rest are either unknown or polyurethane. And this is an update of the data from a week ago. We have, to this date, 575 confirmed cases, 55 not confirmed. Besides the one report published in literature with the smooth implant, we have another smooth implant declared. However, before this implant, The patient was implanted for 16 years with a microtextured implant. So I presume this doesn't count as a pure smooth implantation rather. Out of the 19 deaths, 4 of them are confirmed as not related to lymphoma. It doesn't mean that 15 are related to lymphoma. We don't necessarily have that information. So I cannot tell exactly how many cases are lymphoma related. Maybe an important point under the new regulations is that the transparency is increased and information for clinicians and patients are available in various types of documents. I can name some as the summary of safety and clinical performance, the implant card, instructions for use, certificate and manufacturer, and the UDI, clinical investigation report, and summary. For the later, we plan to already start publishing in the next couple of weeks. The rest will be found in the future EUDAMED when available. There is also a link for additional resources useful for you as clinicians should you be interested to dig in further. Very latest development and novelty compared to the last time we spoke. We have a project with the commissioned DG Joint Research Center, project on breast implants. It is called Scientific Support for Improved Surface and Biological Characterization of Breast Implants. Main work packages for this project are literature research. This is finalized. Development of testing methodology. This is almost finalized. And it was used for input in a new revised ISO standard. And also application of these methodologies from the revised standard. This is planned mostly by implant testing. We have quite a broad coverage of implants placed on the EU market. So I am looking at least personally forward to the results of this testing exercise. As you may know, the standard on memory implants, the ISO 14607, has been revised. This revision has been going for quite some years now, and there are significant changes. The GJRC joined the technical committee drafting this update. It's a type 8 liaison, and in preparation, GRC ran laboratory experiments and provided comments on the draft international standard, then participated in the discussions and provided input to the final draft standard. This revised standard is expected for the Q3 of this year, and it contains a number of significant changes. Maybe the most important are listed on this slide. On the surface classification, we go from 3 categories to 2 categories, micro and macrotexture plus a multipolar classification system. In terms of surface characterization methodology, a new parameter has been introduced beyond the average serial roughness. It is called surface complexity. It is useful to determine and to consider overhanging and hidden structure of the surfaces, thus better characterizing the surfaces of the breast implants. A novelty, and this is introduced in a new annex to the standard, is the determination of particulates, especially in terms of quantity, size, morphology, and the chemical composition. And with this, I thank you for your attention, and I will finish my presentation.
Next, we'll be moving on to the FDA. So there's US FDA guidance on breast implant safety and best practice by Dr. Nagel.
Hello, everyone, and thank you, Dr. Clemens, for the invitation to join you virtually. My name is Stephen Nagel, and I am a surgical oncologist and medical officer in the Center for Devices and Radiological Health at the U.S. Food and Drug Administration. My group resides within the Office of Product Evaluation and Quality and is responsible for the regulation of all breast implants marketed in the United States. I work with a team of scientists, engineers, plastic surgeons, and many others who evaluate all aspects of breast implant testing, including clinical testing to assure device safety and effectiveness. In my role, I regularly interface with other federal agencies, medical device companies, clinical investigators, and patient advocacy groups. I'm pleased to be here today to discuss the FDA's role in breast implant safety and the BIA ALCL updates. To help place the FDA's recent actions into context, I would like to highlight the agency's involvement in breast implant safety. In the next few minutes, I will provide a brief update on recent breast implant history and current surveillance data on breast implant-associated anaplastic large cell lymphoma, various other lymphomas, and squamous cell carcinoma. In September 2022, the FDA issued an announcement informing the public about reports of cancers, including squamous cell carcinoma and various lymphomas in the capsule around the breast implant, often in the posterior aspect without being present in the breast tissue. In March 2023, the FDA issued a safety communication with updated information about squamous cell carcinoma and various lymphomas in the scar tissue around breast implants. Healthcare providers can submit case reports of squamous cell carcinoma, various lymphomas, and any other cancers in the capsule around breast implants, including BIA ACL, to the profile registry, and anyone can report medical device problems to the medical device reporting website. In December 2023, the FDA has updated our website, including the section on the risks and complications of breast implants, clarifying information about implant removal, and adding ultrasound as an acceptable alternative imaging for screening for rupture for asymptomatic patients to silicone gel-filled implant rupture. The FDA also added a new subsection entitled Reports of Squamous Cell Carcinoma, Various Lymphomas Other than BIA, ALCL, and Mesenchymal tumors, including sarcoma. The various lymphomas reported are not the same as the lymphomas described in previous FDA communications as breast implant-associated anaplastic large cell lymphoma. The other lymphomas include various B-cell and non-ALCL T-cell lymphomas. In our March 2023 safety communication update, the FDA noted that the agency is aware of less than 20 cases of squamous cell carcinoma and less than 30 cases of various lymphomas in the capsule around the breast implant, and 3 deaths due to the disease were reported in the literature. As of January 15, 2023, the FDA has received 24 medical device reports about squamous cell carcinoma related to breast implants and 12 MDRs about various lymphomas related to breast implants. Currently, the incidence rate for squamous cell carcinoma and various lymphomas in the capsule around the breast implants are unknown. There have been reports in the literature of squamous cell carcinoma and various lymphomas in the capsules around breast implants for both silicone and saline breast implants and textured and smooth breast implants. In the 4 cases of squamous cell carcinoma with smooth implants at the time of diagnosis, 2 have a history of prior implants of unknown texture, 1 has a history of textured implant, and 1 has a history of smooth implant and no known textured implant. The diagnosis of squamous cell carcinoma in the capsule around the breast implant occurred approximately 7 to 42 years when the data was available after initial implant placement. The age at the time of diagnosis of squamous cell carcinoma ranged from 40 to 81 years, with a median age at time of diagnosis at 53 years. Currently, the risk factors for squamous cell carcinoma and various lymphomas in the capsules around the breast implants are unknown. Some of the reported signs and symptoms include swelling, pain, peri-implant mass, or skin changes. This is an emerging issue and our understanding is evolving. The FDA will continue to gather and review all available data from sources to evaluate the occurrence of cancers in the capsule around breast implants and to communicate to the public on significant findings as new information becomes available. As of June 2023, the FDA updated the medical device reporting of breast implant-associated anaplastic large cell lymphoma. The updated information is published on the FDA breast implant website. As of June 30, 2023, the FDA received a total of 1,264 U.S. and global medical device reports of BIA ALCL. This includes all breast implant-related MDRs the FDA received with any mention of ALCL or other variations in the narrative text. As of April 2022 update, there are 8 individuals with bilateral ALCL. Patients with bilateral ALCL are counted as 2 cases of BIA ALCL, and therefore these are counted as 16 unique ALCL cases. MDRs provide a qualitative snapshot of adverse events for a specific device or device type, which can vary in quality and usefulness due to the information provided. However, the incidence and prevalence of BIA ALCL cannot be determined from this reporting system alone due to potential underreporting of duplicate reporting and lack of information about total number of patients who have breast implants. Although the MDR system is a valuable source of information, this passive surveillance system has limitations, including underreporting of events and potentially incomplete, inaccurate, untimely, unverified, or biased data in the reports. Moreover, in some cases, lack of pathology prevents confirmation of diagnosis. For the characteristic of implant surface, 73% of the cases were textured. In the 37 cases of smooth implants, 18 have an unknown prior history of implants, 8 have a history of at least one textured implant, 10 have a history of prior implants with unknown texture, and 1 has a history of one smooth implant and no known textured implant. In this case, the history of other implants is unknown. For clinical presentation, 48% of the cases reported seroma, 25% breast swelling, 14% capsular contracture, and 11% of the cases reported a peri-implant mass. The median age at time of diagnosis was 53 years, and the median time from the last implant to diagnosis was 8 years, with a range of up to 40 years. As of June 2023, there were a total of 63 reported BIA-ALCL deaths. There was no information provided in the MDR regarding the time to diagnosis. Whereas the most commonly reported presentation of BIA-ALCL cases was seroma, 48%, the most commonly reported presentation of BIA-ALCL deaths was peri-implant mass, 30%. Prophylactic surgery presents a range of risks depending upon individual patient risk factors, including history and anatomy. Additionally, there are different types of breast implants currently marketed in the US, and risks vary by type of implant and patient. Given that the occurrence of BIA-ALCL is uncommon, prophylactic removal of textured implants is not recommended in asymptomatic patients. Individual patients should discuss possible benefits and risks of removal with their healthcare providers to make an informed decision about their health. We continue to closely monitor and analyze all information regarding risks associated with breast implants and remain committed to continually publicating when we receive any new or significant information so that patients together with the providers can make thoughtful, informed decisions. The agency is continually evaluating the post-market safety of approved breast implants and communicating about the risks associated with these devices. CDRH welcomes a broader engagement of all clinical and scientific experts in the clinical, and especially patients, to gather and available all information about any cancers in the capsule around the breast implant. The agency takes this data and trends very seriously. The FDA is committed to protecting the public health and providing information to patients and providers to better understand the safety risks of breast implants and to help strengthen the evidence generated to inform regulatory actions in this space. So what can you do? When you find a safety issue, notify us. We learned about these issues from you. Your continued work in conducting research, generating evidence, and communicating with the FDA can help us to further understand the risks and how they can be mitigated. Through our partnership together, we can better inform our patients. After all, we serve the same customer, the patient. Many people, including those undergoing reconstruction following breast cancer, choose breast implants every year. The FDA's priority is always to ensure that patients are safe and that they have clear, accurate information on the benefits and risks of medical devices so that they may make informed decisions. We do not do it alone. We rely on other key stakeholders like you to achieve this goal. I want to close with thanking you again for the opportunity to share this important information. It is forums like this involving multiple perspectives that serves to highlight where we can do better with respect to evidence generation and risk communication so that we can target priorities for improvement. After all, patients are at the heart of what we do. Thank you.
All right, now we're going to open it up to discussion. We also have all of our society representatives that we named at the beginning. We want to open it up just to the front row first, just to see if there's any observations or thoughts or questions based on hearing from so many government authorities. Oh, yes, and we welcome Dr. Piskoy and Dr. Nagel.
Eventually, for question, no question from the leader of the society. Yes, thank you.
Professor Dutey from France, from French Society. I had a question to Professor Panagiotakos. Sorry for the pronunciation. I was very surprised to see that the rate of this type of pathology is very higher in France than in Europe. I mean, there's a high difference between France and all countries surrounding France. So is there a clear explication or something who could explain this one?
Sure. You, Mark.
Thank you for the question. If I can interpret your question well, is whether the France data influence global prevalence and incidence of BALCL. Yes, yes. It is a clear difference, and probably it's attributed to the surveillance system you have in France and the awareness you have shown in the past. So as an epidemiologist, when I have to study all this data, I have to weight the information given from French data, from US data, and UK data, making a weighted prevalence, which we have not done yet. Thank you.
Other comments from the society officers? Yes, Schenk. I saw you were moving a little bit at the end.
Thank you. I would like to comment on this ALCL that we, as the plastic surgeons, we're aware of ALCL and we try to gather all updated data and try to do our best in order to treat our patients accordingly. But on the other hand, we have to be aware of the many general surgeons are using breast implants unofficially in many countries. They started as the breast reconstruction cases, but now they moved on using as aesthetic cases as well. So most of them, I cannot blame all of them, but most of them are not aware of ALCL at all. And in case of when they confront of any case of seroma, they don't know what to do. So as the main societies of the Europe and the US and other part of the world, we have to just limitate their use, this kind of products. So once I have read on the FDA's website that these products are just valid in the existence of plastic surgeons. So the other important thing that the big companies should not sell these implants to the general surgeons as well. So in Turkey we try to do limitate their sell, but still some small companies are just selling to them, providing the implants. So we should really struggle on this. So thank you.
Excellent point.
Thank you for your point and comments. If you have specific questions to the presentation that has been done before, so we can have a focused discussion on the presentation of the FDA, of the European Commission, and the other we've seen from UK or Italy. Okay, Joe.
Thank you very much. It's good. Is that working? You hear me? Sorry, Joe O'Donoghue from the UK. A question for Dr. Nagel, actually. Thank you very much for your very clear presentation. But I wanted to clarify 2 points that you made. One was I think I'm correct in saying that you have one patient with BIALCL with a smooth implant who has never, it's a de novo smooth implant, who's never had a history of a textured implant, and one patient, I think if I'm correct, if my memory is correct, with SCC, with a smooth implant and never had a previous textured implant. Is that correct?
Thank you for your question. And let me start by diverging and again, thanking Dr. Clemens and the Society for the opportunity to present. It's not just a privilege, but I've learned so much from this esteemed group, so thank you again. To clarify, in the case of BIA ALCL, there was a report of one patient with a smooth implant in which the BIA ALCL was diagnosed. However, the prior history of that patient is unknown. So we don't call it a known history of it ever having had an implant before. It was just not reported. That's just one of the limitations of the reporting system. We do look into it. We tried our best to vet that information, but it's just not known. It was a little bit more clear with the case of squamous cell carcinoma. It appears that that patient may not have had a prior implant, but we can't confirm that.
Thank you very much.
So these are two
very
they're
important.
not confirmed cases then?
Sorry?
They're not confirmed cases.
No.
What's not confirmed is the prior history.
That's what I mean.
Yeah.
Okay.
Right.
Fine.
It was confirmed that it was disease, not confirmed what the history was. And I think we saw that in our...
It's an important point.
Definitely.
Sure.
I think that we saw that in our squamous cell, as it doesn't seem to be exclusive to textured surface. We have seen cases that were purely smooth with squamous cell. An important distinction. I also know the MHRA representative, Dr. Reeve, I believe, showed a pure smooth implant case. I believe you showed the PubMed reference for that was a case following a textured surface tissue expander. So it is technically a pure smooth implant case, but it did have a type of textured device for 11 months in the presentation. Okay.
Thank you. Brian, please.
I'm Angela Patenis from UC Santa Barbara, and I had a question for Stephen. Thank you so much for the great presentation. I was wondering why there is a distinction between a patient who presents with BIA ALCL in one breast and one that has presented in both breasts, and why they're counted as two cases versus one.
So thank you for that question. The cases are counted per case. So if a patient has bilateral ALCL, that's counted as two unique cases of BIA ALCL. So if that would just notch the number up one, because each of them were a case. Does that make sense?
I've seen in other cases where it's maybe just bilateral as one patient, and it's counted as one case. So I was just confused, but I appreciate the answer. Thank you.
To play the devil's advocate, sometimes bilateral cases are two separate primaries. So it is technically two separate diseases, not a metastasis.
So thank you for the great talks we heard in this last session. I'm Riccardo Giunta, representing the European Society for Plastic, Reconstructive and Aesthetic Surgery. Let me make one comment. One thing of our society is to give information to our fellow members, which are over 7,000. And I would suggest that we make all papers on BIA ALCL in free access. So this contains also the paper from AAPS and the EURAPS paper, and maybe also the one from NCCN. And let me also make a little comment, which I'm asking for a comment also from the FDA or from the European Commission. I don't know if Paul Piscoy is here. But I'm surprised that with increasing awareness of BIA ALCL, the figures didn't exponentially grow. So when we look at the figures of the British Society, they even decreased. So I was wondering what was the interpretation by the authorities, and probably it has also some clinical implications. So thank you for commenting that.
I'm a guest, so I'll allow the European Society to go first, but I have some answers.
So maybe Dr. Piscoy?
Thank you. Actually, when preparing the presentation and looking at the data, I saw that more or less the number of reports per year is constant in the last 4 years. We didn't discussed the phenomenon in the group. I just saw it a few days ago when I was finishing the presentation. So I don't know what that is. We didn't discuss it, but I can confirm that in our data set, the number of reports is stable. So maybe the colleagues from the FDA have an explanation to that.
Yeah. Thank you. I think it's mainly a matter of awareness. You know, when BIA ALCL was first reported, there was a dearth of reports, and there was a few years before the reports started to increase. Thanks in great part to the work of Dr. Clemens and his group, the awareness grew. And then we saw large numbers of reports starting to come in, both through the reporting system, the MOD reporting system, but as well as in the literature. And then that, I believe, we witnessed led to the work of societies such as this esteemed society, making the awareness even expand far greater. So it was an awareness effect. I think we see that happening with squamous cell carcinoma associated as well. And now we're starting to see that with reports coming in for mesenchymal tumors and various other lymphomas associated with breast implants. So I think it's a matter of awareness.
If I can answer to Ricardo, according to the data from the European Association of Plastic Surgery, the number has increased. Of course, not as we probably could expect, but so far we count 654 cases in Europe. But what has increased mainly is the mean risk that was before something like 1 in 16, 1 in 12,000. Now it's 1 in 8,000. So according to our data, risk is increasing and total number of cases too.
How can we explain the difference? Rado Zik from Croatian Society of Plastic Surgery. How can we explain the difference of the number of cases if you look at the US and we look at Europe? Europe was putting in more than 90% of textured implants. The US was putting about 10%, what we saw from the explanation. And we see that we have some similar numbers appearing. And Europe has actually a lower incidence. It's 1 to 8,000, and we saw in 1 to 900 in US. So how can we explain this difference?
Some of it's explained by the denominator. So even though the US is a minority use of textured implants, they still place approximately 650,000 breast implants per year. And so it's still a large proportion of total breast implants worldwide. Even a fraction of textured still is a large number. And prior to 2017, textured implant use was actually relatively high, about 30% in the United States. And then it's diminished since then. And if you go back far enough, 2 decades, it was actually the dominant within the United States. So there's temporal aspects, there's volume aspects to explain it. Any other questions from the audience?
Okay, Ricardo.
I have another question for the authorities. The question is concerning textured implants. Nobody gave the official advice by the authorities to no longer implant textured implants, what you advocated today. So I would like to better understand the reason why. Maybe you can give your main arguments for not giving the advice to the plastic surgeons.
Good point.
So I apologize. I'm not really sure I understand the premise of the question as to the communications between the agency and plastic surgeons with regards to placing these implants. The FDA has changed their guidances over time as more information has become known. We've restricted the use as we needed to based upon the information that as it became known. They're no longer placed in the United States, large groups of implants that previously were placed in the US. And we've also included additional mitigations such as boxed warnings and a patient checklist that are required. So I'm not really sure what the question is with regards to the FDA's restrictions on breast implants. It's been well published on our website. Perhaps I could have you to ask the question again somewhat differently.
I can make it probably clear if I understood what Ricardo said. Probably Ricardo said that during this Congress, it was demonstrated high level of evidence, level of evidence too, that there is no difference between macrotexture and microtexture. And report from Brazil was the same with polyurethane. So he is wondering why so far, if we have those evidence, we are still continuing free implantation of other texturization than macro. Was that the question? Yeah, more or less, yes. So probably is wonder, why don't we do a new update of the regulation with all the implant? That one.
Right, thank you. So we continually look at the risks associated with the implants. And as information becomes available, for example, one particular type of implant having an increased safety signal of adverse outcomes, we have recalled those implants and we'll continue to do that. Currently, there are no more macro-textured, so-called macro-textured implants that are authorized for placement by the FDA in the US. But as this information continues to evolve and we become more aware of risks associated with specific types of implants, we act on those.
Paul Piscoy?
Thank you for putting me on the spot. As you know, in Europe, the delivery of health is in the remit of the member states. We do have a common legislation. And actually, the reply is not straightforward and easy. If I understand correctly, the colleague asking the question is asking actually, why do you still allow textured implant on the market? And the reply is debated in the scientific opinion that I put a link to in the chat, and you have it also in the in my presentation. In short, textured implants is believed in Europe to have their place in the arsenal of the clinicians. And maybe one final comment on this: those implants which have been associated mostly with anaplastic large cell lymphoma and with very rough surfaces and macrotextured are not on the market anymore. So I do invite you to read the SCIR opinion on this, which actually contains the reply to the question. Thank you.
Thank you. Professor Serratos, question.
I would like to take advantage of having all these European societies here, national societies of plastic surgery, just to ask, like, if in Europe, having so many nations, if each country has its own guidelines, or how do you inform your plastic surgeons? Do you just copy the guidelines of someone else? Are you planning to create guidelines, do consensus papers like the one they did in the US, or?
Hi, I'm Dr. Cañadas from Spain. In Spain, we have revised, Dr. Berenguer and me, all the guidelines, Europe guidelines, and we did guideline for the fellow and for the patient. So you can inform your patients about VALCL and ACC and everything, so with information for patients, but they must know that they will have that problem. So we did in the society guideline for us.
Because, like, my question is, in Europe, we have a lot of discrepancy between the numbers of reported cases. So definitely some countries are well informed, some other countries are less informed. So maybe we can adopt like a common ground where we can, you know.
I've got one comment about that, because now FILAC Congress is in Argentina. So they asked me to ask everyone here if it will possible to do share registry for all the world. I mean, but not only plastic surgeon, because we have the same problem. We have lots of general surgeon doing breast surgery. So how do you control that people? Because in Spain we have the health ministry and the Association for the Medication and Plastic Surgery Society. But how do you control all the surgeon that is doing breast surgery? It's very difficult because
it's very difficult. But I think we've seen from this conference there is a will, there's a desire.
At least all the plastic societies try to do like a paper to register all the items, the same items for that problems. Is a good idea, I think so.
I agree.
So,
may I have a brief intervention, Paul Piscoy here?
Yes, sorry.
Apologies, I cannot raise my hand. I don't seem to have the function in Zoom. There is an international initiative which is called iCobra, which is led by Australia to do exactly this thing, to have common data sets for breast implant registries. You find them easily online. I can also put the links to them in the chat. And they did provide a common data set or a recommended data set, which is available for free online. And you can contact them if you wish to join this initiative of international registries for breast implants. Thank you.
Thank you, Paul. I have one question for SICPRE, if I may. So I noticed something that is very peculiar compared to NCCN guideline, FDA, and all the others. So it seems that SICPRE is contraindicated, is recommending not to use any implant in BLCL patient after surgery. This is not suggested by any authority or scientific. So are we missing some evidence that you have? Because those patients, to me, appear they've been already unlucky, some of them, to have a cancer. Then they've been unlucky because we gave a second cancer. And now, what is the evidence that they have to be so unlucky not to give a further chance after that cancer?
You mean after ALCL diagnosis, so the contraindication to use a new prosthesis?
Yes, exactly.
Okay, this is the guidelines of the Ministry of Health. It's not, we just stick to this as a SICPRE.
Yeah.
And this is since I should remember, but it should be maybe 3 or 4 years that the ministry is recommending not to implant a new prosthesis in patients with ALCL because maybe they don't bring any big number of evidence, but maybe this is another trigger to develop a new ALCL in the future. In the future, that's the logical.
I understand the logic.
Yeah, the logical.
If there is any evidence.
Yes, we need evidence. We need big numbers, and it will be really interesting to sharing the numbers all over the world, and with USA and in Europe, and having a scientific evidence on big numbers. I don't know if it would be ethical to me a randomized study on this. I don't know.
Andrei Sukov, Czech Republic. My question is, does the European Union Central Implant Register? Because in my country, we have no 3, but 8 patients. We have no problem to report it, but we don't know where and how. Thank you.
Maybe for Paul Piscoy.
Thank you. No, there is no central implant registry. Again, that falls under the duty of the member states. The latest I'm aware of is in Italy. I think it was launched last year. If you wish to report, you need to report to your national competent authority. And as you saw in my presentations, if they are a member of the task force, but they can become at any time. They bring that information at central level through this task force, but there is no breast implants of registry for all member states of the European Union, as there is no such registry for any other type of devices. Thank you.
Thank you. Since you were standing since a long time, we cannot send you back without chance to give your quick question, please.
I just want to say thank you again for the great presentation and the great panel. I'd like to ask a slightly different question. Given the importance of texture in the role of BIA, ALCL, whatever it might be, and given the outsized role of silicone in general in breast implants, but also in other medical devices, is there going to be any recommendation against texturing silicone devices, whether it's ports, stents, drains, any types of other related devices that are made of silicone, like gastric bands, for instance? How far does this...
Let's start from USA.
Yeah, USA might be helpful.
Sure. Thank you for that. Let me just deconstruct it somewhat and just define a distinction between breast implants and implants outside the breast. Although there have been reports for implant-associated malignancies outside of the breast, and there have been reports for malignancies associated with silicone, both within the breast and outside the breast. Unfortunately, there are still reports of free silicone in the breast. The FDA, as I explained, has received reports for breast implant-associated anaplastic large cell lymphoma, as well as squamous cell carcinoma for both smooth and silicone implants. As was mentioned earlier, to the question of why allow certain implants to remain on the market, it's an evolving issue. And as we continually look at the data, and as more data becomes available, and the data demonstrates that the risks outweigh the benefits for a specific device or device type, then the FDA would recognize that and come to the determination that for that particular device or device type, if the risks outweigh the benefits, that has led to recall in the past or restrictions. At this time, there's insufficient data to support that a silicone versus a saline implant should make a distinction for either a further restriction at this time or even a recall.
Thank you. I should just clarify. I only meant the texture. Thank you.
Yeah, just one more thing with regards to the question on texturing, and there's no question, they are excellent questions. Why should they continue? The point was made earlier that the FDA has stated that we believe it's a discussion between the provider and the patient as to risks and benefits. But you only mentioned three. We always discuss the risk of keeping the implant, and it's exceedingly low, but it's a very, very profound risk. We've mentioned the benefits of removing the implant, which is really based upon what is the risk of keeping it. That informs the benefit of removing it. There are both physical benefits and risks, and the psychological benefits and risks. And so that informs the risk of removing the implant. But what has not been discussed are the benefits of keeping the implant. That's got to be considered in the equation. And that's huge. Many women who choose reconstruction and augmentation have an immense benefit, both physical and psychological. And we would need a whole nother day to discuss that, of keeping the implant. And it's got to be factored in the decision between the patient and the provider.
Thank you very much. Is there anything Paul Pisco would like to answer to?
I didn't actually heard the question because that mic doesn't filter to my connection. But judging by from what the colleagues from FDA said, in Europe we have 3 carcinoma reports so far. Why allowing still textured implants on the market? I do remember that when the discussion started, I think in 2011 on plasticilar cell lymphoma and in the following years, We did discuss quite a lot the difference between US and the Europe market and preference and even needs of the patients. Round versus pear-shaped implants, which for the second, in order to have better tissue integration, you need texture surfaces. I do recall from the scanner opinion that also in cancer reconstruction, the integration is better and is needed to have textured implants. So there are clinical needs for having those besides the patient preferences. And my last remark, if that was part of the question, apologies if I'm giving information which was not required, but anaplastic large cell lymphoma is also has found in implants other elsewhere than the breast. I do not know if it's 2 or 3 cases that we have in our opinion, one of which is linked to a dental implant. I do not remember the other one, so I'd rather not venture inventing them, but I invite you to consult that opinion. Thank you.
Thank you very much, Paul. I think we can probably conclude.
That will officially close the 5th World Consensus Conference on BIA-ALCL. I want to thank 17 society representatives that we had today. Absolutely extraordinary. I want to thank our government authorities, the US FDA, the MHRA, the European Commission, Italian SICPRA, so many different representatives weighing in on this, over 70 speakers over the last 2 days. I just want to echo some of the words of the FDA, which is that patients are at the heart of what we do. We call it a consensus conference, but that doesn't magically make it so. And you've seen that we have a lot of lack of consensus, but hopefully we've come closer. And I think that we all realize that we have more in common than divides us. And so that's ultimately the way that we'll be able to move the needle on these issues. Fabio?
Yes, thank you very much. I'd like to give the last comments, and I want to thank several people, starting from company who supported us for arranging that meeting. That was not easy to have, as Mark says, 17 representatives from all the society. So without their support, it could have been much more difficult and probably smaller and less important, with less impact of the issue. Then I like to thanks, of course, the participant, which made huge and important this meeting, as all the faculty, with this tremendous impact factor, the tremendous age index, total age index of the faculty of 1,683. It's amazing the level of science that we were able to take advantage during the meeting. And of course, if everything went fine, is because of the professional support from Eurotraining, Diana, Carlotta, and Anna, and slide boy Michael Sorodos, my assistant, who overview all the technical aspect, and the technician, of course, that went very fine. And what to say?
Veronica.
Yeah, wait a moment. You don't need to remember. I just want to give a bit of suspense. Come on. Okay, wait, hold on. I want to just give the information that we had a very high number of participants due to the restricted field of the Congress, with 240 physical registered participants that were coming from 30 different countries. So that was the support, or that was the way we paid back the support from companies. But most important, we had 1,200 different IP connecting with the Congress on streaming. So all from 83 different countries. So altogether, we had enormous amount, something like 1,440 participants to this meeting, which makes really important the audience that we were able to reach. And of course, as my partner remember me, I want to thank my wife because she had that very difficult task. First of all, to deal and stand with the husband, which is not easy. But at the same time, But at the same time, she has to play the role of the mother because we have a 2-year-and-a-half young boy. So it was not easy. But at the same time, she has to take care of all the graphic that you have seen and all the media communication. So she was working very hard at the same time when was taking care of our son and taking care of me too. So thank you very much to my wife and thank you to everybody.
We will see you next year. 10th International Breast Surgery Workshop, 6th World Consensus Conference, Tampa, Florida, with Denise and the entire academic faculty there. Excited to see you then.
Thank you. Bye.
Hello, I'm Mark Clemens, and you've been watching the 5th World Consensus Conference on BIA ALCL. We're going to do a bit of a transition at this point in the program, and we're turning now to our 5th session, which is completely online, completely virtual, and really focused on patient education. This is our patient education session. Dr. Santanelli and myself really struggled with only having 2 days worth of time to fit in everything new that's been happening about ALCL. And so this year, for the very first time, we came up with the idea of doing a half day at the very end of our conference, just devoted to extra information on ALCL. This enabled us to do a deep dive into patient education, as well as some of the newest research that's being performed on the subject, and just to be able to take a deeper dive into everything that we've wanted to show in the past, but sometimes we've had to make editorial decisions that we just didn't have enough time for it. Now, much of this content was actually driven by patient advocates asking for specific information to expand on. Other areas were key aspects that we haven't been able to focus on in the past just due to time constraints. And this year, we're finally able to give an entire full half-day experience. I know it's been a long 2 days with the main conference. Hopefully, you'll either continue to watch this or you can use it as a library to come back to for your own reference. With that said, I want to turn it over to the patient education session. Thank you so much.
I'm going to talk about the process of breast implant associated ALCL. I'm going to talk first about how to establish the diagnosis of breast implant ALCL, which starts with suspicion of the disease, and then how we do the handling of cytology, flow cytometry, and pathology, and then discuss if we really need all those testings. Then I'm going to talk about when breast implant ALCL is not the diagnosis. That is because there are other lymphomas which arise also in the capsules, as well as other neoplasias such as squamous cell carcinoma and other disorders which are also associated with breast capsule. So what is well established in breast implant ALCL that we all know is that is a CD30 positive T-cell lymphoma, usually presents as an effusion, less frequent as a mass, and sometimes with enlarged lymph nodes. The pathologic staging is crucial and essential, as well as the assessment of margins when the specimen is resected. Why? Because a positive margins results in high rate of recurrence or progression of disease if left undiagnosed. And then that leads to the proper clinical staging and management of the patient. So this is an example of effusion. We can see here the implant, which is distorted, surrounded by an effusion, which has been resected and blocked. And this is an example of a case presented with mass, and you can see here the MRI seeing a mass. The PET-CT shows several areas of enhancing, which indicates infiltration, and this is the en bloc resection, and we have in the margin. Subsequently, we take sections and proceed with pathologic staging, which consists in assessing what is the tumor. If this is the capsule, the tumor cells appear here on the surface. We call this pathologic stage T1. When there are some few cells start infiltrating and there is an inflammatory reaction around, we call T2. And when this is deeper, we call T3. And when they infiltrate of cells, we call pathologic stage T4. And then on the right, we can see all the brown means CD30 positive cells. So on the pathologic stage T1, the neoplastic cells are only on the surface, eventually start progressing a little bit, and this is a T2. And when it's deeper, we call T3. And when the neoplastic cells are beyond the capsule, we call pathologic stage T4. In this particular case, we can see the ink and the deep margins, and we can say that the margin is negative, so the tumor is not infiltrating the margin. When we receive the specimens, it's essential to do an adequate grossing. So we require from our surgeons that the specimen is oriented with sutures denoting the superior margin or the lateral or median margins, and we palpate the specimen to see if there is any fluid, so we aspirate and send for processing. Then we open the capsule sequentially in different axes, and then we get exposed the implant, and then the implant is removed and the capsule remains, and we make additional sections to have this flat and get it fixed. So this is after it's fixed, and then we ink the margin with several colors to keep the orientation of the specimen, and we take several sections. Initially, we proposed to take 2 sections per side, about 2.5 centimeter per section. So this is 5 centimeters here, 2.5 on each of the other side. And we submitted 6 cassettes for each side of the specimen. And some people were complaining it's too many sections. So more recently, we're not sending 6 cassettes, but we're sending 2 or 3, which contains extensive large sections of the capsule where we make a roll and put in a cassette, and we can that way have an extensive sampling with just 2 or 3 cassettes. And that obviously is saving some expenses, and we publish this procedure in modern technology. Now, what do we do with the cytology? The cytology, the problem is that sometimes you can have a lot of neoplastic cells, but sometimes inflammation looks very necrotic. There are many inflammatory cells, and then it's difficult to call a diagnosis of malignancy because you just have very few neoplastic cells. And then you try to resample then the specimen, the cytologic specimen start having a decrease in the number of neoplastic cells, so there are less and less every time. And then sometimes when you open the specimen, you don't see a lesion really identifiable. The lesions are not really, right now, they appear. So what is the minimum amount of fluid? Again, there is not consensus, but in general, 2 or 3 or 5 mLs are very little of fluid, and that's usually considered not pathologic. In general, less than 10 is not pathologic. But if we can aspirate 10 to 15 mLs, and that is probably an adequate volume that we can distribute for cytology. We give them 15 mL so they can do smears and cell block. So this is in general, let's say we have a 50 mLs, we get 15 for cytopathology, they do smears and cell block. We send 15 mLs for flow cytometry so they can do the T cell markers and CD30. And we still have 15 mL we send for molecular testing for gene rearrangement of the T cell receptor to see there is clonality. Again, this is not the standard. Many places don't do it. You see the neoplastic cells already demonstrated by other means you don't need, but sometimes it can be very important. So it's very difficult to say don't do it. If we can do it. So this is the cytology, how it looks like large neoplastic cells in a cell block. They're still large. With CD30, you can see how they are highlighted here. By flow cytometry, if the laboratory has an established testing for CD30, then it can get the neoplastic cells there. But sometimes, if they don't have this marker in their panel, then the diagnosis can be missed because the neoplastic cells are very large, usually fall in the area of monocytes, and then that is the area where we avoid testing because the area of lymphocytes. So the question always is, do we need all that? Well, you know, if clinically suspicious, either because the clinician thinks it can be or the patient has a strong feeling it can be, there is no other alternative than doing as much as possible. Certainly, if there is cytology and there is good amount of effusion, we do all the testing, send for flow cytometry. And again, as we say, T-cell receptor gene rearrangement, again, there is not a definitive role for this testing, and we use it. Sometimes it's positive, it supports the diagnosis. And finally, we try to be very careful with the handling of histology. So this is, for example, a case of a patient with a thickened capsule, had a little bit of thickening of the capsule, and this was initially evaluated and looked like a lot of fibrosis with some few cells, and this case was not tested for. My colleague pathologist says not necessary, but certainly we received the case in consultation, and then we review that, and we say maybe we should try CD30, and in fact there are many CD30 positive cells. So again, sometimes the clusters of neoplastic cells are so small that we don't want to believe that this is a tumor. This is another case which was also missed because there is the capsule very fibrotic, a lot of inflammation. When we look high power, they say it's necrosis. But when we do CD30, there are cells here on the surface. It's a T1, it's a pathologic T1, but in fact, this case was not diagnosed. And 3 years later, the patient presented with a large mass here in the capsule, and this is pathologic stage T4. And here we can see how the CD30 highlights the neoplastic cell within the capsule, so an invasive. We try to study these cases. So in our series, there were 70 cases. We refer that there were previous biopsy or previous fine needle aspiration or previous cytology. And then we say, well, let's retrieve those. And in fact, of 70, only 10 had the capsule or the fluid was examined. 60 cases did not process the cytology. 60 cases did not process the capsule, anything. So there is no evidence what happened the years before. But in 10 cases, we were able to see that of those 10 cases, 3 remained the same after 3 years follow-up. So they were T2, and 3 years later, they still were T2. 5 cases progressed from T2 initially to T4 3 years later. So there is a progression, and 2 remain about the same. They were T4 at 1 year later, they still were T4. So they were already invasive. Of these 10 patients, 2 died because they progressed from T1 to T4 while the disease was not diagnosed. So again, that's not cannot be extrapolated very much, but certainly it tells you that there is progression. You let it alone, and we publish this in Monology also. Now, are there other diseases which associate with the breast implant? Certainly, there are other lymphomas which have a recent associated with the implants and the capsule. There are B-cell lymphomas such as diffuse large B-cell lymphoma, marginal zone lymphoma, extranodal TNK, EBP positive, or EBP positive large B-cell lymphoma, as well as more recently, there are more than 20 cases of squamous cell carcinoma already diagnosed. Squamous cell carcinoma certainly is not that you do a stain and you find it. Really, the capsule is thick, and we can see this nest of carcinoma cells clearly infiltrating. It's not like you do a stain and you see, wow, I discovered a squamous cell carcinoma. No, in fact, there is a lesion. It's not like you see a normal capsule and then you're not surprised. There are other diagnoses on breast capsules, and then again, the usual complications, which again is estimated about 30% with breast implant have complications. Many of them have the need to repair by surgery, like rupture of the implants, contracture, effusions, which are not breast implant ALCL, or complications of the cellular dermal matrix. And certainly, there are other processes like breast implant illness, which again is recognized by some and not recognized for others. So it's controversial. Again, there are non-neoplastic complications. We have some few examples of a seroma, looks like a breast implant, the fluid here, but in fact, when we see the cytology, they are just lymphocytes, some macrophages, and we examine the capsule, it's almost no cells, almost no inflammatory cells. All that you have is synovium on the surface. This is clearly benign. This is not breast implant. And I wouldn't do this CD30 here. If I do CD30, I won't find anything because there are no cells to test. Maybe there is one cell here, one little cell here, but that's not what is ALCL. This is another example of a ruptured implant, and you can see how the implant has been ruptured and the gelatin inside from the silicone is outside. And this goes through the capsule and this appears like light clusters of jello. And then when you see the cytology, there are a lot of reactive small lymphocytes and macrophages which are phagocytizing silicone. So again, the question always is, how about the markers? The markers for breast implant ALCL. Well, you know, the markers don't make a diagnosis. Let me tell you, if we check some markers, CD30, we say, oh, B-cell markers like CD2079 or keratin, or let's put the microscopy. This is us, the skill of a pathologist as a marker. For every disease, like breast implant ALCL, for example, we will see an ablation. For every lymphoma, we will see lymphoma cells. For squamous cell carcinoma, we will see carcinoma infiltrating the capsule, or for reactive process like seroma, we will see what? Synovium, silicone, inflammation. Again, CD30 positive, then when it's breast implant ALCL, when we see an ablation. When we see B-cell lymphoma, we see B-cell markers, again, we see lymphoma cells. And when we see carcinoma, or squamous cell carcinoma, is positive for keratin, but certainly we don't do just blindly. We see in the case of look carcinoma. Again, if the specimen looks reactive and everything is negative, we don't do anything. And again, to emphasize, ALK is negative in all. So there are no diseases in the breast which are ALK positive, and there is not a need for them. So we are almost at the time. And so in conclusion, breast implant ALCL is a diagnosis can be straightforward, but there are several presentations which can lead to misdiagnosis and progression of disease. There are emergency entities like angiolymphoma, squamous cell carcinoma, reactive process seroma, contracture, which again bring morbidity to patients affected with using implants. Thank you very much.
Good morning. Thank you very much for giving me, to Fabio Santanelli, to give me the possibility to have this interesting intervention about the BIA ALCL lymphoma and the implication, the psychological implication about this delicate type of lymphoma. Also, despite reconstructive surgery is secondary to other treatments, this type of intervention is very, very important to the well-being of the patients. The breast implants are conducted in order to restore body image, self-esteem, and femininity. And of course, this type of intervention has a very important implication on the sexual and relation well-being of the patients, and so on the psychological well-being. The data of in the world about this specific type of lymphoma due to the implantation, breast implantation, the data are very different in the world. And in the single countries. In the American Society of Plastic Surgeons report approximately 1,300 cases of this type of lymphoma. The European Association report 511 confirmed cases, and in Italy we have only 105 confirmed cases with from 2000 2010 to 2023, including 2 reported deaths due to the lymphoma. So we can see on this data that the prevalence is very different in the world. And in Italy, we have a very little prevalence. So we have to understand what is the meaning about this little prevalence in Italy. And this could be due probably to the difficulty to report all the confirmed cases that probably could be more than only 105. And so the problem is the attention of the single countries, like Italy probably, to report with precision all the confirmed cases in order to find a possible solution of this problem that has so important psychological consequences. Then we know about the breast implanted woman experience for all the type of consequences. 50% of these women reported some complication about the post-surgery. But what happened from a psychological point of view when a woman that reported this implantation and this damage, this so bad outcome about implantation? What happened from a psychological point of view? We have very few data about this. Overall, probably because there are very few reported cases, and so it is very difficult to study the psychological implication in this woman because it's very difficult to identify them. So one problem that we can to take attention is to report all the cases, to find an organization that can identify all these cases. This is the first problem. After this, which are the psychological reaction that a patient can feel after this bad outcome, so with the diagnosis of this type of lymphoma due to the implantation? The first reaction probably is shock and fear, considering that they are conducting this type of implantation in order to resolve a problem about cancer generally, and so they find that this type of treatment causes another cancer. So the stress and probably the effect on this patient is very, very important. It can be a very important impact, psychological impact. So we can, of course, hypothesize a reaction with anxiety and depression. And of course, and we can see also about the experience in the clinical context, we have an impact very important on the body image of these patients. Which is what causes this psychological impact on these patients? The big problem is that the patient can see a changing on their representation of the medical institution from a provider of cures and solution to one of further possible treats to one's life. So the problem is to see a treat in the relationship between between patient and medical staff. So we know how is important the relationship doctor patients, where the trust in this relationship is very important also for the outcome of the treatment. So when there is a break in this relationship, we can see a very important implication on the outcome of the treatment. So what are the possible solutions that we can find in this situation? Of course, is on the clearness, on the clarity that the medical staff can have with the patient. Not only the clarity. Of course, there are 5 points that are reported in the literature, and one is very important, is the fidelity. So the problem is to have in mind the importance to favor the fidelity of the patient in the medical staff. Another point is to have in mind the importance to communicate own competence on the treatment. Third point is to favor the global trust of the patient in the institution, medical institution. And of course, the confidentiality. So to find, create an environment of trust and security in the patients. We know that all these points are very important, not only for an ethical problem, an ethical question of the medical staff, but also in relation to the outcome of the treatment. So it's very important to have in mind this point. The last one, but not for the priority, is the honesty of the medical staff in front of the patients, where it's important to be and to report all the risk and the option of a treatment with the patient. And it's very important to be very clear and reporting all the possibilities. So also the possible, also if it is not so probable, all the possible risk. And from a point of view of the relationship with the patient, we can imagine that report honestly, so also the possibility of bad outcome can break the relationship between patients and medical staff. Despite from the previous research, but also the previous experience in the clinical context, we know that this type of break can be resolved in mid and long-term relationship with the patient. So it's very, very, very important to communicate all the possibility to the patient about the treatment. This can, so in synthesis, this can bring a little break in the start after this type of communication, but in the midterm, the patient can consolidate a more important and more solid relationship with the medical staff. In all these situations, so it's very, very, very important to prepare a need for a psychological support in these steps, and that Dr. Virginia Campedelli will explain in this brief oral presentation. Thank you very much for giving me the possibility to report this brief oral presentation on this so delicate problem.
Thank you, Prof, and good afternoon, everybody. Psychological support is important for these women because is essential to address the emotional challenges associated with this condition. And psychologists can help patients to manage stress, anxiety, and depression, or develop coping strategies to deal with all the care process. Psychological support must be characterized by important aspects. For example, to manage cognitive biases, it's crucial to address anything that may make women overly concerned about the risk of this lymphoma and emotionally influence decisions. Helping patients assess the real risk and reviewing decisions together before surgery can reduce emotions that influence treatment choices. Then it's important to focus on the actual risk. Psychological support should help patients understand the evidence-based risk and clinical data on breast reconstruction, and this can alleviate anxiety and lead to decision based on a clear understanding. Then, when exploring motivation for breast reconstruction, it helps to compare concern about this lymphoma with the reasons that lead the patients to reconstruction to improve their quality of life. And this contrast can balance emotions and reinforce the patient's decision. Then it's important to help patients deal with any guilt or responsibility they may feel about choosing the reconstruction, whether if it's for aesthetic or medical reasons, and supporting them in recognizing their needs and the benefits of reconstruction can help alleviate negative emotions. In the end, it's crucial to manage harmful emotions like anger, distrust, or regret well, and because these feelings can disrupt communication with the surgeon or the participation in the screening and the future treatment. Psychological support aims to promote healthy emotional management and improve communication. This approach can help surgeons to rebuild trust with patients and improving the quality of care and patient experience in plastic surgery practice. Firstly, it's crucial to inform patients by providing comprehensive and transparent information. Surgeons can empower patients to make informed decisions about their health. Then, listening to patients is equally important. Actively listening to their concerns, understanding their point of view can help build a solid foundation of trust and communication between patients and surgeon. Then, acknowledging patient concern is a fundamental aspect of their care because it demonstrates empathy and promotes a supportive relationship between patients and surgeon. Then, clear communication is essential to clarify any problems related to breast implants, because if patients have a thorough understanding of their situation, can alleviate anxiety. In the future, it's essential to develop and implement better process for monitoring, treating, and supporting these patients, because in this way, surgeons can demonstrate their commitment to effectively solve patients' problem and improve the overall patient's experience. Finally, what could be the key points to take home? Firstly, recognition and importance of both the emotional impact in women with this lymphoma and the concern about the lymphoma itself in women with breast implants. Then, psychological support is essential to ensure a complete healing process to support women's emotional well-being during all the care process. Then, plastic surgeons must ensure patient-centered care, open communication, and proactive measures to effectively address patient concerns. And in the end, the multidisciplinary approach is fundamental to management of risk communication, diagnosis, and treatment of this lymphoma. Thank you for attention.
Hi there, this is Dr. Terrence McCatton. I'm at Washington University in St. Louis, Missouri, and today I'm going to be talking to you about uncommon presentations of BIA-ALCL and maximizing prompt diagnosis and treatment. Here are my conflicts of interest. So, in my view, uncommon BIA-ALCL presentations include patients that present who don't have a diagnosis of BIA-ALCL until after the pathology comes back. They've already had some sort of breast implant explantation surgery, and then we find out they have BIA-ALCL. Or potentially in patients who have persistence of symptoms after explantation and or capsulectomy, patients who present with a mass without a seroma, patients who in fact have BIA-ALCL in the contralateral breast to the one of concern, and then also patients who present with BIA-ALCL with a smooth implant. And just to address this now, what I mean by this is patients who historically have a textured breast implant, but now have a smooth device and then present with BIA-ALCL. To be clear, there are no cases where the history is fully known where a patient developed BIA-ALCL without a textured device. So I think the critical thing here is to make the diagnosis upfront to avoid an uncommon presentation later. Unfortunately, plastic surgeons don't uniformly follow these guidelines to make the diagnosis in a prompt manner. Oftentimes, they don't recognize the fluid or the mass prior to surgery. Sometimes they don't assess the fluid or the mass prior to surgery, or if they assess it, they don't send it for the correct tests. Sometimes they're not actually performing a formal en bloc capsulectomy. And then often they're not actually engaging a multidisciplinary team to help with the management of these patients with BIA-ALCL. And all of these can lead to a delayed diagnosis of BIA-ALCL. So this is just one of our patients. She has a moderate right-sided breast seroma that presents 9 years after placement of a textured device. And just to underscore the importance of making this diagnosis first, aspirating enough fluid, 60 cc's are aspirated here. We recommend at least 10 cc's. Performing an en bloc capsulectomy, recognizing that this is a disease that affects textured breast implants. So this is just a simple schematic. And just to take away from this, the importance of aspirating a fluid collection, or if there's a mass, trying to biopsy the mass before going to the OR, and making sure that you are sending this fluid for cytology, looking for the status of CD30 and ALK, performing flow cytometry on the fluid, and looking for whether there is a CD30 positive cells or not. And then when you go to the operating room, to test the capsule with these tests as well, to test the fluid as well. So what is an en bloc capsulectomy? So for me, this is resection of the entire capsule as a single unit with a margin of normal tissue around the capsule. So this is not synonymous with a total capsulectomy. A total capsulectomy means the entire capsule is removed, but it doesn't necessarily mean that there is a margin of normal tissue around it. That is what you need to do an en bloc capsulectomy. So if that means you have to take out some muscle, some cartilage, some rib, some pec, some skin, in order to truly get a margin on the capsule, that is what you need to do. That is an en bloc capsulectomy. It's not just shaving the capsule off of the adjacent tissue. So in one of the common ways or one of the uncommon diagnoses, pardon me, for BIA-ALCL is to find out that this patient has BIA-ALCL after plastic surgeon has already performed an explantation, possibly even a capsulectomy. So why does this happen? Well, it happens because the diagnosis wasn't made before, whether because it wasn't recognized or there was a failure to properly assess it. But what do you do now? So basically, at this point in time, I would personally engage a medical oncologist on a multidisciplinary team for some further guidance. I would also go ahead and get some PET CT imaging first, just to further delineate and understand the extent of disease as much as you can with imaging. And after I've got that information, I would go back and I would perform a formal en bloc capsulectomy. Something that often comes up is whether or not in an aesthetic patient you can put a breast implant in right away, or in a recon patient put in an implant right away or do a flap right away after performing an en bloc capsulectomy in a patient with BIA-ALCL. And the answer is you probably can in many cases. So this is a nice report from 2019 involving our colleagues from MD Anderson, from University of Toronto, as well as from Australia. And what they found was that essentially for early stage disease, so disease confined to the capsule, they found that it was appropriate to immediately thereafter, at the same operation, place a new breast implant or flap. However, for more advanced disease, so extracapsular disease, they recommend that the patient was clear for at least 6 months before proceeding. And my own institution, our medical oncology team, prefers that we don't put in any implants, not try to reconstruct, regardless of the stage of disease, for at least 2 years after the en bloc capsulectomy. So sometimes what can happen is that the fluid is aspirated, but it's not actually sent for the appropriate tests. So just to review, for cytology, essentially the fluid or the mass is sent, the fluid would be spun down into a block, and the mass or the fluid would then be stained using immunohistochemical techniques, looking for T cells that are CD30 positive and ALK, anaplastic large cell lymphoma kinase, negative. The fluid also be sent for flow cytometry. And this is very important, that the fluid that is sent be done with flow cytometry that's gated for CD30, not CD3. Certainly at our institution, when somebody has a T-cell lymphoma, the standard practice is to gate for CD3, CD3 being a component of the T-cell receptor. However, in BIA-ALCL, the T-cell receptor CD3 is solubilized in a large percentage of cases. So if you go ahead and you do your flow cytometry gated for CD3, as was the case in this patient of ours, you won't find it. And so when we gated for CD30, we noted that that patient was grossly positive and were able to make a BIA-ALCL diagnosis. But this patient went to another lab that wasn't as used to this. And when they initially had their aspiration done, they were called ALCL negative. We had our suspicions. So when we took her back, we resent the fluid, gated for CD30, and found the disease. So this is just here a schematic of CD3, CD30, and the relationship to the T-cell receptor and the cell membrane. So sometimes what can happen is that the patient has an explant, has potentially a capsulectomy, maybe not, but there's no information to suggest that they have BIA-ALCL. So none of the pathology came back. There was no assessment done prior to surgery. So this disease can either recur or persist. Now, of course, if the disease is there and it's not adequately treated, there's a much higher likelihood of advanced disease or and also of potentially needing more advanced treatments. So what happens? So again, you need to get a PET CT to delineate disease, to engage your multidisciplinary team. Once you have their input, sometimes depending on the extent of disease, also input from other teams such as thoracic surgery, then you can go back and perform your en bloc capsulectomy. Sometimes at that point in time, other types of immunotherapy such as brentuximab or chemotherapy may be recommended first. Sometimes a more extensive resection, including chest wall resection, sternal resection, may be recommended in conjunction with your en bloc capsulectomy. Now, analogous to the last one, but what happens if maybe somebody knew the patient had ALCL, but did not actually perform an en bloc capsulectomy? Well, the simple answer is you got to go back and perform an en bloc capsulectomy. But I'd like to make this caveat, and I think many of the plastic surgeons watching this would know what I mean, but essentially you can do aggressive capsulectomy, perhaps an en bloc capsulectomy at the time of removing a breast implant, and for some reason have to go back on that patient weeks, months, years later. And you can actually find, even when there's no breast implant present, that there's this synovial synovial metaplasia, this pseudoepithelial hyperplasia that can develop. And it makes it look as if somebody never performed a capsulectomy, when in fact they did. This is essentially the lining of a seroma cavity. Even sometimes with our best efforts, including imbricating sutures and drains, for example, these types of lined cavities can occur, particularly in radiated patients. So I just wanted to make the point that even when people do everything right, remove the capsule, these types of lined cavities can still develop. Sometimes what can happen is that potentially in the community setting where somebody has not all the resources, that they don't engage a multidisciplinary team. And the answer here is to do so, to refer patients on to a center that potentially does more of these cases, has the resources for imaging, oncology, et cetera, to manage these complex BIA ALCL patients. What do you do about the contralateral breast? So this is one of our cases. She had a stage 3 BIA ALCL diagnosed preoperatively on the left. You can see from her PET CT image that she has a fluid collection. She has this extracapsular area of enhancement. Notably, she doesn't have any fluid or mass at all on the contralateral side. So we went ahead, did an en bloc capsulectomy, resected some additional tissue. Fortunately, we did perform a total capsulectomy implant removal on the contralateral right side. And this patient had occult stage 1 BIA ALCL confined to the capsule on the right side. So even though we imaged her, we didn't see a mass, we didn't see a fluid collection, this patient was noted to have contralateral disease. So we certainly would advocate for bilateral management of patients if they have bilateral implants, even if the diagnosis is just made on the ipsilateral side. It's also important to recognize that only about 10% of patients with delayed seromas in patients with textured breast implants actually turn out to have BIA ALCL. So I found that this has always been a useful diagram in conceptualizing what to do about late seromas that Dr. Di Napoli, our colleague in Italy, has previously published. Certainly in patients with atypical cells, where more than 10% of them are CD30 positive, a BIA ALCL diagnosis can be made. However, if fewer than 10% of the cells are CD30 positive, but there are some such cells, one may consider incipient BIA ALCL or perhaps some other non-BIA ALCL related malignancy. In the absence of atypical cells, depending on the percentage of neutrophils, some sort of an inflammatory response, whether that be acute or chronic, may be considered. It's always important not to miss the forest for the trees when managing the swollen breast, since only 10% of these delayed seromas are in fact BIA ALCL, and given the fact that a breast can be swollen for many other reasons beyond that. Don't forget about things like the double capsule, breast cancer, congestive heart failure in an elderly patient can present with a swollen breast as well. And of course, the dreaded breast implant associated squamous cell carcinoma. Oftentimes, a swollen breast implant, of course, people are thinking a BIA ALCL. However, if this workup comes back negative, they have a PET CT with this very aggressive appearance, you need to start considering things such as breast implant associated squamous cell carcinomas, which are extremely morbid with a mortality rate of over 50%, or other types of lymphomas, including these B-cell lymphomas, also developing often in patients with textured implants, often developing with seromas. However, in patients who have different markers. I should also point out that the link between texturing has been made for BIA ALCL, but has not been made at this point for B-cell lymphomas and for squamous cell carcinomas, just for the T-cell lymphomas. Thank you very much for listening to my presentation. I hope you enjoy the rest of the meeting. Have a great day. Thank you.
Dear patients, I'm Dr. Sorotos. I'm going to speak to you today about Centers of Excellence, accessing knowledgeable and experienced treatment teams. These are my disclosures. Let's define what a Center of Excellence is. Center of Excellence in healthcare refers to a specialized facility or program within healthcare organizations that demonstrate exceptional expertise and capabilities and outcomes in a particular area of medical practice or treatment. These centers are typically distinguished by their focus on a specific specialty or, like in our case, on a specific pathology like BALCL. What are the characteristics of such a Centers of Excellence? It has to be specialized. It has to be a center where the pathology is recognized and treated regularly. It should be expertise by all the team members, and the center must be well prepared in diagnosing and treating patients with such pathology. The facility should be top-notch. We should have, for example, in BALCL, a pathology department that is very well prepared, and a radiology department that is very well prepared. And we should have a multidisciplinary team. We should include all the specialists necessary to deal with such pathology. So, for example, in BALCL, an aware plastic surgeon, oncologist, hematologist, radiologist, and of course, a pathologist that will help us with the diagnosis of the disease. Then the center should be involved in research. This is a very important thing. For example, in pathology such as BALCL, where research is changing the view we have on this pathology yearly, these centers should be involved in research and should be updated with new research. Then outcomes should be offered, and they should be able to be evaluated. Evidence-based practice are very important, and this goes together with research, guidelines that should be followed. And of course, it should be a center that is patient-centered, and this is very, very important for diseases such as BALCL. But now let's see how we can research, how we can find a center of excellence. We can do that by doing a simple search. And we'll see that, for example, if we look for BALCL Centers of Excellence in the US, MD Anderson comes first. We can see that we can find further information, for example, on our website regarding the International Breast Surgery Workshop or the World Consensus Conference on BALCL, where resources can be found. Once we do that, we have to go and look for the credentials of the Center of Excellence. And we can do that by checking, for example, on PubMed. We can see if we go on the advanced query box, we can find that the affiliation MD Anderson and the title and abstract with BALCL will give us all the manuscripts that are published by the MD Anderson on BALCL. We can see that we have 46 manuscripts that are published. And if we check that with the overall production of BALCL in the literature, just by doing a simple search, and this is very, very generic because, for example, initial manuscripts were not referring to BALCL as BALCL. We are able to find, for example, that currently in literature, there are around 420 manuscripts. So 46, 50 out of 420 is a good number to establish that MD Anderson is a great center of excellence. Also, patient advocacy groups are very important. They help a lot with information, with initial support, guiding patients towards centers of excellence. It happens very frequently with BALCL. So it is very important to their role, and they can really be very, very useful in the initial stages of a diagnosis for patients. Now, the next step would be to schedule an initial consultation with the Center of Excellence, and we can discuss with the treatment team, evaluate the expertise, the experience, and the approach of the healthcare providers. It is very important to emphasize the collaboration that there exists should be between the members of the team. So we should be able to see that the plastic surgeon will speak to the oncologist and the radiologist and the pathologist in order to have a multidisciplinary approach to our pathology. This is something that can be done once we visit the center. Now, we've seen what a center of excellence is, how we can define it, characterize it, and look for it. Let's see why it is important. And I will do that by presenting some cases we have to deal with in the past. So this is a very standard case of BALCL, a woman that came to us in June 2019. It was a woman with 76 years old with a history of radical mastectomy, expander implant reconstruction with a textured implant 15 years before, the standard case. She came to our center for recurrent seromas. As you can see, her right breast is swollen. We did a classical approach, fine needle aspiration, cytology analysis, and we always do a microbial culture in order to exclude an infection. We found that she had BALCL, so it was a classic case of BALCL. So we went on to do a pre-op